Hello, I'd like to welcome you to the Research and Education Foundation 21st Conference. I'm really excited to be here. It's the first time that we have done this virtually, so please bear with us through any technical hitches, but we're well practiced, so I hope there won't be any. The focus of this conference is the challenges and experiences and learning that we've had up till now through COVID, and also a focus on what's going to happen going forward. We've been, I'm first going to thank the sponsors of the conference and then tell you about the technical detail. So I'd like to really thank the sponsors who've made this possible. That's Neil Med, Alk Albello, Sword Medical, Ambi, GSK, Kingsbridge, Pfizer, Irish Hospital Supplies, Gemini Surgical, Apex and Lundex. So thank you all for doing that. These sponsors have come on board, but they've had no influence in what our material is for this research conference. Our research conference is really based on what we've learned about COVID and how we can utilise it practically and how we've utilised it practically. We're going to have a number of speakers today who are all of great quality. We want this to be an interactive session, so we'd be grateful if you could link into Messenger and do send us comments because it really adds to the conference. After each session, after each speaker, there will be questions, and we are going to get those questions off Messenger. Your questions won't necessarily be shown publicly, so you needn't worry that your name will be shown. But so if you could put your name and your maybe where you're associated to, that would be added interest. But you're not obliged. We'd also love to hear what you think of the conference, so if you have any comments, please do put them in the message box and we will put them onto the feed so that people can see how you're finding the conference and hopefully enjoying it. So to the technical detail of the day, we have Messenger, as I say. We're then going to have speakers and the question sessions. The speakers are all live, so that will add to a little bit of precariousness, but it also adds to interest because we'll be responding to you. During the breaks, we've got a coffee break and a lunchtime break, we will be showing the posters that people have submitted because this conference is all about promoting research. And it's using this research that we've been able to respond so fast to such things as COVID, but using an evidence base. So the posters will be up during the breaks. You may not get as much time as you usually would to peruse the posters, so be aware that there'll be a link to the posters on the Research and Education Foundation website that you can go to and look at afterwards. The other thing of note is that if you do have to step out of the conference to do, for example, your daily work, clinical duties, then be aware that this conference will be recorded and that you will find a link on the REF website so that you can watch the bits that you miss in the future. So I think at this point, I will hand over to Pat, who is the chairman of the Education Foundation, and he will introduce and open the conference and also present the grants that have been awarded this year to research going forward, the seed grants for research going forward into 2021. So welcome and thank you for coming.
Good morning. On behalf of the board of the Research and Education Foundation based at Sligo University Hospital, I'm very pleased to welcome you to our 21st Annual Research Day. The topic for this year's conference was self-selecting. It's dominating the news. Listening to the radio this morning from 7 to 8, there's almost nothing else except COVID. And I never realised that if the pubs don't open, we're all going to have nervous breakdowns, but that's beside the point. It was self-selecting, but we also decided with the support of one of our collaborative partners, the Institute of Technology Sligo, that we'd present a conference remotely on the virtual platform. This, of course, has enabled us to reach a much wider audience. And to someone of my vintage, this is an extraordinary facility. Normally, we held a conference in the hospital in a room holding 60 to 80 people, not exactly without discomfort. Now we have speakers from all over Europe, all over Ireland, and even further afield. Our audience is large and also spanning Europe. but let's not lose the run of ourselves. I live about 10 miles from Sligo, and I have difficulty getting a mobile phone signal out there. So in the background, you've heard Anna, she's chairing the conference. Brian Murphy will be filtering and feeding your questions to her. Anita Patel and John Williams are directing speakers in the facility here, and Brendan Hurley is conducting the whole orchestra in the background. So to go back to the conference itself, we're very fortunate indeed with our team of speakers. And let me add that we had not one single refusal from all the speakers we asked to present the paper. Now, Anita Patel, our executive officer, is very persuasive, and I'm sure this helped. And Anita, can I use the circumstances to thank you for your sterling contribution in organising this conference and making it a success. But back to the quality of the speakers. This has attracted an audience of more than 1,000 people. Well, that's from yesterday afternoon. I'm sure it's grown since. And the vast majority of these are healthcare staff engaged in community work in health, research and education, or with healthcare industries. And we designed it that way. We focused our invitations on this section, and the papers reflect that. So what does the Research and Education Foundation do? We're an independent company, limited by guarantee, and we're a registered charity. We were established in 1991 to support research, education and training at what was then Sligo General Hospital and in its catchment. The members of the board of the foundation are engaged on an entirely voluntary basis and include members of the Sligo University Hospital and its community, as well as representatives of third-level institutions and health-based businesses. And I would like to take this opportunity to thank the board and to thank the research committee for their commitment and hard work to put in over the last year. And as I'm wearing my thank you hat at the moment, I'd also like to record special appreciation for the support we continue to receive from Gráinne McCann, the General Manager at SUH, and from CELTA with respect to pilot research structures. So going back to the foundation, our biggest challenge now is achieving funding support. We receive no departmental or government funding. Consultant staff at the hospital are generous in their support. We fundraise, of course, it's essential, but it absorbs a lot of our time and a lot of our energy. This is time and energy we should be putting into enhancing our community activities. So we're now looking at attracting an organisation or a group who will provide some medium-term modest financial support to the foundation within a collaborative structure. So introductions over. I'd now like to see who has been awarded research seed grants for 2020. And you'll see now that the first was awarded to Helen O'Connor, who is based in the laboratory with her title, Optimization of Laboratory Workflow using the Molecular Eplex GenMark Diagnostic System for Rapid Detection of Sepsis, enabling better antimicrobial stewardship. Well done, Helen. I might mention at this stage, normally you'd need a PhD in Latin to read out some of the titles, and I seem to be able to do all of the ones this year. The second seed grant is going to Ina Jordan, who's in the psychiatry section. Lovely title, Never Too Early to Start Reflecting. The third one is a Hilary Cullinan in physiotherapy. Can a progressive resistance training program improve sarcopenia markers in a rehabilitation setting compared to standard physiotherapy care alone? The fourth grant is going to Margaret Given, who's in the nursing. Distraction of the perioperative nurse in the operating room. Great title. The final two seed grants are awarded to people in the ENT section. Mel Corbett for age-related changes in the middle ear, and Tommy Crotty, whose submission was on So congratulations to these people, and we look forward to getting reports on how their projects are progressing. So now I'll hand you back to Anna.
Oh, I do apologise. First technical difficulty, I left my mic on mute. So welcome back. And as you will notice, there will be a slight gap between the speaker and then coming back to myself and then returning to the speaker. And that is because we're in two different rooms for social distancing. We are now going to move towards the first speaker, whose name is Laura Keever. She's a lecturer in human nutrition and dietetics in the Institute of Technology in Sligo, and she's presenting her own research. Laura's research is into nutrition in the oncology setting, which I think is a fascinating topic and something we need to explore in the future. I suspect over these lockdown times, we've all had more interest in what we're eating and how it affects us. So I think this will tie in well with that also. So I look forward to listening to Laura's lecture or talk, and I hand over to her now. Thank you.
Thank you very much. Thank you very much, Anita. So I'm going to be talking about nutrition in the oncology setting. This is a combination of two abstracts that have been put together. So excuse me while I speed talk through them. This work would have been done as a collaboration between IT Sligo and SUH, but also Ulster University, Letterkenny Hospital and Cavan Monaghan Hospital as well. So cancer treatment can have a detrimental impact on dietary intake, and particularly we see side effects such as nutrition impact symptoms. So things like loss of appetite, dry or sore mouth, nausea, vomiting, and these can persist throughout and beyond treatment as well. And so nutrition support is really, really pivotal. And we do see, however, in an Irish setting that more than 70% of cancer patients are reporting that they've never received nutrition advice from their providers, and that we know that their main interest in getting that advice is actually from the oncology team. And so the first study that I'm going to present today is looking at what is going on in the northwest of the country in that regard in terms of providing nutrition advice in the oncology setting. And so we recruited individuals from across 3 hospitals in the northwest, and we used a previously developed questionnaire by the National Institute for Health Research. And this really looked at what was going on currently in terms of screening practice, in terms of provision of advice, but also looked at training needs. The majority of this would have been analysed with SPSS, but we did have one open-ended question that underwent thematic analysis as well. So we had 51 individuals who completed this particular survey, the majority of which were nurses working in general oncology, and pretty much all of our cohort believed that nutrition was very important or of critical importance in the management of cancer. When we move then to looking at what is currently going on in terms of screening for nutrition status, the majority of individuals reported screening inpatient, so 74.5%, with the main tool being used being the MUST screening tool. When we move then to an outpatient setting, however, we see a much lower prevalence, so 43.1%. The majority of individuals reported routinely giving nutrition advice to individuals within their care as to how to manage their nutritional problems. And about half of those reported they also referred on for dietetic advice. We did have less than 1 in 5, however, who reported collecting data on the nutritional status of cancer patients in their care. And less than 1 in 5 doctors and nurses reported that they were confident in assessing nutrition status as well. So this graph here really represents the nutrition impact symptoms that healthcare professionals report patients in their care experiencing. So appetite loss, weight loss, nausea, vomiting and fatigue are the main ones to focus in on. But also about 50% of the cohort reported they didn't know what to eat, and about 1 in 5 had reported that they had got conflicting nutrition advice as well. We can see a difference in terms of awareness of nutrition guidelines between dietitians and doctors and nurses, but the majority of the cohort were interested in further training, and they preferred that delivery to actually be a conference or a study day as well. This slide represents the results then of our thematic analysis. So we had three main themes that came through. The first one was an awareness of the need for different interventions and advice depending on cancer type and stage. The second was the importance of early integration, or intervention, and integration into current practice. And the last one then was a lack of resources, so a lack of dietetic resources within the particular setting. So I suppose to wrap up the first study, we had a very small proportion that reported screening outpatients. This may potentially reflect a situation where they're not working in the outpatient setting, but also might reflect a situation whereby once someone is no longer in acute care, the perceived need for nutrition screening might reduce. And therefore, we're depriving a cohort of individuals who do require nutrition support of that particular guidance. The majority reported giving nutrition advice to their patients, which is actually differing from current Irish data where we see about 1 in 3 individuals with cancer reporting that they're getting advice or guidance. I think it would be interesting to explore this further and to maybe see, we didn't really do a comprehensive assessment of the type of nutrition advice being given, how many consults, if there were supports provided, if there was follow-up, for instance. And also something that was highlighted was that lack of resources. And we see that at a national level. There are 7 oncology dietitians and only 2 of those are outside of Dublin. So you're looking at roughly 1 oncology dietitian for 4,500 patients, and that doesn't take into account the growing body of cancer survivors either. So kind of more important work to be done in this area. The second study then was where we wanted to actually look at, can we create a typology of cancer survivor based on the nutrition impact symptoms that they experience? And so we recruited from Sligo University Hospital right up until the pandemic, essentially, and individuals completed a series of questionnaires. So we had some demographics, we got individuals to complete the patient-generated subjective global assessment form, which is an assessment of malnutrition, but also contains a list of 13 nutrition impact symptoms. And we also then had them complete the EORTC, which is a quality of life questionnaire that's validated for use in oncology. And what we did with this data was we performed a latent class analysis, which is really a person-centred statistical approach. And we did that using M+. We used it to identify subgroups based on the 13 nutrition impact symptoms that we identified. So the majority of our cohort were female. They had a mean age of 63.5, and the majority were diagnosed less than 5 years and currently receiving treatment. So when we looked then at our latent class analysis, there were 3 distinct groups that we identified. 11% of our cohort could be identified as a high symptom burden group. So they experienced a high prevalence for the majority of nutrition impact symptoms that we looked at. The second group was our fatigue group, and this represented 29.6% of the cohort. And this group had a high prevalence of fatigue, but a low prevalence of the other nutrition impact symptoms. And finally, the third group that we identified was that low symptom burden group, so about 59.4% of the cohort. And we can see there's a low rate of prevalence for all of the 13 nutrition impact symptoms here. So what we wanted to do then was to see if we could identify who ends up in each of these particular groups. So when we look at our first group, our high symptom burden, our 11% of our cohort, we found that these were more likely to be female, to not be working, and to have consumed less food in the last month, so to have a reduction in appetite and food intake compared to those in the low symptom burden group. When we then looked at our fatigue group to try and identify who's more likely to end up in that particular group, we found that they were more likely to be undergoing treatment, in particular chemotherapy, and also to have been diagnosed more recently than those in the low symptom burden group as well. And finally, we looked at quality of life, and we found that they were significantly different between all 3 nutrition impact symptom classes that we identified. And we did this for global health status, which you can see on the left-hand side, and also for 5 different functioning scales. And we can see significant differences across the board, where those who are in the high symptom burden group report the lowest levels right across, and those who are in the low symptom burden group report the highest levels right across all measures of quality of life. So the identification of these 3 symptom groups, we're hoping it will help clinicians to differentiate patients based on their level of nutritional risk, but it could also help to translate into greater accuracy when we're determining the best treatment or management plan for our patients. It allows for interventions to be tailored to the needs of each group, and it would allow us to see if we intervene on one symptom, can we actually help or improve another symptom within that cluster as well. So future research then, it will be interesting maybe to look longitudinally at this cohort to really determine any changes in membership. So when do people move from that high symptom burden group to either a fatigue or a low symptom burden group as well? And all of this can help to change or improve how we manage practice as well. So I'd like to thank all individuals who took part, all of the healthcare professionals who undertook our questionnaires, all of those with cancer who spent a lot of time completing our questionnaires, our surveys, undertaking different measurements for us, and all of the hospital and academic staff as well, because without everyone here, I definitely wouldn't be here today, and this research wouldn't have been possible as well. So thank you very much. Both of these studies have posters up in the hospital, because I know I've kind of sped through them quite quickly, but if anyone has any questions, I'm happy to take them.
Thank you, Laura, for your talk there. It was really interesting. I was just wondering, you talk about fatigue being a nutritional consequence linked with oncology and sort of treatment for your cancer. How I would be used to thinking the fatigue is a consequence of the chemo itself, so the fatigue of illness and the fatigue of a drug taking effect on your body. How does the nutrition affect that aspect of that symptom?
So you're right, that's absolutely where the fatigue is generating from. So when I'm talking about the nutrition impact symptoms, then it's the impact that those symptoms can have. So if we think about someone who has fatigue, they might now have issues in terms of shopping for food, of preparing food, of ensuring that they have a nutritionally replete diet. So it's kind of the impact on the nutrition status of that particular symptom.
Thank you very much, that's interesting. And just going to look at our questions. There's a question about the nutrition advice from the nurses versus what the carers perceive. I know that you're saying that you're planning to do further research to try and look at where the difference lies, but the question is why at this point do you have any sort of ideas as why the cancer patients might perceive getting a different level of nutritional advice than the nurses appear to be giving?
Yeah, I definitely think, because we discussed this even as a group, and we were thinking maybe because we didn't include that really kind of comprehensive assessment, that sometimes, you know, there's so much going on in all of these consultations and so many different things that clinicians and nurses and doctors have to be aware of, and that the patient is trying to take in as well. And so it could be a case whereby, you know, it's being brought up briefly, but maybe because there isn't a real specific emphasis on it, for instance, that, you know, it's being perceived differently on both sides. So maybe, you know, they mentioned that they're experiencing fatigue or appetite loss, and it's maybe briefly addressed, but maybe the patient feels that actually because it was part of a whole host of other advice that they were getting, maybe it's just not being picked up in exactly the same way. Because we saw recently, about a year ago, the Irish Cancer Society, who quite often host patient-centred conferences, they would have come up with similar statistics where about 1 in 3 were saying that they weren't getting advice. And I think as well it can be quite confusing for individuals. You know, there's a whole host of information. And also it's probably the one thing that they themselves can control. But that was maybe what we were thinking might be going on. But it definitely would be really interesting to try and delve a little bit further into that.
Yeah, very interesting answer. Interesting. And I guess patients are getting a whole host of information at the same time. So it may be that they retain certain aspects of information and then subsequently forget that the bit that might seem less important to them at that time. Especially, you know, even as staff, we probably place most emphasis on the details around the medicines and possibly as an add-on do the nutritional side. So it's good to have that focus. We have a question in from the Sligo IT department from Margaret. She says that it was a really interesting talk, well done, and she's really enjoyed it. But she was interested to know what quality of life scales you used. She didn't quite hear that.
Yeah, of course. It was the EORTC QLQC30. So it's a quality of life questionnaire that's validated for the oncology setting, and it collects data on a global health status, on 5 functioning scales, and then on 8 nutrition symptom scales as well. So we focus specifically on that global health status and the 5 functioning scales.
Thank you. Can I ask, the oncology, the nutritional aspect, we see that you're looking at patients who are having treatment with the chemotherapy and the radiotherapy. You're looking at those patients, and then the survivorship patients. Does the nutritional intake alter the outcomes from the treatment they receive?
So there actually isn't probably a lot of information on that. What we do know is that individuals, as soon as they're getting cancer diagnosis, they can quite often disproportionately lose, say, muscle mass compared to fat mass, and that can alter their ability to tolerate treatment and the toxicity of treatment. And a lot of the time we can see nutritional status kind of decreasing over time as individuals are receiving treatment. Whether or not in terms of specific nutrients have an impact on treatment, we don't really have evidence or much research done on that. But what we do know is that individuals who have a good nutrition status, who are at a lower risk of malnutrition and who maintain their muscle mass respond much better to treatment. They tend to have a lesser amount of toxicity, they tend to have a better quality of life and to have less detrimental effects of treatment as well.
Thank you. Yes, that makes sense in terms of if your body's in a good position, it's going to respond better to the challenges that are thrown against it. Looking at the questions here, there's another one with regards to nutrition and hospitalisation. In terms of this research, is there any research being done, and it doesn't relate directly to your talk, but it relates to the topic. Has there been research done on nutrition in hospital? Because I presume that would both affect what patients' perceptions about nutrition are, as well as an education role. So has there been research or activity taken on looking at how people are fed in hospital when receiving their oncological treatments?
Yeah, so not a huge amount in terms of maybe what they're consuming while they're in the hospital, but there has been a lot of research right across different patient groups that look at the fact that once someone is hospitalised, their risk of malnutrition increases quite largely for a whole host of reasons. It can be side effects of condition, the fact that when you're quite sick, you don't feel like eating anyway, regardless of what food is put in front of you. In terms of actually assessing nutrition that is provided within a hospital setting, kind of, I suppose, different studies I'd be aware of are more audits that are done within hospitals individually, rather than maybe very large scale studies that look exactly at how much nutrition is being provided, for instance. And I think some of the reasoning for that is the fact that depending on the patient group you're looking at, the nutrition requirements will be quite different, and that in some cases those requirements aren't reflective of what we would be looking at for a general population, for instance. So it is quite specific in that regard, but definitely within a hospital setting there tends to be a lot of auditing work and quality assurance and practice and I suppose changing things in that regard. So that definitely does go on at more of a local level, even if we don't have very large scale studies that are they're looking specifically, probably because of a lot of the limitations that could be involved in that as well.
Thank you very much. That's interesting. I'm just checking to see if we have any further questions online.
Yeah, no worries.
Okay. At the moment, I think that's the questions that we have. Thank you so much for a very interesting talk, and we really appreciate your bringing it to us in this environment. Thank you.
No problem at all. Thank you.
And we're just going to wait we have to swap over presenters in the room. So our next presenter will be a gentleman called Dr. Imran Ali. And Imran Ali is going to talk to us about Treatment to Target programme. This is work that he's been exploring, and he will be able to tell us much more about it. I explored it on the net last night, and I look forward to getting insights from him because I know there's a lot I have to learn. So when we have swapped desks and he's got his presentation up, we'll swap over to him. But I'm sure it will be as interesting as Laura Keaveney's talk was just then. Thank you very much. So I'm going to hand over to Dr. Imran Ali.
Thank you so much. My name is Imran and I'm the Rheumatology SPR. Thank you so much for listening and attending this conference. Well, I know everybody's talking about the COVID, but I know it was, in rheumatology, we were doing research about the Treat to Target program. And this is the gold standard actually in treating the rheumatoid arthritis itself. So the outline is just to talk quickly about Treat to Target. What is this program? Then what scores do we use? And about 3 of my studies, and then where are we going forward? So Treat to Target program, it's not new in medicine. It was practiced before, and it was born in rheumatology. It was in diabetes, so the UK PDA study. Then it was in the treatment of the hypertension and hyperlipidemia. In 2010, the International Task Force from EULAR and the ACR came up with the decision to have a program just like the prior ones that I discussed, and treat the rheumatoid arthritis accordingly. There were a good few randomized controlled trials done, like a Cohort study in UK, where 2 NHS hospitals were involved. And apart from them, there was a camera study done in the Netherlands. So 50 rheumatologists around the globe, mainly from Europe, Northern America, Latin America, Australia, and Japan. And also I had 5 rheumatoid arthritis patients in this group. And they came up with the recommendations for treat to target program in rheumatoid arthritis. So talking about it, if a patient is referred to us with active rheumatoid arthritis in our early arthritis cohort, early rheumatoid arthritis patients clinic, we actually sit down with the patient and decide about the treatment target. So the main target always will be remission, but taking on board patients' comorbidities and any previous adverse effects to the therapies prescribed by GP, or so then the alternative target, which is a low disease activity, will be sorted. So the patient actually been started on the treatment. This is always between a mutual decision between a consultant and the patient. We start the DMARDs, follow them every 1 month usually, but if they are stable, it could be up to 3 months. When they achieve remission, they are transferred back to the inflammatory arthritis clinic. We have an advanced nurse practitioner which actually looks after this clinic, and she will not only set the target with the consultant and the patient, but also look after a number of other factors that will help the patient with the functional abilities and to go back to work, and any help in terms of the functionality. So the disease scoring that we use in rheumatoid arthritis mainly are the DAS28, CRP, DAS28 ESR, CDAI, and SDAI. They all have the tender joints count and the swollen joints count. CDAI is a bit different, which actually has, apart from tender joints and the total swollen joints count, we calculate the physician visual assessment scoring, that what do I think, what is the patient's active disease score, and then we have the patient's visual assessment score. And in this the simplified disease activity index, there is an ESR added on to the to these scorings, and they're all used in this treat to target program when we assess the patient, decide about whether the patient is in remission or have they achieved the low disease activity. Other than that, in our study, we also look at the health assessment questionnaire disability index in rheumatoid arthritis, and different categories are assessed in this HAQ-D scoring. That includes dressing and grooming, arising from chair or the bed, eating, walking, do they require any help, the health hygiene, to when they're in the kitchen or in the washroom, how about the reach, the grip of the hands, and common daily life activities to see, do they require help or not? 0 is really the best, like if somebody can do that, and 3 is that if really unable to do any of these activities. The early arthritis cohort in Northwest Rheumatology Unit. So this is the main part of my talk today. We have a total number of 517 inflammatory arthritis patients that actually both rheumatoid and psoriatic arthritis. Among them, 61.5% are female, and the mean age is around 53.98 with a standard deviation of 14. We use methotrexate as a first-line DMARD if there is no contraindication. And talking about contraindication, if somebody is, having previous history of liver function derangement, or is there any issues with alcohol, or if the childbearing age, so we need to be careful in that terms, and then we have to opt up for the other DMARDs. The seropositive patients in our cohort is about 60%, and they are both, I'm talking about the IgM rheumatoid factor positive and NTCCP positive. As I mentioned, our advanced nurse practitioner, Noreen Harrington, is involved in this program, and we refer the patients to her on the day when the patient presents to us. She educates the patient about the drug, about the disease, provide all the information, and then follow up accordingly as per the program. Once the target is achieved, we follow them in the clinic. Usually, it depends when the patient is steroids free, and their scoring in terms of the clinical and biological, biochemical, if they are all back into remission, then we will follow them in the clinic. either 6 monthly or annually, depending upon what medications are they on and how are they doing. We use SPSS to analyze all this data. So the study number 1, my first question for the study was that whether this effectiveness of treat to target model we have from the EULAR. In our early arthritis cohort patient, are we achieving the remission as per the other countries? So I looked at the TICARA and the CAMERA study and looked then at our data from the early arthritis cohort. We found that the CDAI scoring for the rheumatoid arthritis at baseline when the patient came was 22.65. Now, talking about that is that anything more than 22 is severe disease. The standard deviation was about 20, which was, some people were with severe rheumatoid arthritis, and a few of them were like in low disease activity scoring. Again, the HAG-D scoring was about 1.19, which wasn't too bad of presentation. The results, what we found that the remission in less than 40 years of age, they all, went into remission 100%. And this more than 40 years of age, around 49%. So the p-value here was less than 0.01, which is really, the same that we found in the other studies. Dominant demand, again, as I mentioned earlier, we use methotrexate in more than 50% of the cases, and 1/4 of the patients were escalated to the biologics, and they include mainly anti-TNF agents, and a few of them are on the JAK inhibitors. In the end, what we found that 66% of our total cohort achieved remission, and the remaining around 33.9% went into low disease activity. There were very few, actually. We were still with the advanced nurse practitioner, but it was always with the help of the consultant. We look after their treatment, but this is a good outcome. 66% is no different than what the previous studies in Europe are having their results. The second question, my next abstract was the questioning the clinical disease activity index as a measure of disease activity itself in the treat to target program. Why did I choose this question? Because the remission rate what we were getting in these patients were not really, the optimal one. Whether there was an issue with the CDAI itself, or if we calculated with the other disease activity scoring. So what we found here that the erosions on X-rays at the time of the diagnosis when they were referred to us. Erosion X-rays, the hands and feet I'm talking about, male were having more erosions than the female. That is 38% of the male had erosions and 50% of the female as compared to that. Remission with the monotherapy and the combination DMARDs were around 60%, and in the biologic and JAK inhibitor group was around only 41.7%. So in the biologic group, it's less than 50%, so probably when I was going through all these data with my bosses and finding out what could be the possible cause, and we found that the explanation for this particular results would be that CDAI remission is difficult to achieve in a sense that it has the physician assessment visual assessment score and the patient visual assessment score. And if the patient visual assessment score, let's suppose, is 5 out of 10 or 6 out of 10, even though we would have the tender joints and the swollen joints as a number, still it will come up as a moderate disease activity. As opposed to that, DAS28, where we see the inflammatory markers and the total tender joints and swollen joints with the global assessment scoring is better to achieve, and they were in the remission as per the DAS28 scoring. My next question was whether time to remission differ depending upon the route of administration of methotrexate in early arthritis patients, if we are giving oral methotrexate or subcut methotrexate. The starting dose we used in 88% of our patients was 15 milligram, which is usually the standard. The median time to first increment, that is from 15 milligram to 20 milligram, was around 7 to 8 weeks, and this is what in the other studies, in the European studies as well, it's around 8 weeks. When the 6 to 8 weeks actually is the first increment time. The route of administration, 70% were started on oral methotrexate, and the remaining were 30% were on subcut methotrexate, and it was mainly, due to the many factors, the patient's choice, and the if somebody on polypharmacy, and they wouldn't go for any further 6 tablets in a week, so they actually opted to go for the subcut one. Outcome of this study was that we found no statistical difference in terms of the time to remission, likelihood to achieve remission, or discontinuation of methotrexate between the oral and subcut methotrexate group in our cohort, which the p-value was 0.24. Well, certainly, we found, and another, if you talk about the, if you talk about other studies where the subcut methotrexate has a higher achievement rate, but in our cohort we didn't find anything in particular that there is any difference if we compare both the subcut and oral methotrexate. Where are we going forward from here? So my next target would be to study the CDAI versus DAS28 remission. That why is this not why the patient with CDAI remission is not really we're not achieving the remission with the CDAI, and we are achieving the remission with the DAS28. So I'm going to look at that quite in detail in the next couple of months and bring it forward to you people as well in the next next conference. Thank you so much. And if you have any questions, I know it wasn't about the COVID, but just to bring to you, and it's something different, Thank you. If there's any question, I'm very happy to take them.
Thank you, Dr. Ali. That was a really interesting talk. And I think one of the things from this conference is that although we're focused on COVID today, it's been quite difficult to get research done and get results within the time frame that the COVID pandemic has been here. So that's the research we're focusing on now, is research that's happened in this region during the last year. And so research like yours is still really, really valuable, because as we know, all these other illnesses are continuing to occur, and we need ongoing research in all aspects of healthcare. So your talk is really relevant and really important. Just for my clarity, how many patients were in the cohorts that you looked at? How many patients were in your study?
So 517 patients are total number of patients at present. We have, at the time of the study when I was doing it, it was around 430 patients, and among them the patients who qualified the criteria. So now there are 3 different actually studies. A few of them were, one of them was entirely rheumatoid arthritis one, which we took out the psoriatic ones, and the other one was the inflammatory arthritis one to have a look. So yes, at that time around 339 patients in one study, around 200 or something in the second study. But yes, we had 400 plus patients when I started the study.
Excellent. Those are quite good numbers of patients. That makes the study's power much more significant. Another question that's come in is, were you able to compare, from what we can gather, you used the treatment to target regime. Were you able to compare patients who were using a target to treatment regime versus those who weren't, or were you just looking at a cohort who all had that strategy applied?
So that's a very wonderful question, actually. So no, we haven't compared the standard patients who were treated with the standard therapy or the conventional, just usual therapy, as compared to the treated target program. There were a lot of studies done on this before the treated target program, came up in 2010, and they found in there that this is one of the gold standard for the treatment. So we just looked at our early arthritis cohort patient in the treat to target program.
Thank you very much. And we've had a question in: does the treat to target regime or protocol, does it alter in those discussions with the patients about the outcomes? does it alter what medicine you might choose to use for the patient?
Well, that's a great question again. So I'll comment here that when we enroll somebody in the Treat to Target program, this is a mutual decision between the treating physician and the patient, and we suggest that this will be the right drug for you. But again, this is a mutual decision about the doses, about the medications, and we update them every month to 6 weeks when they have a follow-up appointment. I understand due to COVID, this is not possible face-to-face, but our advanced nurse practitioner or in Harrington does that on telephone. And if they need to be seen face-to-face, we bring them to the clinic.
Thank you very much. That's very helpful. We've had a question from in online that asks us, thinking about both talks that we've heard this morning, have you noticed throughout your research, or would you have any information about the correlation between diet and arthritis?
That's a great question. I've actually read about it before, and I had a presentation about diet in these scleroderma patients, but the diet and the early arthritis patients, usually we have parameters noted in our data. We have the data on the ESE, and this is a nice boost for me to look at that one in the next study. But overall, reading about that as part of my training, I've seen that there is a lot of things on from people that the fried food and a lot of meat shouldn't be consumed in order to keep the disease in remission, and few of the recommendations were like to have the keto diet. But truly saying, I do not see any recommendation coming from the authorities like a EULAR or American College of Rheumatology or the British Society of Rheumatology. Nothing in particular that I know of. I've gone through a few papers, but I didn't see anything in particular. But yes, I will look at it from our cohort, because there are more than 300 parameters that Noreen has gathered, just calculated. So we'll be looking at that as well. Thank you so much for that.
Sorry, yes, I realise. I think sometimes when we are giving a presentation, we have our background medical knowledge, but as you said, you didn't directly look at that in your presentation, and so that's probably not your area of research. But I appreciate your expertise that you bring to the response. We have another question here. Having carried out this research, are there any practical changes you'll make to the way that you provide your rheumatological services or practice going forward? So what's the practical effect of the research so far on your practice?
So the goal actually for this, for the patient that we treat with the Treat to Target program, is to have the patient less symptoms as less as possible, to have their functionality maintained, to decrease the rate of structural damage to the joints, and to avoid any systemic involvement. That means that we look at the disease from day one and we start the treatment. We follow them with regular intervals in order to avoid all these factors that I mentioned. This is how I see that, as far as before the Treat to Target program, things were different and patients were going into the structural damage with typical rheumatoid arthritis deformities, and they were not able to do work, or they were finding very much difficulty in the daily life activities. In terms of the practice, it has made a significant difference, and I actually take this as a gold standard treatment, and this is what it's practicing around the globe as well. So yeah, it has made a significant change, and I think it's not only our setup; it's actually practiced around the globe. So yeah.
Brilliant, thank you. That's really interesting. I think it's so important that we can take what we research and actually apply it to our clinical practice. And both of the pieces of research that we've heard this morning, yours and Laura Keaveney's, are actually practically looking at what we do on the ground. And I think it's so important that we can make that step from one to the other. I just want to alert you while you're on that we've had some very positive comments on your talk. Very interesting, excellent review. Thank you very much. So these comments are coming in through the internet, just to note. So thank you very much for your presentation. Very much.
Thank you so much, everybody, for listening. Thank you so much.
And now we are going to move to so we really appreciate the talks that we've just had. I think it's really important that we showcase the research that is going on, and it's really one of the functions of the Research and Education Foundation is to support research that's happening in Sligo University and to grow that research so that we can share it between in industry and in the IT and across Ireland. We're really attempting to grow connections, because if we can advance research in our settings, we create new doctors and scientists that are going to add to research in the future, which will really benefit medicine here in Ireland, but also nationally and internationally. And never more have we seen how important it is to have these researchers up and going, working on different aspects of our healthcare. So we are now going to move our focus of the conference towards COVID and the challenges and learning we have experienced in the last number of months. We're going to open this section of the conference with a talk by Dr. Anthony Breslin. He is the Public Health Director for the Northeast. Sorry if I just shuffle my papers here. He was the Vice President of the Irish Medical Association, and due to his due to the nature of the COVID crisis and his role that post in order to focus more closely on his activities in managing COVID in our region. So we really look forward to hearing from Dr. Breslin about his insights and his learnings and how he has been aiding and applying the public health policies to our region. So we move now to Dr. Anthony Breslin. Thank you.
Thank you very much. I hope you can hear me. If you can someone wave, please. Because I can't hear myself, and thank you for the invitation and Peter Wright for facilitating this. So what I'm going to do, I hope, is go through very quickly some of the major issues that have occurred, sort of both nationally and locally, and some sort of learning points we have during the COVID. And I'm just trying to get my slides now to behave themselves. Okay, so very quickly, we know it all started off in China, much to Donald Trump's amusement. We know then it spread to Italy, and I think a lot of us have seen the film that happened in northern Italy of the military trucks transporting bodies when they had a phenomenally high number of deaths, and it's an amazing number of people who I've met who've brought that up in conversation. Afterwards, then it started in Ireland, mainly through ski trips and travel from the EU and the UK. And I was amazed how many school trips there were in skiing at that time. I knew there was TY breaks and everything else, but I never realized how many people went skiing. So busy slide this, but where we were trying to decide what we were dealing with. We were aware of reports coming from China at the end of December that something unusual was happening, and we were keeping our fingers crossed it was die out, but it didn't. So we're trying to see what we're dealing with. It is a very infectious virus, not as infectious as measles, but very infectious. One advantage, if you could call it that, is that it's spread by droplet, and therefore simple measures such as surgical masks, face coverings, distancing, etc., could be protective. But of course, when you have something new that's happening very quickly, it can be very difficult to get that knowledge out, and that was one of our problems. And then, not just in Ireland, but throughout the world, there was a phenomenal lack of access to PPE, mainly due to the position of just-in-time delivery that had been in place, not just for industry, but also for the healthcare sector, that you don't have vast warehouses with stock. and that did cause a problem. And I think we can see that particularly in residential care facilities and nursing homes, that at the moment, touch wood, we are really keeping those premises safe and those residents safe, because we have PPE, we have the knowledge of infection control procedures in there, whereas back in February, March, the knowledge was scanty and trying to get PPE was very difficult. When this kicked off, then there was phenomenal panic, and we had a big issue in most public health departments around the country, including our own here in the Northwest, that no one was answering phones, and for instance GPs were not answering phones, or if COVID was mentioned they were hanging up. And we have boxes of files with phone requests coming in from members of the public about this, that and the other. And ironically then, GPs were trying to get information from public health, and because public health departments around the country were inundated with calls, somehow our out of hours number went around in WhatsApp groups, and we were getting calls from Dublin and Cork, etc., etc. So it's a very difficult situation. Locally, we did provide an out of hours service, but we had to go to a sort of a full tier service, 24/7. And when we started off, well, 3 years ago we had 5 specialists in the department. Then, because of people retiring and moving to other positions, we ended up with 2 specialists. We were later joined by a retired individual who thankfully came back and helped us out, and then another retired individual came back and helped us out. But we still end up a sort of very tight on-call situation. And as I said, the highest hit rate in the Northwest and a lot of locations was in residential care facilities. And as I've said, we currently, apart from the odd occasion around the country, we don't have a big problem in residential care situation. And obviously, in part of trying to manage the situation was, as well as doing the work, it was a phenomenal number of continuous meetings, because the advice was changing every day. It was certainly a state of flux that just kept on changing and changing, and that's very difficult for staff to deal with, because what you were certain of is what was a contact, and the advice today changed tomorrow and would change again the next day, and that was very, very difficult. But I will say that we were very lucky in most public health departments that our colleagues in the community health organisations did give us additional staff to help out, and the laboratories in hospitals such as Letterkenny and Sligo were phenomenally helpful as well, because trying to decide who to test, when to test, and then the numbers increased. That was all a big challenge to the whole healthcare system. Just a quick graph here of our notifications. As you can see, started off back in March, died off then, pardon these words, decreased then substantially in May, and then came back towards the end of August. We thought we might get a bit of delay until September when the schools opened and people were more active, but it happened a bit quicker. As you can see, the numbers overall in the autumn were much higher than in the spring. And you can see that the numbers of notifications did vary by county, not just in terms of the population, not just in terms of the normal variation you expect in terms of the different populations in the county, but Donegal just did continue to have a higher rate of infection. You can see by the blue there. Sligo did jump up and down, mainly due to outbreaks, and Leitrim, apart from one or two small outbreaks, was at a lower rate of infection, and that continued all throughout since March. In terms of our local numbers, again, you can see the numbers here, that almost 3,000 in Donegal, just under 260 in Leitrim, and 700 in Sligo. Almost 4,000 cases altogether. And as you know, that sort of it's sort of 20% serious infection, 10% admitted to hospital, 1% to ICU, and a death rate then of sort of 2%. And it's interesting to note that although the elderly and those with underlying conditions are more susceptible to the infection and unfortunately die more, as I'll show shortly, the infection does hit people of all ages. And I can just show you here very quickly, with 68 deaths so far, unfortunately, in the Northwest. And then you can see here age groups that 11% are under 14, 3/4 between the ages of 15 to 64, and 13% over the age of 65. But obviously, the over 65 more hospital and admissions. So the infection does hit all age groups. And as I keep on saying, when it hits you, you don't know, are you going to get a mild infection? You get no infection, a mild infection, get a very, very bad flu-like illness and be in hospital, be in your bed for a number of weeks, because it is more severe than the normal flu, more aches and pains, coughing, etc., phenomenal fatigue, and then we don't know who's going to end up in hospital or who's going to unfortunately die. And just in terms of gender, sort of 50-50 split. And where the patients are arising from, well, where they were diagnosed, majority of them from general practice, small number hospital inpatients, just under 10%, but the vast majority identified in the community. And in terms of the source of infection, over 55% were the result of close contact of a confirmed case, and 15% were acquired in a healthcare setting. 20% due to community transmission. In other words, they picked it up from someone who wasn't a close contact but in the community, and small number of travel related as well, even though that did take up a big piece of work initially when there was travel, international travel was happening, and that's workloads begin to pick up again as travel increases. Here's a map of over the last couple of weeks of where the cases have been occurring throughout the country, and you can see the preponderance of red and yellow dots along the population centres: Dublin, Cork, Limerick, Letterkenny. But you can also see that in Donegal they are spread out throughout Donegal, and they are spread around the border areas, and I'll come back to that in a moment. And then this is sort of a heat map of areas where over the last number of weeks infection rates have gone up by the red and the dark red, and also the rate per 100,000. You see again, Donegal is fairly hit compared to other parts of the country. And then, sorry, this is the one I was mentioning, where the rates have changed, and the red is where rates have increased. The pale white yellow is where nothing has happened, a rate is staying stable, and then the blue is where rates have decreased. And as you can see, very much a different picture, a varied picture throughout the country. These are based on primary care teams areas, so there's the sub-county level. And you can see that a lot of variation within neighbouring areas. If you look at Donegal, we have red areas beside white areas beside blue areas. So it's very difficult to get an overall picture of what's happening. In terms of contact tracing, what we have seen is that when we identify a close contact and test them straight away, 12% are positive overall. Of those who are symptomatic, the positivity rate goes up to 25%, and of those who are asymptomatic, it's 10%. And then if the negative people are retested again, only 3% convert to positive. But that rate does vary according to what's out in the community, and you can see that towards the end of November, the positivity rate for the day zero went up to 16%, so it does vary slightly around what's happening in the community, but does show you that obviously if you have symptoms you're more likely to have be positive, but significantly we're getting 10% of those who are asymptomatic who are close contacts also have the virus. In terms of outbreaks, we've had in the country over 840 outbreaks, varying sort of as 3 or 4 cases up to hundreds of cases, and in the northwest we've had 35 of those outbreaks, and the workload behind those is phenomenal in terms of, if you consider that in one outbreak we had in a residential facility, back in March, it got so severe that we actually had to close that building and move the residents into another facility, and that took not just public health and the CHO, but involved the acute hospital helping us as well, and also the ambulance service transporting them, and social care, etc. So phenomenal work behind those numbers. And then coming on to schools, which were a big issue for not just the public and parents and teachers and school staff, but also the government. And I think what this shows is that since the beginning of the school year, we've tested throughout the country over 700 schools. And obviously these repeated schools can be repeat tested. They might have been tested in September and then tested in November, etc., etc. And we have been involved in 46 schools. But what we found is that in schools, the positivity rate when we go in to test people who are query cases of contact in school, in secondary school we only find 2% of the people, students and teachers and staff, positive. In primary schools, it's only 2.1%. Special schools, it goes up to 3.3%, and in preschools or creches, it goes up to 5%, mainly because they're dealing with a very young population, and you can't sort of put them into pods, separate groups. Difficult to wear face masks, etc., and face coverings. But it shows you that the basics, which the schools, the pupils, the teachers, all of the staff have done, bus drivers, everyone have done in terms of social distancing, face covering, and if you're sick, you stay away. That has been phenomenally successful. And as well as doing that, the pupils have gone on to learn, and the staff have gone on to teach, and the bus drivers have transported kids, etc. So if schools can do it, why can't the rest of the community do it? So in terms of the next steps, obviously we have to continue to follow the guidance, and it's interesting to hear Mike Ryan. I know Mike is speaking later on. I heard him on the radio this morning saying that if we get the vaccine, it's not the golden bullet. It's going to take time for a vaccine to be produced. It's going to take time for get it distributed. It's going to take time to get people immunized. We don't know either how many people will actually take up the vaccine. And while all that is happening, we will have to continue to follow the guidance. And we do have to take an evidence-based approach to all that we're doing. What we're doing in terms of guidance is not high-tech, high-spec. It is definitely not rocket science. It's saying maintain a distance between people and wear a face covering if you can't maintain a distance, or if you're in an enclosed situation. And obviously in a healthcare setting, you wear a surgical mask or an FFP3 mask if you're involved in aerosol generating procedure. It is a bit disconcerting that even at this stage, we're having to tell staff in the healthcare sector that 15 people cannot go into a tea room, or that 15 people cannot go into the ward office or the nurse's station, and that if you're walking down a corridor and having coffee after a tea meeting, whatever, you have to maintain your social distance, or you have to wear a face covering. And then as well as that people who are positive cases have to isolate for 10 days, and if you're contact, you have to stay away for at least 14 days. It's still amazing to hear a range of health professionals come out and say, well, it's only 7 days, isn't it? And once I get a not detected test, I can go back to work. Isn't that correct? And even then, trying to get people to understand that a positive test is a positive test, but there's no such thing as a negative test. It's a not detected test, because if you don't detect it on a swab, it means maybe you don't have it, or maybe the swabber didn't do a good job, but that's unlikely now because people are doing it so much, or there just wasn't a virus in the upper respiratory tract. It was too early or it was too late and the virus has gone to the lower respiratory tract. So there's no such thing as a negative test, and that's one of the concerns we have about all this push for testing for flights and for going back to work, etc., etc. Just coming back briefly to the Donegal situation, obviously things were complicated by the fact that Northern Ireland has a much higher rate of infection. If you consider Northern Ireland, they do not test contacts who don't have any symptoms, they only test contacts who are symptomatic. So therefore you could add about 25 to 30% to their reported figures to make them comparable to the figures in the Republic. So if they're saying they have 700 cases a day, you could really say that's 1,000 cases a day. They have half our population, so the rate of infection is phenomenal. We know that for generations and years, forget about the politics, people have crossed back and over the border because it's the hinterlands differ, and that people go to work, they go to their business, they go to shopping, they go to schools on both sides of the border. So there is a lot of cross-border flow, but we have to try and push with the public, etc., that if they go into the north, there's a higher rate of infection there, so they're more likely to meet someone with the virus, and therefore they need to do the social distancing and the face covering. And on the other side, if people from the north do come to Donegal for work, education or business, etc., that they should do the social distancing, face covering, and the people from Donegal who meet them should do the same. And that's a difficult message to get across. We know that doing the basics is a pain, technical phrase there. It is difficult, that we've all been in the situation where we've gone to pay for fuel or gone into a shop and we're at the door and we say, oh dear, or a stronger word, because we've forgotten the mask and we have to go back to the car or wherever, or go and buy a mask there, which is infuriating. We've all done that. Slips happen. They'll always happen, but really, apart from a person who cannot wear a mask for some medical reason or whatever, the people should be wearing face coverings and they should be doing social distancing. It's people who spread the virus, not the air or anything else like that. And in theory, we could put 30,000 people into Croke Park for an All-Ireland final or into the Aviva Stadium for a soccer match, and we could social distance there. The difficulty is getting people in and out of the stadium. The difficulty would be getting people to and from Dublin and travelling, because people will travel in cars. They won't social distance going down Jones's Road, etc., etc. But there's a lot we could do if people would adhere to the basics. We could possibly open businesses. We could possibly open restaurants. Now that's not my decision. I'm not making any comment because that's the government decision, and they act on the advice given to them, and that's their role. I have no problem with that. But obviously pubs are difficult because when people get a few drinks in them, their judgment decreases, etc. So that's a more complicated matter. But there is a lot we could do if people would do the basics in order to allow us to keep the virus spread low, because the analogy I use is on a stairs. People use the stairs every single day of various ages and various abilities, but sometimes you trip. You might just trip and curse yourself and say, I'll catch the banister again. Other times you might fall and you might sprain something, or you might break something, or you might break your neck, or you might have a head injury, or you might die. And that's, we don't know if someone's going to trip on the stairs, what's going to happen to them. The same way we don't know if someone comes in contact with the virus, we don't know what's going to happen to them. And that's why, as well as talking about treatment and the vaccine, let's try and not get the virus in the first place. Because if we don't get the virus, we don't have to do contact tracing, we don't have to put them in the hospital, we don't have to treat them. And the basics, unfortunately, are not glamorous, but they work. Thank you.
Thank you very much, Dr. Breslin. That was a really interesting talk, full of very relevant information. And I think obviously the take-home message is that we need to continue taking all the precautions and social distancing to continue keeping the viral load as low as possible, the sort of viral load in the community as low as possible. So thank you very much for that. We've a question from the floor. You gave data on the schools, primary, secondary and preschool percentage of infection less than 5%. Do you have any corresponding data relating to the third level sector?
We don't particularly, because we're not sort of having, we don't have a specific sort of program to support third level education. They're sort of managed as sort of community outbreaks, but again the rate is very low. We get outbreaks, and for instance we know that Galway has had an issue over the last couple of weeks. Cork had an issue about a month ago. We've had a bit of an issue around Sligo, but about a month ago. But in general, the issues aren't associated with the institutions themselves. They're associated with the student accommodation, etc. And for instance, Galway had an issue post sort of the Halloween parties, etc. that occurred, and they had outbreaks afterwards. So it's just trying to get the message across to students that you don't want them to get sick. You don't. It's not nice for them to be doing a lot of stuff online, and some of them do go in for supervised activity, and that seems to be very well sorted. The main risk for students is in their own accommodation, but apart from the outbreaks, the infection rate seems to be lowish.
Okay, thank you for that. Now, we actually have quite a few questions here, but unfortunately due to time we're going to have to limit it. So I'll perhaps ask 2 more questions and then we may have to end the session, though I suspect we could keep asking questions right through the coffee break. One question that's come in is, distribution pattern in Donegal is very varied. Has cross-border involvement been a definite factor in influencing the infection rates?
Yes, because when we've sort of looked at the rates, we find higher rates of infection around Lisstraban, about around Buncrana, and vice versa on the north. We've got a very good collaboration with our colleagues in the north. They've seen infection around Derry, etc. So we do know they are hotspots, because the very reason that if you're going to go across the border for a pint of milk rather than drive 5 or 6 kilometres in the alternative shop, and you're going to take the shortest route, that happens a lot. If people don't do the basics, you're going to get infection, and we know that. So that's what we've seen, and that's what we try and prevent.
And has there been a cross-border discussion on how to reduce and solve this cross sort of contamination?
Well, on the health side, we have phenomenally regular meetings to deal with incidents and cases, but also look at policy to try and improve this. But obviously, you have 2 different political regimes who have lockdowns at different times, and obviously we're opening up next week. The north are closing down this week. Ourselves, or the Gardaí and the local authorities, etc., have concerns that we might see possibly an influx of people from the north into Donegal, Sligo, Leitrim and Cavan Monaghan over the next couple of weeks while their lockdown is happening. So we're trying to get a message out to people if they are going to come to follow the guidance, and people here who are contact with them to follow the guidance. But it's very, very difficult to stop people, because as I said, the border has been there since 1920, but people have been living in the area for hundreds of years, and whatever they do, they're going to continue doing.
Thank you. I was just interested to note that you were saying the labs have been very, very helpful in terms of knowing who to test and when to test, the local labs. Is it local or national policy that determines who and when people are tested?
Well, because we didn't know who we should test way back initially in February and March, that took it down to discussion of patients, of were the symptoms, had they travelled, etc. We didn't have a lot of reagent in the country. Tests had to be done in the NVRL in Dublin, so they had to be transported. So that was a lot of clinical decision making there. And obviously, as the reagents became available and NVRL could test more, the local labs had to package that. And then at the moment now, it's sort of a split between the local lab testing and NVR testing and other private labs testing like Enver and Kildare. But there's a lot of mechanics around there and trying to get that sorted out and delivered and get the test done very quickly, get the results out. So that's been a big undertaking between ourselves, the CHO who are doing the community testing clinics, and the local labs and the ambulance services as well, then who did the initial testing but are still involved in doing mop-ups of people who can't come to community testing, who are disabled or don't have transport, etc., have to be tested at home. So it's a big organizational exercise in the background.
Okay, so it's really a combination of national policy and also local availability and strategy.
Yeah.
I recognise that we're now hitting the coffee break. What I would suggest is that, would you have time for 2 more questions, Dr. Breslin?
Yes.
Yeah, so those who want to go and get coffee may get coffee. We'll have 2 more questions and then we'll have a break until 11:10. So the next question comes from our audience over the internet. Do we know about the prevalence or severity of disease in normal weight patients versus obese patients?
There is data out there. I couldn't tell you at the top of my head. There is a higher severity of, obviously the infection rate is the same, but in general, but obviously obese patients and physically they can get more illness because of the respiratory compromise they have. I couldn't give you the exact figures, but it is there.
Thank you. And the final question, you noted that 15% of COVID is acquired in health settings. I suppose, what settings are we talking? Hospitals there, and what measures are being taken to reduce that?
Well, that 50% is slightly because people are being diagnosed and they come in sick and they've been diagnosed. It also includes people who pick it up there, unfortunately. We have had the occasional outbreak, but obviously staff should know the basics, that social distancing, a surgical mask as opposed to a face covering, and if they're doing aerosol generating procedure, to use FFP3 mask. Staff know that, but obviously we get situations where you're trying to keep only a set people who need to be in hospital should be in hospital, and then patients who are in hospital should stay to their bed or stay to the room. We know they don't do that, and we have situations where patients who have been positive have roamed the room and the ward, etc., and spread the infection. And we also had situations where staff who've had the infection haven't followed the correct infection control guidance and have infected people. So we're still having to keep on to get the message across that they need to protect themselves, protect their families, and protect the patients they're dealing with by doing the basics in terms of infection control. Yeah. It's not rocket science, as I said, it's basic. It isn't a blood test. People like simple answers. They wanted an app. The app hasn't been fantastic. The app tells you your phone has been in contact with another phone, and that's all it does. But simple high-tech answers don't always work. If a pencil and paper work, use the pencil and paper.
Thank you for that. So I think it's interesting, isn't it? I guess what you're saying is we've got humans involved here, and we need to apply the advice of social distancing, mask wearing, hand washing. But in hospitals, the healthcare workers may all follow that, and as humans they may not be 100%, which brings risk. And then actually you've got the patient component, and sometimes, especially when they're ill, actually understanding and sticking to rules can be quite challenging.
If you think some of the age group who are in hospital, they might have cognitive problems, etc. Slips happen, that's life, but where you're able to do something, you should do it.
Yeah. Thank you so much, Dr. Breslin. That was a really fascinating talk, and I think we really got a lot from it. So thank you so much for giving us your time, and we appreciate how busy you are and stepping away from the cold front. Thank you very much.
Thank you.
So now we are going to the break. The break is until 11:10. At 11:10, we'll have a really interesting talk from Molly Byrne from the School of Psychology, and she's going to look at the behavioural vaccine, how behaviour science is informing the policy response to COVID-19. I think the psychology of how we all behave in this outbreak is really, really interesting. I'm looking forward to hearing that. So if you want to go away, get your coffee, have your loo break. In the meantime, if you are wanting to stay in front of the computer, we have our posters coming up. They will be scrolling through across the screen. And if you see something of interest, you can go to the REF website, the Research and Education Foundation website, and look at the poster in more detail afterwards. We'll see you back at 11:10 for the next talk. Thank you so much. Welcome back, everybody. I hope that you've all had a nice cup of coffee and are feeling refreshed and are ready to start for the second session. We're looking forward to a really interesting session looking at both national level and local and regional level COVID response, presently, past and going forward. We're going to start with Professor Molly Byrne from the School of Psychology, NUI Galway. She is going to talk to us about the behavioural vaccine, how behavioural science is informing the policy response to the COVID-19 pandemic. And I'm really looking forward to hearing this presentation. So I hand over now to you, Prof. Molly Byrne, and thank you in advance.
Thank you very much, Anna, and hello, everybody. Can you see my slides? I know we're all getting used to this speaking into a screen thing, but can people see now my slides there?
Yes, we can.
Yeah, brilliant, Anna. Thank you very much. So thanks very much for the nice introduction, and I'm delighted to be here presenting as part of this really impressive conference. I have to say, it's brilliant to see the programme, such a lovely combination of work that's happening locally, nationally and internationally, and just to say thank you to Anita Patil, who's been really very pleasant and efficient and super to deal with. So I'm a health psychologist. I direct the Health Behaviour Change Research Group at the School of Psychology in NUI Galway. And my normal business is caught up in research in which we apply behavioural science to develop behaviour change interventions. And most of my research is actually in the area of chronic disease management and prevention. However, for the last year, obviously with the COVID-19 pandemic, which is so clearly of interest behaviourally, a lot of my work has focused on this. So of course, we're all kind of sitting at our desks and doing all this virtual work. I just wanted to say that I would actually love to be up in Sligo at the minute. I'm from Derry and I'm very familiar with the Northwest, and these beautiful places of Drumcliff and Sligo town are our stopping off places on the way up to Derry. So I do hope to be making that journey, hopefully in the foreseeable future. What I plan to do for the next kind of 20 minutes or so is, first of all, ask the question around whether behavioural scientists can retire now with news of a vaccine. I'm going to give you a little bit of what I know as a behavioural scientist of how we can inform the public health response. And I'm going to tell you a little bit about what has happened in Ireland in terms of how we've used behavioural science to inform the policy response, reflect on how well we're doing, what has worked well, and finish off with a reflection on some current critical issues from how I see it, and draw a little bit of a conclusion. And hopefully we will have time for a few questions at the end. So really welcome any feedback or questions. So we had a brilliant speaker there just before the coffee break who raised this very point about whether this fabulous news that we've had in recent weeks about successful vaccine candidates, whether these are the silver bullet. And we had both Dr. Anthony Breslin and then Mike Ryan of the World Health Organization on the radio this morning, talking about issues that mean that perhaps the vaccine is not the silver bullet that we all really desperately want it to be. These problems are around that research is still ongoing. It's still relatively early days in terms of what we know about effectiveness of the vaccine in the longer term. There will be challenges encountered around production, distribution. We all are aware with vaccine distribution and uptake in different areas or for different conditions that vaccine hesitancy and even anti-vaccination conspiracy theories are very problematic in encouraging uptake of vaccination. It's a real challenge to motivate the public to ensure uptake at high levels that are required for herd immunity. And this type of evidence around the type of trials that have been underway with COVID, with the vaccine, it's difficult science sometimes to communicate to the public, and these are all essential prerequisites before the vaccine can be really effective. So I think in conclusion, and Mike Ryan will probably be saying this later in the conference, and certainly in his clip this morning on the radio, the vaccine really presents us with just one tool in the toolbox. This may not be for eternity, but it's certainly for the foreseeable future. So I think it does leave us still with this focus that Anthony Breslin really emphasised in his talk, that the behavioural vaccine, so all of these behaviours that we now know so well about social distancing, hand hygiene, coughing etiquette, addressing symptoms and self-isolation, these are still our best defence. And this is where behavioural scientists have much to contribute to informing the public health response. So behavioural science, its strength is that it uses a scientific and evidence-based approach to understand human behaviour. So I might just start off, and if I was a bit more savvy and confident about my technology, I could be doing an online poll. But for now, I'm just going to ask you first to reflect on this question. Do you think fines are an effective strategy to increase adherence to the public health restrictions? Now, there would be quite a lot of support for this view in terms of people believing that this is actually an effective strategy. However, I'm just bringing this up as an example of, I suppose, in a way, a common sense belief that really is not supported by evidence from behavioural science. So in a very large international study, which has been carried out this year, focusing specifically on the response to COVID called iCare, respondents indicated that fines and the threat of these punitive approaches are the least persuasive of all of these approaches. And not only are these types of approaches potentially ineffective, but they are also potentially damaging. So there's a threat to social cohesion, and this type of approach can reduce the collective willingness, which, as we know from the past few months, these are critical aspects of a positive response to the public health restrictions. Also, fines can aggravate inequalities by unfairly targeting maybe those who are least able to pay them. And then policing fines can increase antagonistic encounters between police and the population and increase public disorder. So all of these taken into account, behavioural scientists would not recommend fines and punitive approaches to trying to enhance our public health response to something like COVID. So if fines don't work, what do we know does work? So a very widely used framework now from behavioural science, some of you online might be familiar with this model. It is called COM-B, and this model has been developed by Susan Mickey and her colleagues in University College London and is now very widely used. And really what this model says is that for any behaviour to happen, so think of any of those range of behaviours we've talked about that are essential to addressing COVID-19, an individual needs to have the capability. So this is basically, do they have the knowledge? Do they know for how long they need to self-isolate? Do they have the motivation? So this is, do we believe it's important to follow the guidelines? Do we want to do the right thing? Do we believe in government strategy? And finally, do they have the opportunity? So these would be things like, can I actually get to a COVID testing centre, or is it too far from where I live? Is it only accessible by car? Am I actually allowed to take time off work to do the required testing and isolation? And then a practical thing such as when we're shopping, are we actually practically given the opportunity to keep 2 meters from others while shopping? So these are really important factors for us all to examine in terms of developing approaches to encourage the required behaviours to respond to COVID-19. And if we look at some of the principles from behavioural science, which are really useful to keep in mind in terms of developing approaches for our response, I've just highlighted or extracted 5 of these from this really excellent, very clear paper. And this is firstly that any guidance needs to be clear and specific. So really, the more simple the guidance can be, the more chance there is that the public will be able to follow it. In terms of how to frame messages that focus on protecting each other and standing together are much more effective than any messages which are about trying to increase people's individual perception of their own risk. Most of us will believe that we have a smaller chance than others around us. It's called an optimistic bias of contracting the virus. However, if we frame messages in a way that we encourage people being motivated to protect more vulnerable members of society, these will be much more effective. Avoiding authoritarian messages. So again, this can feed into encouraging more of a socially motivated and collective response. In terms of, this balance between rewards versus punishments, what we find with these types of behaviours, which are largely voluntary because many of them happen in privacy, within our own homes, or, we're not going to be caught out if we're disobeying some of the restrictions, is that rewards, incentives and enablement are much more effective strategies than any form of punishment. And then finally, a comment around the process in which we use to develop our public health response. What we know from behavioural science interventions is that interventions in which we engage with the target audience, if you like, or the key stakeholders from the outset are going to be much more effective. And we need to evaluate these as we're going along and learn from the process. So they are just some of the key principles from behavioural science, which I think can really, contribute a lot to informing our response to the pandemic. So to move gears now a little bit and move into looking at how behavioural science has input to the Irish response. And I have to say, I have, been in a number of international fora where I've learned about different responses that different countries have had. And I have to say, I think that Ireland has done particularly well in terms of engaging with behavioural science from the outset. So this diagram is the overview of the governance structure, which was set up in early March in response to the virus. And obviously at the centre of this is NPHET, the National Public Health Emergency Team. And right from the outset, 9 advisory groups were set up, of which the behaviour change subgroup was one of them. And I've been a member of this behaviour change subgroup from the outset with 8 other colleagues. The committee was led by Kate O'Flaherty in the Department of Health, and we also had other social scientists, behavioural economists and health psychologists within the group. So we met weekly from mid-March until the end of August. In September then we were reconstituted to become a behavioural and communications subgroup. So a lot of the core members from this original group are still part of that group, but we are now having much more discussions with the Department of Health communications team, as they are now key members of the group as well. So the group would meet on a weekly basis, and the chair then would take our recommendations back to feed into NPHET's considerations. So what kind of things did we do within the group? Well, this list is a list of all the activities that we did as a group. And I'm actually just going to focus on 3 of these to give you a little flavour of the work that we have been doing. So the first one I'll focus on is the weekly national representative surveys, which have been conducted since the start of the pandemic. So you may have seen some of these referred to in current media. So this is the Amara Tracker survey, which has been conducted on a weekly basis, and all of the data and findings from that survey are up on the Department of Health website. And these have allowed us within the behaviour change group to really take a very evidence-based approach to gauge what behaviours people are doing, how well people are adhering to the public health restrictions, but also what they feel about the responses to the virus. So do they feel that the worst of the virus is over? And I think very importantly, we've collected data from the outset about whether the public think the current restriction measures are too extreme, appropriate, or insufficient. And what we have found consistently since the outset of the pandemic is that there are very high levels of public support for the public health restrictions. So as I think Anthony Breslin outlined in his presentation, nobody likes these restrictions. Nobody likes that we have to do these. However, we still find that the vast majority of the public think that we do need to do them. And indeed, there is a significant proportion of the population who believe that the measures could be stronger. And I think these data are really important to inform the national narrative, which seems to be about everybody wanting things to open up, whereas that is not what the data would suggest or support. Members of the subgroup also conducted more experimental type research in the form of behavioural studies. So a number of these were led by Pete Lund and the ESRI. So this is just one example of an online study that Pete and his team conducted, in which they looked at different ways to motivate people through this poster campaign around social distancing. And what they found was that any campaign which brought up a thought of infecting vulnerable people or large numbers of people were highly motivating for social distancing campaigns and communications. And this type of behavioural and experimental work was done to inform a number of the Department of Health outcomes to really target the things that were going to be effective in encouraging people to adhere to the guidelines. And finally, the one I'm going to focus on is our collaboration with international studies and networks. So I think across all areas, not just behavioural science, from the outset of the pandemic, we have seen really such incredible high levels of international collaboration in ways that I certainly have never been aware of before. So one of the roles of the members of the subgroup has been to really monitor the international literature in the area and feedback findings from this into the national considerations. And then one example of a study which I was directly, or still am directly involved in, what is the eye care study. So this is a very large longitudinal international study led by researchers at the Montreal Behavioural Medicine Centre. And this study, it's an online survey study gathering data about behavioural responses, attitudes, and different international policies, is over a number of waves of the survey, provides really excellent data in terms of being able to allow us to really kind of drill down on what are the effects of different types of national responses. So they have had, I think they've maybe about 6 waves of the survey done at this stage, with research findings from over 140 countries. So we were able to feedback findings from this survey and others like it, but specifically in this example, this survey. For example, in this response to the measure of finding that the threat of fines and these kind of more punitive approaches were ranked very low down in strategies that people found convincing. So we were able to feed these findings back through the behaviour change group, but also through media in terms of, there was a very nice RT brainstorm article written by Hannah Durand, in which she linked the data found in the eye care study to the national response, discouraging this threat of fines as an approach. So how are we doing then? This is the final bit now of my presentation in terms of reflecting of, you know, where has all that work really left us? So you're probably, all of you are familiar with these graphs, and, you know, obviously these graphs, underneath all of these graphs, there is suffering and death. There is stress and isolation, you know, so I don't want to glibly say I think we've done relatively well, because, you know, it has been a very, very challenging time for many people nationally. However, I still do think we're at a relatively good position in terms of having one of the lowest cumulative number of cases per 100,000 currently. So I think we have shown that by being willing to have these relatively high level of restrictions, we have actually managed to keep numbers to some degree under control. What has worked well? I think that the Department of Health and their communications have been highly effective. I think that research has shown that the branding is trusted, respected, highly recognisable. These are all important characteristics of a good public health campaign. I think we also, certainly for the first wave of the pandemic, we had a very effective governmental response. So obviously this is Leo Varadkar in one of his addresses to the nation. And sorry, now this is a bit self-indulgent just in terms of this is a little letter which was sent by Leo Varadkar to my daughter. So Maeve, my daughter, who was 9 at the time, had written to Leo expressing, this was back in, maybe she'd written back in May, expressing her concern that the government weren't really taking the whole issue of schools seriously enough. And this was the response that she received. And I'm really flagging it here because I think it really captures a lot of the spirit that was there at the start of the pandemic, and to some degree has been able to be continued throughout. I think we have had excellent communicators from public health. I think RTE have played an absolute blinder in terms of communicating what can be difficult information for allowing the scientists to contribute. I think also in terms of contributions to print media and also to online media with blogs and more on social media, scientists have really been they've been offered the opportunity to really contribute to the debate. And these things are all critically important in allowing the public to become informed and to feel that they trust in what the public health guidance is. So I think in all of these ways, the public health response in Ireland has worked very well. And as I said earlier there, I've been in a few international fora where, I think Ireland can really be quite proud of how it has done. So where are we going? I think at this stage, just to pause and to think where we're at, I think each stage of the pandemic is, potentially you could say it's a difficult stage. With the first wave and the first lockdown, it was very challenging, very stressful, very new to most of us. But we did really well in terms of engaging the public because our aim was relatively simple. It was flattening the curve. Most people had bought into this, and we could see how effective our behavioural responses were to delivering on that. However, now I feel we're in murkier waters. I think we're in this place of muddling along, and maybe it is just muddling along until a vaccine can enable us to have a more effective response. But I think it is really important to realise that the public are willing to buy into relatively high level of public health restrictions if they believe that they are achieving what needs to be achieved. So I suppose it's the model behind the strategy is critically important. And I think that is going to be very interesting as we move forward. And I do believe we need to remain open and allow debate and dialogue about what strategy we're taking. So in conclusion then, I think the COVID pandemic really presents a golden age for behavioural science. I think behavioural scientists have much to contribute to the discussion and the debate. I think we really need to harness the brilliant infrastructure that has been set up for an evidence-based response to COVID. I think we need to learn, we need to evaluate what we're doing, we need to measure and collect data, and we need to use these data to inform our current response. But also we need to use this evidence and harness these strengths for future pandemics and to contribute to knowledge more globally. And we need to continue our international collaboration and research and to learn from other experiences and other countries. So thank you very much for the attention. I hope what I've presented is of some interest to you, and if we have time, I'd be delighted to take questions.
Thank you very much for that interesting talk. And we have questions online, and I have so many questions in our head. And unfortunately, we only have 3 minutes, so we'll go directly to the questions that have come in online. One of the first questions was relating to the survey that you talked about in the beginning, where 2,500 people are asked weekly about their behaviour. Who are you surveying and how do you access them?
So this is a survey conducted by Amara Research Agency. So this is nationally representative in terms of spread around the country, in terms of age groups. So Amara are very experienced in terms of developing strategies for conducting these national surveys. So yes, so nationally and age representative, Anna.
Okay, thank you. That's really helpful. Interestingly, you talked about fines and restrictions not being effective. Restrictions being effective, but fines and punitive measures not being effective, and people needing to have a sort of an incentive to take action. How does this marry with, say, the Swedish picture, where they were informed and expected, versus here, where actually more restrictions were put in? What's the behavioural science interaction there?
Yeah, I mean, of course, Anna, that's a very interesting question. And I think Sweden has provided, for both behavioural scientists and for public health people, has provided a really interesting example of, differing approaches. While I think it's really important that we learn from different countries and learn from different responses, I think it's also important to understand that different countries have different cultural norms and different cultural approaches. I've certainly spent a little bit of time in Sweden, and I would certainly have experienced that their ability and natural inclination to follow rules naturally is quite different from the Irish inclination. So while I think, it'll come out in the wash to some degree in terms of looking at levels of cases, levels of deaths in countries who have used these different approaches, I think we do need to be cautious by thinking, oh, well, if it works in Sweden, and I think the jury, to be honest, is still out on whether it has worked in Sweden. But I think we do need to be cautious in terms of generalizing findings like that to other settings in which we just have a different culture than Swedes around adhering to rules naturally.
That's very interesting. I mean, that leads nicely onto another question we have, which is there any evidence that you've seen so far that there are specific ways of communicating with the Irish population that would differ from other countries?
Mm-hmm. Well, I think, Anna, and again, I was at a few different international events where people were talking about, there were contributors from Israel who were talking about, different communication approaches that just seemed they were dealing with a very different type of a population. And I think in a way, Ireland being a relatively small country, relatively low levels of population density, and generally by international standards, highly cohesive society with really one main national broadcaster. I think we are actually a lot of those things that we have within our culture put us in a really good and strong position to communicate and respond in the pandemic.
Thank you. That's really interesting. And as I say, we would love to ask you lots more questions, but unfortunately time is against us. So thank you very much for your contribution.
So much. Okay.
It's been fascinating. So I think that was a really interesting talk, and now we're going to move on to another interesting set of talks. We're moving on to hear from Gráinne McCann, who is the manager of Sligo University Hospital. This has been an extremely difficult task, which Gráinne has managed, I think, very well, and maintained an approachability and calm throughout it that's been reassuring to staff. So Gráinne McCann is going to talk to us. And Professor Nash Patel is also going to join her to talk about managing the COVID-19 response at Sligo University Hospital. So without greater delay, we will move on to them. Thank you very much.
Thanks very much, Anna, and thank you to the RAF for organising the conference today. So I suppose the calm exterior may not reflect the uncalm interior. So I'll talk about how we have been managing the pandemic, I suppose, since the beginning of the year in the hospital. And Anthony Breslin would have referred to a couple of things as we entered into 2020, nothing that we'd ever seen before. And some of the things that were happening around the world and started to come closer to home when we saw our first confirmed case in Ireland at the end of February. And then for the hospital itself, we saw a peak in admissions in the middle of, towards the end of March. We had our first outbreak in the hospital in November, and then a peak in admissions to the hospital in November. So, and the prevalence in Sligo, Leitrim and our surrounding areas and South Donegal obviously had increased in that period and has had its own knock-on consequences in terms of patients coming to the hospital. And what did that mean, really? Well, the pandemic was something new in my management experience anyways, and it had many crises across the country. So we had health, economic, social. But I suppose some of the things, what has happened for all of us, and Molly alluded to some of the impacts and consequences of a pandemic. And there's some of the things, the stress, the anxiety, isolation people were feeling, hoarding. Gosh, we started off with the toilet roll incident and everybody was hoarding the toilet rolls for some obscure reason. And then right tools for the job. People were starting to have to work at home. Well, did they all have the setups at home to work from home? Did they want to? Is that isolating in itself? And then you have things around childcare, schooling of such major concern to people. Insomnia, I have to say, I had lots of sleepless nights myself at various different stages. And then, of course, people who become unwell and have had to live with the long-term impacts of COVID itself. So not very pleasant experiences for us. And so we've had to look at, what have we had to do and how well have we managed over the whole period. So we started, I suppose, really the COVID response team was a multidisciplinary team in the hospital. And it was the fora that we had, or the forum for managing and making our decisions in that time, and continues to be in existence up to today. We've had to change our patient pathways. And that was at the start of the pandemic, and that has continued throughout the pandemic at various different stages. And they were immediate responses. So the emergency department and our acute assessment unit had to immediately switch over, and we had to have red and green pathways for patients. And an emergency arrival unit was set up within a matter of a week between, I suppose, its consideration and it being in place. And that would have been unheard of before this. So the speed at which capital projects and equipment purchases were able to take place was something that we wouldn't have experienced previously, and is certainly something that I would say was a great benefit during the period of the pandemic. Communication, and Molly also talked about communication and having information out, as did Anthony, and accurate information for people. We know that there was lots of fake news at various different stages. So it is really important for our staff to be able to get accurate information, timely information, to be well informed, not only, from the hospital management right down through the system, and that gives people a sense of better understanding and assurance in terms of how things are being managed within a hospital structure. Lots of infrastructural improvements had to happen. So all of a sudden we had working environments that were very challenged in terms of the space that they needed to I suppose, contend with and the volumes of people in small areas. And, the supply of perspex and perspex demands went through the roof. Then, of course, PPE, and it wasn't just about having PPE, but it was about the management of PPE and foreseeing what we were going to need. So it was projecting, all of a sudden it was about projecting that demand and where we were going to be able to source supplies if we felt that we weren't going to have enough supplies. So management of the PPE and then having those supplies. And then training staff in the correct use of their PPEs. And our infection control team and our NMPDU services played a key role in making sure that staff were well equipped, and that's not something that just happens at one stage. It's an ongoing process, and even in the recent weeks, we've had rolling video sessions and one-to-one sessions, departmental sessions in terms of the correct use of PPE and just refreshing people and reaffirming some key messages. One of the things from a staff perspective, I suppose, really in terms of there was a time period we went through around swabbing and people's referral to test centres and we're having to wait for results. So we established a staff swabbing team in the early days with rapid results through our own lab. That was hugely supportive for staff because they were able to get those results very quickly, and that either meant they may be off work in isolation or restricted movements, or they could return to work, depending on that. So that was very important for staff. Virtual working continues to be a challenge. I suppose one of the things we learned is that IT infrastructure and setups are a great challenge in this environment, and delivering a service in an acute hospital isn't designed for extensive virtual working, but it is to a certain degree. And certainly we've been able to move forward with, and even this conference is a good example of virtual communication and working together. But we've had, virtual meetings, virtual outpatient clinics. So we continued our outpatient clinics during the early days of the pandemic, and that was all telephone assessments. Now we have multiple methods of OPD assessment, be it virtual or face-to-face. Supports from community partners were a huge piece, particularly in the early days of the pandemic. And we saw IT Sligo playing a pivotal role in supporting us in the hospital. We saw places like the County Council, where staff came and worked along our own staff in supporting us delivering our services in that time. So they were very important and very unique times, really, because they wouldn't have been something that would have happened to that extent previous times. Staff initiatives and ideas. So a lot of things were coming up from the ground up, which was fantastic. And I know some others will talk about those ideas. And it was great to be able to give staff the opportunity to feed into the pandemic and play their role in terms of their ideas coming to fruition. Staff wellbeing continues to be a very important focus for us, and during the early stages of the pandemic we had various different apps. One of them had been a mindfulness app. We have different staff acknowledgement things that took place, and that continues right to the current time and will continue in the post-pandemic period. And Nash will talk about the private hospital arrangement and how that has supported us during this time. So the challenges that we faced have been immense, but we've got through them. And some of the challenges, resumption of services, has been a big challenge. Configuring our outpatient department into a service where you're now seeing people through multiple platforms, it is a challenge because you need to have those set up. You need to decide how you're going to see the different people that are scheduled in your clinic. So a lot of time, a lot of preparation, a lot of manpower to actually get those things in place. Uncertainties, we're in, we get out of a lockdown period, different levels of restrictions. That means habits change sometimes for people. So it's uncertain times, and it'll continue to be uncertain times for some time ahead. We're currently learning to live with COVID. and old habits die hard, as they say, so it can be a challenge for us in that world. And continue communications to staff. Communication can never be underestimated, and it is always a challenge because you have to keep on top of that. It's important to do it. And I just threw up a couple of photographs there, various different things that were happening throughout the hospital in terms of, even donations we got at certain times. The hospital's entrance it had to change. The emergency arrival unit came along, and staff were working in that unit. We had to drop off and pick up for patients because their visitors have still not been able to come in, only in restricted manner. And then refresh training, as I mentioned earlier. So some of the learnings that we have had over the course of the pandemic. I have mentioned communications. It does need to be factual, it does need to be timely, and it needs to be continuous. So it shouldn't stop, and we shouldn't forget the fact that we need to continually have key messages for our staff. Supports for staff. Staff need to have training, they need to have well-being initiatives, they need to know that what supports are there and available for them. And we also need to continue to look at our decision-making processes and rapid decision-making and timely decision-making. And finally, our cohesive team working. So when we make that decision, then the team needs to work behind the scenes in delivering on those decisions, and that's of key importance to us. So I just wanted the final sort of a few pictures there show some of the working together. The county council are there, and what was the hospital entrance going back to the beginning of the year. We had a Thinking of You initiative that our Consumer Services Department, the idea generated from them to engage with families and their loved ones in hospital.
Thank you so much, Gráinne. I'm really sorry to interrupt you. I'm just aware of time, and I'm really sorry. I think we might have to switch over to Nash, but it's been really interesting and I'd love to carry on listening. But unfortunately, we only have 5 minutes before our next speaker. So thank you so much.
Thank you.
Thanks, Anna. I was actually letting Gráinne go on in full flow because what she said is far more interesting than with a few comments I was going to make. So I've not got more than a few minutes to introduce myself. This talk is probably me wearing my hat as an associate clinical director, although I'm an ENT consultant at the hospital. And as Gráinne correctly said, the family approach to this situation is something that is really germane. Obviously, this has been reflected all over, but my little neck of the woods is this hospital that I work in and this private hospital that we have in town. So my specific remit for this talk, just as a follow-up to Gráinne, is the collaboration and the communications we had with Kingsbridge Private Hospital, which is the hospital in town. So to start with, my personal view, and it's a philosophical view, is that every situation has positives. And if this pandemic has any positives in it, one key one is the communication, the collaboration, the cooperation we were able to develop with the private hospital. So as Gráinne says, on the 29th of February, a leap year like no other, everything changed for us in Ireland in terms of COVID finally coming onto our shores. Very quickly thereafter, I have to say the HSC put into place plans by which they were going to commandeer or take over the private hospital. This was the first wave, retrospectively called the first wave, but at that time we were new to this situation. We didn't know exactly what we need. So it was all to play for. And Kingsbridge is a hospital that has been in town for all of the time that I've been in Sligo. That's since 2004. And I remember Mary Harney's words way back, almost 15 years ago, where she was looking at co-locating hospitals, putting private hospitals on the public sites, and Sligo was one such targeted site, except that never happened. In a strange way and in a positive way, this pandemic has brought Kingsbridge and Sligo together, because with the speed of light, nearly, we put together, Gráinne and myself and Jennifer McLaughlin, Mark Regan and Kingsbridge, we put together a working group. We had weekly meetings every Wednesday, still happening at 10 a.m. We put in governance structures, and my key tenet for engaging with Kingsbridge was patient safety. If there was a hospital, an institution in town, where there was no emergency department, no hot treatment, and we could decant out of the hospital those services that could move across to Kingsbridge so that they'd be safe for our patients, and we could use the floor space that was created in Sligo to enhance the emergency department, have the green zone and red zone, as Grania said, although I always say it's the amber zone that causes most worry. So we decanted or transferred a large amount of outpatient services, mainly antenatal, gynae, ophthalmology. We did, I think, over 7,000, and we're still counting patients in Kingsbridge since that time. We also took their endoscopy suites, and we offered those endoscopy suites to cross sites in the CERTA group. And the third part that we looked at was theatres, and there was an issue in terms of not just us, but Kingsbridge had to be COVID compliant, and time was of the essence. So we parked that for the moment, and we moved ahead with these two. I genuinely believe that the interaction we had with Kingsbridge has brought several advantages. It's created a bridge between our two institutions that is of value for all, because as Grania says, this is a moving situation. We're still going to have more COVID lockdowns, perhaps spikes, maybe waves, flat or otherwise. And I am very happy, and I like the fact that Kingsbridge and we now speak of one hymn sheet with one common goal: to give enhanced patient care in a safe manner, and to incorporate the lessons of the COVID. Maybe the vaccine will change this, and we'll be able to put more services into Kingsbridge. Kingsbridge itself is on a roll. They're putting in MRI scanners. They're enhancing their own operation capacity. So I see for the next while that this will be a mutually symbiotic and beneficial relationship. I do believe within the group there's been wide recognition that the interaction we had between SUH and Kingsbridge was generally commended. I think it was well seen by most. So those are my few thoughts. I have a few figures and so, but this is largely what I'd like to say. So I'm happy to take questions, or I'm sure Grania would, but that's what I have to say. Thanks.
Thank you so much, both of you, for your presentation. I think it's really remarkable how much work has been done in the local setting in order to rapidly accommodate this pandemic. And I really personally would like to thank you both for the hours that I know you've put in order to just make things function. It's been really important and really effective. Unfortunately, we haven't time for questions straight after this talk. Perhaps if you were able to stay on, we could give questions together after Dr. Finan and Dr. Vota's talk subsequently. So thank you so much, and if possible we may be able to address the questions that have come into after this if you are able to stay on. Now we are having a slight change to our programme due to the schedules of what's happening in Geneva and how they're able to accommodate us. And Dr. Ryan, Mike Ryan, was kind enough to come and join this conference and break up his time in his job with the WHO. So he has had to alter his schedule and will speak to us now. Many of you will know who Dr. Ryan is. Dr. Ryan is a local man. That's not the main acumen to his CV, but it's important. He was born in Curry in Sligo, so he's local. So I think that gives inspiration to all of us working and researching in this area. While we may be a small county, well, we may be just one person, together we can actually do big things. Dr. Ryan is currently the executive director of the WHO's response to emergencies programme. He's leading the containment and treatment response to the COVID. And just recently, he's the winner of the Bar of Ireland Human Rights Award for his tireless work and leadership in the field of public health. He was also at one point involved in the polio vaccinations and the global eradication of polio. So he has had a long involvement with dealing with challenges to our health on a global scale from a public health perspective. And we really look forward to the insights that he brings to our conference from his international perspective. His plan is to give a short talk and then have time for a good number of questions. So please listen carefully and do send us in your questions, because this is a unique opportunity. Thank you, and over to Dr. Ryan.
Thanks very much for that lovely and warm introduction, and it's great to be talking to home over the airwaves. And just let me start by just recognizing the amazing efforts that you and all of your staff and all of your teams have done over the last 10 months. It's been a demanding and brutal time, one filled with fear and sorrow, but also hope and courage. So to all of you, you are the true heroes of this story, and you should take a bow. I'm sure all the communities in the Northwest recognize the efforts that you have made. I'll speak for a very few minutes. I think it'd be good to have a dialogue. Globally, you're all watching the numbers, but we've exceeded 60 million cases, and we'll soon approach 1.5 million deaths. We're over 1.4 million deaths globally at the moment. The pandemic is evolving in slightly different ways in our different regions, and obviously you're experiencing the second surge in Europe, which continues, but the number of cases is starting to fall. However, the European region, our European region, is not the European Union, but the European region of WHO accounts for 56% of all cases in the last week and nearly 50% of all deaths. So the epicenter for this pandemic is squarely in Europe. In this second surge or second wave, Ireland was the first country to turn the corner and turn that curve in a downward direction. So again, congrats to the people at home, to the public health staff, to you, clinical and other staff for having achieved that. And I suppose the challenge now is how to continue to drive that number down. I think the R0 or the R0 hovers around 1, test positivity around 3%. And while they're good numbers, that means the virus is still out there, and the virus is still very capable of reigniting community transmission at any moment. So continued vigilance over the coming weeks, and hopefully some respite at Christmas. But this is going to require a continued effort on everyone's part. The situation in the rest of Europe, as I said, has improved, although Eastern Europe and has not stabilized yet. We see patterns in North America of increasing cases, particularly in the United States. Similarly in the North Africa and the Middle East. Southeast Asia, Africa, and Western Pacific still have relatively low numbers of cases and continue to experience less deaths from the pandemic. We have good news in the sense that we have 3 vaccines now that are shown efficacy in trials. It's a really important and hopeful note. We have further 9 vaccines in phase 3 trials and 50 more in other forms of preclinical trials. And the hope is that by bringing in and adding vaccine to our continued efforts to physically distance and stop giving the virus chances for transmission, if we add vaccine, good, strong, well accepted vaccination into that we have a chance of getting COVID under complete control and hopefully down to 0. So there is good news. Again, it's been a wonderful collaboration of scientists all over the world, both in the public and in the private sector. And I would note what the previous colleague said, there has been tremendous collaboration between the public and the private sector in all areas of innovation and service delivery over the last 10 months. And I think it bodes well for the future. I think I'll leave my comments there. Actually, we still face strong challenges going forward in sustaining this response, and at the moment there is huge pressure on health systems in a number of countries. And once again, we see frontline staff struggling with fatigue, with stress, with overwork, and with lack of resources. I'll be interested to hear from you what your experience is in the front line there in the Northwest, what your needs are and how you see the situation, and how better we as WHO can communicate your needs and your concerns, both within and beyond Ireland. As I said, it's just for me a very nice opportunity to speak with you all. I know Fergal Hickey there in the emergency department. has drawn me into other speaking roles with his community, and again, I'm very pleased to just be with you here today and reflect on the issues that we all face. And I think it's better if we have a Q&A and I can answer the questions you think are most pertinent to your situation, your experience, and your concerns. Back to you.
Thank you, Dr. Ryan, for your insights there. We have a number of questions that were already come in. Interestingly, we have local questions, but we also have delegates from Zimbabwe and Canada, so they may not all be Irish-centric. We've got one question with regards to funding of the fight against COVID and suppression of the disease. It says, given the billions of euros/dollars spent on mitigation, do you feel enough funding has been given to fight COVID internationally?
I think the underinvestment, we are where we are, not necessarily only because we didn't put the resources in the last 10 months. We've unfortunately spent decades under-resourcing public health systems, primary healthcare systems, and frontline health systems, and we're paying a price for that now. Globally, public health surveillance, the capacity to do contact tracing, the integration of laboratory services and diagnostic services into strong public health measures, strong primary healthcare-led health services, better elasticity in our healthcare and secondary and tertiary systems so they can expand and absorb surges without the chaos and fear of absences of PPE and lack of trained staff and exhaustion. Many people have had to, the system has had to rely on the courage and the goodwill and the heart and passion of workers to make up the difference. That should not be the formula for success in response to a pandemic. So therefore, the ingredients for this situation, or the seeds for this situation, were sown over the last decades in this area, and that needs to change if we're going to do better the next time. With regard to the response itself, I think all governments have tried to resource the response as best they can within their means, but there have been real difficulties in getting resources to frontline workers, whoever they may be. And some of that is a financial issue, some of that's a procurement and a logistics issue, some of that's an equity issue, some of that's just a data issue, knowing where the needs are and responding to those needs quickly. So it's not just a money equation. There has been significant investment in the research and innovation side. I think the private sector have come in to support that heavily. And we now have the prospect of being able to deliver a vaccine for the first time in an epidemic response at the beginning on an equitable basis, based on the need of the patient or the person at risk, and not just on the ability to pay. But we are struggling to raise the necessary funds to pay for that. We have the access, we've negotiated the agreements, but we need the dollars to make that actually happen. And that's a gap. Access to COVID tools, diagnostics, therapeutics, and vaccines requires significant extra funding. Our responses in humanitarian and conflict situations still requires extra resources so we can serve the most vulnerable in our societies. And then beyond that, the broader health, social, and economic consequences. We call it mitigation as such, and I think the term itself needs to be thought about. I mean, many people are suffering mental health distress. Many people are suffering social and economic loss, losing jobs, and that in itself requires a response to fix that problem, and that in itself is drawing a lot of resources, particularly on the economic side. And governments around the world collectively are investing trillions of dollars in that exercise. And there have been times when we've called for a more balanced investment, because we don't get back our economies and our social lives until we deal with this virus. So if we underinvest in the response to the virus, then we're just going to extend the economic and social losses. So we do and would like to see more resources flowing into the frontline public health responses, into community engagement, into dialogue and community empowerment, into messaging, into frontline health services. Absolutely. And in particular, in some countries right now, unfortunately, because of a lack of full strength in the frontline public health service, we've ended up using so-called lockdowns as the emergency breaks. And that's not a very good emergency break. Now that Ireland has, for the second time, controlled a peak in virus, and I would say this to many countries in Europe and beyond, what are we going to do now? Because as soon as we begin to mix again, the numbers will tend to go up again. Do we have the frontline-led public health services with decentralized command and control, where local teams can make decisions, where we can integrate the information on cases and contacts and the lab data and liaise with our clinical colleagues at the hospital level, and that we avoid vertical silos that only connect at national level? We have to have the capacity to respond to what we see in front of us. And the people who can see what's in front of us are the people at local level. The local response teams need to be fully resourced. We need a huge expansion in contact tracers. We need a huge expansion in the ability to be able to do rapid testing. It's not the number of tests we do, it's who we test and how long does it take to get that result. Because the test is only as good as the speed at which it can be delivered. So there are things we need to do that are money oriented, but I think there are things we need to do in terms of how the system is structured and organized and how it's prioritized. Back to you.
That's interesting. I think that ties in a little bit with what we heard from Anthony Breslin, that actually at the outbreak of this COVID pandemic, they had to bring in retired public health doctors back into the service to try and meet the needs. So it's that having a fully available and resourced service to manage pandemics like this. We have a question from here in Sligo. The question is, what percentage of vaccination do we need to achieve for Ireland to get back to normal? And along, perhaps aside that question, we have a question from another member of the Sligo hospital team. Are there other programmes that need to be implemented by healthcare bodies to complement the vaccination programme?
It's difficult at this point to give you an exact figure on what percentage of the population need to be vaccinated to stop the virus or reach that level of population immunity that prevents the virus transmitting, because we don't have final estimates on the efficacy of the individual vaccines, and again, Ireland hasn't chosen which vaccine it's going to use, so it would be improper of me to give numbers. But what we do have is the advantage of 3 vaccines showing high levels of efficacy, and we would like to see high uptake of that vaccine for 2 reasons. We need high uptake of the vaccine in health workers and in older and vulnerable individuals, which in itself is not going to reduce transmission, but that is going to reduce the deaths, it's going to reduce morbidity, and it's going to reduce the pressure on the health system. That's the first thing we have to do, is take the heat out of this. And then rolling that vaccine out to the broader population is what's going to actually interrupt the transmission cycle at community and broader level. And I don't think we can realistically expect to be doing that in the first few months of next year. I think the priority has to be given to those people who are most likely to have an adverse outcome from the disease and those fighting in the front line most likely to be exposed and who we need to stay healthy. So we'll have 2 phases, I think, in many countries. A first phase, which is protecting those high-risk individuals, and then a second phase aimed at controlling the transmission of the virus at community level. And I believe we will need high levels of vaccination to be able to achieve that. This virus spreads easily, as we've seen. It has a much higher transmissibility than previous coronaviruses. It's equivalent or greater in its at least on the face of it, it seems to outdo influenza quite easily in terms of its capacity to transmit this particular strain. So I think we're going to have to achieve high levels of vaccine coverage, and to do that, the work that we need to be doing in advance, even though the vaccine doesn't exist yet on the island, there's a lot of work that needs to be put in place in terms of preparing for that. The logistics work, the training work, the planning work, the micro planning. At the moment, we're macro planning. We're thinking in big terms. We need to get down to the micro planning of exactly how we're going to deliver every dose of this vaccine to everyone who needs to get it. And that's going to require a major planning exercise. I think in Ireland and in most developed countries, we're used to vaccinating children very efficiently in the EPI programs. We're not so used to doing mass vaccination in mainly adult populations. It's a different challenge in terms of communication, in terms of logistics and access. When do you vaccinate working people? You know, is this going to be vaccination at weekends and the evenings? Are we going to go to the people to vaccinate them, or are they going to come to us? Is this going to be led by GPs or led by more vaccination centre type approach? I don't know what the decisions in Ireland are, but these are big choices. And there needs to be a dialogue between the professionals and the community and the government as to how best to achieve that. And I think that can be done. There are also beyond that, there are the vaccine demand issues. We need to generate the demand for this vaccine amongst the people we serve. People have been bombarded with a tsunami of disinformation, misinformation, good information, and people are overwhelmed. And it's time now for frontline public health, community, primary healthcare, GPs, everybody to become the communicators around this vaccine in giving people the information they need. We will deliver safe and efficacious vaccines. Whether we believe they're safe and efficacious is one thing. Whether our community believes they're safe and efficacious is another thing. And that's not just bamboozling people with numbers and figures. That requires a discussion around the concerns that our communities might have. And we need to address their concerns and address their questions in an open way so that we can bring the vast majority of people along with us on this journey. So we've been saying it here, we've reached the base camp of Everest with the vaccine development, but we've still got to climb the mountain. And the mountain climbing is going to have to be led by the frontline health services as ever in this endeavour. And you need your voice in this, in the planning process, because you know the communities, you know how to get this done. And that must, in some sense, and must influence and drive and shape the design of any vaccination program that comes up next year. Back to you.
You said that, thank you for that. You said that the vaccines won't bring us back to zero COVID. So there's a question about what other programs need to go hand in hand with the vaccine being rolled out.
Yeah, I don't think vaccine automatically equals zero COVID. We have measles vaccines for the last 50 years, and we still can't stop that one. So the existence of a vaccine doesn't automatically equal eradication or elimination. There will be a significant period of time next year when we will have to maintain physical and social distance. We will have to be very careful with our hand hygiene. We will have to avoid, to the extent possible, crowded spaces. The question will be, can we add personal measures to vaccine to equal zero COVID, and can we avoid the lockdowns? What everyone wants out of their lives is the lockdowns. Everyone wants the restrictions gone. Everyone wants to get back to normal life. But I still think we will have to proceed with care, with vigilance, and with empathy for other people, and we will still have to manage risk. And each and every individual going forward is still going to have to make an assumption that the virus is still around, and I have to reduce my risk of exposing others and others' risks of exposing me. And that still requires a strong communication campaign from government, strong support to the frontline services, and we add vaccine into that equation, then we can really advance in the fight against this virus, and we can avoid the punishing lockdowns that have come in now, I think in Ireland twice, and in some countries 3 times in the last 11 months.
Thank you for that. Now, we've got a question from a Dr. Cannon in Sligo. He says, how do the WHO pros, so the Pfizer vaccine requires very cold temperatures to transport the vaccine in, and Dr. Cannon's wondering if the WHO has any strategies for and administering this drug.
Yeah, it's a good question. Both the mRNA vaccines require ultra cold transport and delivery, and that presents a big logistics challenge. The companies themselves have developed pretty sophisticated systems of macro distribution to countries, and then pretty good systems for how that can be transported subnationally. We have, as part of our work on Ebola vaccination, working with the Global Challenges and the Gates Foundation and others, have developed a really interesting system that doesn't require liquid hydrogen or dry ice, and it's called an Artex system, which allows for the -80 transport of vaccines. And we did that in Congo, in a tropical country in the middle of a war zone, and we vaccinated hundreds of thousands of people. So it is possible, but it does require a real examination of the cold chain. I'm sure the vaccination authorities in the Department of Health and others in Ireland, HSE, are really looking at that cold chain right now. We do then have the AstraZeneca product and other products in trials which don't require such ultra cold temperatures and can be used in much more in the normal fashion. And it may have to be a mix and match for how the government, number one, what vaccines will the government have access to, and then how those vaccines are best used. I don't think the logistics issue is insurmountable. The ultra cold chain vaccines can be taken out of the freezer and used I can't remember the number of days, but it's not like 2 hours. So there is a chance to bring these ultra cold vaccines to regional or county centres and then distribute them for daily or use in the following few days. So it's not that they have to be frozen at -80 until the moment before they're injected. There are some tolerances there that would allow subnational distribution at ultra cold, and then some distribution for use that don't require such absolute temperature. So we have to look at all of that. It's going to require a very agile and very efficient system for using the products we have, but it shouldn't be an excuse. The logistics and the planning issues shouldn't be an excuse for us to not vaccinate and get on with it. But Dr. Cannon is right; these are real issues. And I see you mentioned Anthony Breslin there. I think if it's the same Anthony Breslin, I think he was a year or two ahead of me in college. I was in the same class as his brother Tom, if that's the Anthony I remember.
That's interesting you say that. We have got a comment here that says it's good to have one of our own leading the way. We are always so proud when we see your appearance on the media. So equally, as you send your greetings to people in Sligo, they're sending them back to you. I think it's interesting in that response how you reference the work in Ebola, because it's fascinating how actually we see that we are not individual countries tackling health problems, but actually it's the health of countries all over the place, and including in nations which are not so economically strong, that actually affect and feed into this. So if the Ebola work hadn't taken place, we wouldn't be in the position we are now to deal with COVID. So I think that's a really interesting point that you make. There's a question here, having learned from COVID and continuing to learn from COVID, do you think that we'll be in a better position to deal with emerging pandemics from, say, other diseases? And do you think we're likely to meet them in our lifetime?
I hope so, but the optimist in me says yes, and the cynic in me says, well, we've had a long time to learn lessons from previous pandemics and epidemics, and we haven't done so well. So I think the danger in this is, and you know what, it's going to be, we all want to forget about this, no one more than me, and get back to see my family and other things. The danger is the amnesia that comes after a trauma. And when we have the pain and suffering and the stress, we want to put this behind us. And the danger, as we put this pandemic behind us, we forget that there are potentially other pandemics ahead of us. But human beings, in order for us as individuals and societies to survive, we try to avoid catastrophization. You know, we have a major catastrophe. We try to put it behind us and get on with our lives, because you don't know when the next one is. Why worry? And that's a problem. It's a natural instinct, and I think it's protective of your mental health and your well-being, but it's not necessarily very clever if we're now going to barrel ourselves into a future pandemic. And remember, we're dealing here with the virus that, while it spreads relatively easily, it really has only infected maybe less than 10%, probably between 5 and 10% of the world's population, and look at the damage it's done at that level. It's got a relatively low mortality if you look at the infection fatality rate as opposed to the hospital or clinical fatality rate, and look at the damage it's done. This is not the worst virus we could be confronted with by a long shot, and we have a responsibility to our communities not to do the Chicken Little and run around and say the sky's going to fall in, because people need to get on with their lives. But we in the health sector have a responsibility to work with government to put in place the necessary preparedness so that the next time this happens, we're better, we're faster, we're quicker, and we're more effective. And I do think that's going to require a big person discussion with policymakers around what health security actually is and what is societal security. Is it building armies and nuclear weapons and stealth fighters and everything else to protect us from visible enemies that we perceive will invade our borders? Or is it actually putting in place the real defenses against the invisible enemies, which are now proving themselves to be much more effective at pulling our societies apart and tearing our economies apart? And I do not believe for 1 second that we're investing near enough in dealing with this threat, like the same way we're not putting near enough into dealing with the climate threat. We face major existential issues on this planet. Our populations have grown, globalization, industrialization, our behaviors have changed. We've exploited the environment. We move around more than we ever did before. We live in dense urban conurbations, very often surrounded by people living in slums with poor access to healthcare. We are creating the most shall we say, productive conditions for microbes to both emerge and amplify and globalize. And we need to recognize that. We need to recognize that that's a risk, and we need to invest in recognizing and managing that risk. So on the one hand, I'm hopeful we won't forget, but and we have learned. And then you mentioned there the Ebola outbreaks. You know, the monoclonal antibodies that we've developed for Ebola, it's the same principles that have been used for this disease. The vector vaccines that were developed for Ebola, the same. If you look at the AstraZeneca vaccine, is based on the same type of technology. The ultra cold chain. You are bound, and you are, and the same for you in there in the Northwest and in Sligo. You are, as a health worker, you not only do your job, but you are bound and you must learn from everything you do and get better the next time. Perfection is not the expectation. The best effort with learning is, to me, the best expectation we can have of ourselves or of others. And we must learn from this pandemic. We absolutely must learn from this pandemic.
Thank you very much for that. It's very sobering and gives us a real global response to what we need to do. Unfortunately, it looks like we're running out of time, and I know that you're busy. Perhaps we might just ask you one last question, which would be how, given the pressure of responding to COVID on our staff and the potential of post-traumatic stress disorder, what do you have any recommendations, maybe on a public health level, but also maybe on a personal level, on how to manage the stress that goes with managing a pandemic? Because I imagine you yourself have come under a lot of intense pressure and may have actually been having to look to strategies personally to manage that.
No, I think it's real, and all health workers and all people working in frontline emergency services for their whole careers deal with very upsetting situations. So, you know, it's not something we're entirely unaware of. It happens, but when it happens at this scale, and when doctors, nurses, and others have to tell so many families that they've lost a loved one who they've not been able to see before they die, when the fatigue and the frustration and sometimes the rage and anger at not being able to do more, these are real things, and they do affect you. And I've certainly experienced that in my life and some of my colleagues in humanitarian settings. It's very often it's not the stress of the work or the fatigue. It's sometimes just the anger at the unfairness of it, just the rage at why do we have to come here and do this? Why did this have to happen this way? Could we not have been better? Could we not have been more ready? So it's that, and it's witnessing those, you know, small tragedies, you know, those tiny day-to-day tragedies of families saying goodbye by Facebook to their loved one. I mean, that just breaks my heart, and that affects us all afterwards. And everyone needs to, I think, be kind to yourself, be kind to each other. And groups are going to need to take time after this. We often do this in humanitarian response. We get together, we do after action reviews, and we try to not only examine our operational performance, but talk to each other about the experience. And there's going to have to be space created for that. And I mean space created by authorities and by government to allow health workers to heal in this process and be facilitated in that healing, because it doesn't happen by itself. I have seen staff and colleagues of mine carry that burden sometimes for months after an intervention. And then there's a crisis. Then there's a major dangerous crisis in their life that could possibly have been avoided if we had been more open, more watchful, more caring, more alert, more aware, more empathic. And I do think there needs to be a proper process to look at that, to allow people to grieve and to heal from some of the experiences they've been through. I mean, that's not a sign of weakness, that's a sign of strength. I hope that happens. We've all in my work and the work that our teams do, we see horrible things every day, and our staff risk their lives every day, leave their families. But it affects them, and that trauma stays with people. That trauma can make you ultimately stronger if you're allowed to process that trauma in a functional way with help and with assistance, or that trauma can lead to very dysfunctional situations and responses to self-ill health, to family conflict, to all kinds of things that you couldn't even predict. So this is really, really important. I'm really glad you raised it. Whoever asked the question, it's the question for us all.
Very much. Thank you for that. That's been a really interesting session, and I'm sorry that we can't continue, but we really appreciate your taking time out of your day job to come and speak to us here and listen to what you've said, and also the fact that you have been able to link with where you're from and just personally communicate has been really, really helpful. So thank you so much.
Thank you. It was a great pleasure. Regards to you all. Keep up the good work.
Thank you. If we please excuse us just now, because of the change in programme, I'm just checking exactly what the schedule is. We're either going to go direct to our next speakers, or we're going to have a question and answer session with our previous speakers. So if you just allow us 2 minutes, I think that session that we've just had was excellent. I do apologise that we couldn't ask all the questions that came up through the forums, but we did our best, and I think it was a very interesting session. We're now returning to our local response, and we're going to go back to Dr. Grania McCann and Professor Nash Patel and respond to questions about for them about the local response to COVID, because as we can see, there's a good interaction between what we do locally and what happens nationally and internationally. And as Professor Ryan said, Dr. Ryan said, it's important that there is local governance over and response to the COVID disease on the ground. Professor Nash Patel would just like to call out a thank you to some people who've been involved in the local response to the COVID. So we'll hand back to them now. Thank you.
Thanks, Anna. No, I just wanted to make the point that I think I overlooked in my previous talk, which is that this pandemic, as Dr. Mike Ryan so lucidly and eloquently pointed out, has come upon a world that already was struggling with healthcare at the front line. So especially in the HSC, where we've worked for years, decades now, we were already overstretched, overstrained, and some of the teams that were involved in this transfer of patient care from SUH to Kingsbridge are people like Miriam McDermott, our waiting list manager, and on the other end, Jennifer McLaughlin, the general manager at Kingsbridge, and Mark Regan, the CEO. The lessons that this pandemic has taught us, I think, will also be of benefit to HSC Inc. in general, because it's taught us to be light on our feet, to look for resources where there were none, to create resources where there are none, and to literally collaborate in a symbiotic fashion where you take an institution and optimize its use. And I'm thinking of weekend work, evening work, all the stuff that's been playing around in the HSC channels for so long. And this particular virus has pushed that to the front line. So I think that is another benefit of this pandemic that I can see coming to the fore. So that's all I wanted to say. Maybe you might have questions for Gráinne, or any questions that come up from your end.
Thank you very much. We've got a question, just it links in with Mike Ryan's talk. So the question was, obviously at the end of that session, Professor Mike Ryan said, Dr. Mike Ryan said how important it was that there be time for staff to reflect and de-stress together regarding the challenges and perhaps the emotional challenges that they've met through handling and managing COVID in the hospital and of course in the community. But with regards to hospital, Gráinne, are there any, what are the supports that are in place, and are there any plans to have sort of post debriefing for the staff? Thank you, Gráinne.
I suppose we, yes, Dr. Liz Gettins and Teresa Donnelly and NMPDU actually have been doing a number of programmes over the past number of months to help staff in dealing with the stress of the environment that we've been in. And actually more recently then we've, both of them have just communicated out and got a high number of participants for a mindfulness train the trainer session, and the intention there would obviously to be to bring those skill sets right throughout the organisation. So I mean, what all those pieces in terms of Mike alluded to, reflecting, being kind to one another, being kind to ourselves, looking at what can we learn, what can we do differently going forward, and how do we support our staff and across the organisation are really important aspects. And the space to allow that to happen is actually very important, and giving people the time for that, and also from a management perspective also making the time for it to happen, because we're very much in an acute hospital, you're very much caught up in the immediate things that are always happening every day, and responding to those needs. So there does need to be a time and space to reflect on things and to look at how do we do more going forward. So I am confident that next year we'll have more wellbeing initiatives, and Pauline Kent through the Healthy Ireland is also looking at what initiatives we can bring forward into 2021. So.
Thank you, Gráinne. That's really good to hear as a member of the health service here in Sligo. There's another question coming around the vaccines. We heard that the vaccine programme is moving forward, and we hope that come 2021 there will be vaccine availability in Ireland. Are there plans being made by the hospital with regard to how staff will procure the vaccine, and whether there would be any sense that people will be obliged to have the vaccine?
Good question, and we don't have the answers to those questions just yet. I mean, the process is just starting at national level in terms of the vaccination programme that will be rolled out nationally. So obviously we'll be playing our role, whatever that is, as part of that vaccination programme. If there's a requirement to do something hospital-wide, we'll obviously be engaging in that.
In terms of another question around visiting, we know that this has been a challenge in the hospital in terms of managing COVID. How are we as a hospital balancing the emotional aspect of visiting and the mental health aspect in terms of, say, patients with cognitive decline, and also patients who are very sick and in danger of dying, versus the need to manage COVID? And is that a national strategy that we're following, or do we respond on a local level?
There has been obviously national guidance on the visiting restrictions. I suppose that's the most suitable term for it, because it is a restriction that have been in place. But there's local, I suppose, processes that we've been that we've had in place to deal with that. And we have a system whereby for end of life, for specific compassionate and care needs of patients, that visiting has been put in place, and there's particular, a mechanism. People get a pass that they will be given so that they can get to the ward freely on their arrival. So that's part of it. The other part of it then is where we've had the patient drop off and pick up collection service for their personal items. It's another aspect of it. And we also had a whole distribution of tablets and electronic communication tools in the earlier days of the pandemic. That was somewhat more challenging for us because Wi-Fi access, etc., in terms of using some of the tools. So it's been mixed results. One of the lovely initiatives that actually was very positively responded to was the Thinking of You initiative, and that was something that Linda Foley in our Consumer Services Department had the idea around, and it was where a family member could write a letter, send it, email it to the Consumer Services Department. They would deliver it to the ward where that patient was, and within an hour of that being launched on social media and other platforms, the department had numerous letters, and they proceeded not just to get letters but photos and all sorts of things from loved ones of patients. So that was a very nice, heartwarming response, and a very simple response at a time during the pandemic.
Yes, I think that was a really, really important and lovely initiative. Thank you for that, Gráinne. We have a question here relating to that maybe Professor Nash can respond to. It was about the public and private sort of response to COVID. The question was regards to HSE financing. Was there HSE finance that went into the dynamic whereby the Kingsbridge and the public hospital collaborated?
Yes, there was. So the background to the financing was, as I mentioned in my previous comment, even before this pandemic came, there was a connect between the public and private hospitals in terms of the National Treatment Purchase Fund, which used to or does tender out particular services. In the first wave, when the commandeering happened, the entire hospital, lock, stock and barrel, was taken over by the HSC at a fixed sum. But after that first wave and after the arrangement ended, which I think is around the 31st of July, we, Sligo University Hospital, opened an SLA, which was carefully crafted so that both sides were protected for specific services, for endoscopy on a very detailed, again, the teams, the IT teams, there were a huge number of people in the background doing this, and we created and have in place an SLA which is site and service specific, which serves both of us. So I think those are the sort of conversations that this pandemic has started, and those are the conversations which I think will help our patients going forwards, even in the time that the pandemic is relatively controlled. I heard Mike Ryan's sobering thoughts on that, but I think these two will run in parallel: the COVID pandemic response and daily healthcare. Because in the first wave, if you remember, everything had been locked down. Healthcare was not being delivered, even acute healthcare. So as we learn to live with the virus, those sort of SLAs will help us. So there is an SLA in place.
Thank you for that, Nash. I must say, while a lot of acute healthcare didn't take place, there was and continues to be access to rapid access testing for cancer and other services. And I put that out there because I responded. I had an acute healthcare crisis, which was responded to on the cancer front. So I think it's important that we're all aware that it was there, and as you say, it continues. And I experienced that private-public dynamic, which was very helpful to my own care. So I think, as you say, Nash, this has been quite helpful. But it's interesting to hear how the economics of that were spread. I think that we unfortunately are coming to the end of our time for questions. Is there anything else either of you would like to add before we move on to our next speakers?
I suppose I'm just going to have a final word to acknowledge that the key thing in terms of how we've survived through all of this has been the staff and the team in the hospital and our surrounding community and people within our community. But for me, in terms of the staff and those working together every day, supporting each other and cooperating and adapting to the changes that we've had to face has been of huge importance, and has been what has really helped us get through this period, and will continue to help us to get through this period. Thanks very much, Anna.
Thank you, Gráinne. Thank you, Professor Nash. We will now, so after both of those interesting talks this morning, we're now going to move on to hear from Dr. Catherine Finan, the consultant and respiratory physician in Sligo University Hospital, and Dr. Wouter Jonker, the consultant anaesthetist. Dr. Finan is going to talk about the medical response at SUH to COVID-19, and Dr. Wouter Jonker is going to give a talk given a tidal wave or a tsunami preparing Sligo ICU for COVID-19. Just in terms of timing, because we've moved away from the schedule, this section of the conference will go from now, which is 10 to 1, until 1:20. So we're going to have a presentation by Dr. Finan, followed by a presentation by Dr. Jonker, and after both those presentations, we will have a time for questions and answers. So thank you, Dr. Finan.
Thanks, Anna. And I'd like to thank Anna and Anita and the team from the Sligo RAF for asking me to talk today. I think in 10 minutes, it's extremely ambitious to try and cover challenges, responses and learning for the COVID-19 pandemic. And so I'm going to just try and encapsulate some of the feelings that I had around it. Some of the pictures and slides that I have will have been touched on by Gráinne and by Nash in their talks as well. So we'll just try and move through this nice and quickly if we can. So in March 2020, as lockdown settled in around Sligo and Ireland in sort of around St. Patrick's Day, the hospital became unseasonably and unusually very quiet. This gave us a little bit of time to sort of think about our strategies and processes for the hospital, and we were able to implement some changes. We changed our entrance to a side entrance. The hut arrived, the emergency arrivals unit arrived, and took up residence in the front of our hospital. The ED and the AAU at this point were able to establish pathways, red, green, amber, as Dr. Patel was talking about, to try and keep our patients and staff as safe as possible. There's been a significant amount of construction around the hospital and a more positive development recently of a more permanent emergency department in the space adjacent to the hut. The processes around ED and outpatients changed. We managed to move our paediatric emergency services to our outpatients department, and some of our outpatient services went across to Kingsbridge. And as I said, we moved our entrance to the hospital to a temporary entrance, and everybody filters through this to try and get to their point of work or our outpatients appointments within the hospital. At this time as well, our wards slightly emptied out, and this gave us time to sort of think about, with our infectious control pathways and our services, to try and work out where would we put COVID-19 patients, where would we put their contacts, and how do we keep everybody safe. And it was very hard to anticipate how to do this because we really didn't know what was coming down the track for us. We started with some education and learning. We spent St. Patrick's Day teaching our non-GIM colleagues how to manage acute GIM issues. Our rheumatologists, neurologists, microbiologists, obstetricians all attended for this and had some upskilling. It was a very interesting St. Patrick's Day. Education continued throughout. In empty rooms, we used Zoom. It took us a while to get used to this platform, and and also to be able to create some interaction on these platforms. It's very hard to speak to empty rooms and to try and teach to empty rooms. Our NCHDs stepped up. They taught each other how to use non-invasive ventilation, high-flow nasal cannula oxygen, Trelegy ventilators, and we did this in cooperation with our very highly skilled respiratory nurses and nursing colleagues. These two pictures were taken in March 2020 before masks were mandatory on our wards. We developed pathways so that the NCHDs could identify and manage patients who were deteriorating acutely in a very safe and planned manner. And this we worked out with our ICU colleagues. Communication became a huge issue, and not all of our interventions would pass QI PDSA cycles, but problems were identified and solutions came up with. We recognised that we couldn't communicate very well, so in the emergency department they used a two-way walkie-talkie system for their resus room, and on the wards, particularly on Medical South, we asked for window panels to be put into our doors so that we could see the monitors at the end of the patient's beds and not have to go into the rooms. And this protected both staff, it limited transit in and out of the rooms. We established an ICU meeting on a 2 or 3 times weekly basis to review patients in the intensive care unit and discuss what medications and treatments could be thought of for those patients. This is the thinking of you development that Grania spoke about from the consumer services, and patients and families found this very useful. This is the drop-off and collection point for patients and families to deliver and manage services for patients and families. And again, this is extremely helpful for patients. It creates a contact for them with their families. PPE. So we worried about PPE. We worried about whether it would be there, whether it would be the right quality, whether we'd be able to use it appropriately. And we know that the finance and purchasing teams worked extremely hard in order to anticipate and provide adequate PPE for us. There were some interesting times in learning how to use this equipment properly and in appropriate manners. We had a lot of learning on different wards, trying to figure out how to but manage our use of PPE appropriately, because we were concerned at the huge amounts of it and the volumes that we were getting through of it very quickly. The next problem then that developed as a result of that was managing stores and waste. All of the PPE that comes has to be put in places on wards and stored. So we had to use areas that would have been for families and patients in order to try and manage our stores. This is endoscopy. Endoscopy had to change completely. In fact, it stopped for a significant period of time only for emergencies, and now it's back up running again with new safety practices and policies. Again, sort of managing our waste has become a significant problem, and the numbers of rounds to try and clear waste from the wards has increased. It's horrifying how much waste we've developed across this time, and I suppose I think there'll be new processes involved to try and help us manage this in a little bit better going forward. Every place across the hospital has had to put in new pathways. This runs from radiology to all different areas of the hospital. In radiology, we've had to think about COVID and non-COVID pathways. We've had to think about trying to put in cleaning and also maintaining a service to patients who are outpatients. Pharmacy has provided a huge amount of knowledge and education with all around the new medications that we wouldn't have been familiar with using. Management has provided a huge leadership role for us and kept us all together, working as a team with one goal in mind, to try and keep us as a healthcare team safe and our patients as safe as possible. All areas of the hospital have come together in order to try and facilitate this work as one team. And I think that's been a significant and quite inspiring part of this process that we've been through. And I'm very proud to have been part of the team that has worked this in Sligo University Hospital. Our patient flows have, I'm sure, caused headaches and new grey hairs for all of our patient flow team. And, you know, this is constantly a difficulty. As I mentioned, education carried on. We've learned how to use Zoom, we've learned how to unmute, remute, share screens. MDTs have continued to occur because, you know, as Anna mentioned, cancer still happens and patients still need to be assessed and managed and treatment plans worked out for them. Dramatic changes have occurred within the medical department. Handover, which had been a bugbear for all of us for quite some time, has now dramatically come in. 8 o'clock Zoom meeting, everybody connects into it. and it seems to be rolling without any difficulties. Other MDTs have altered how they work in order to try and communicate and make things as safe as possible for patients and staff. Gráinne mentioned outpatients, and nowhere has the change been more dramatic than in outpatients. It stopped, it started, it became electronic, now virtual, now a combination of everything. It's still not clear to me how we run our virtual clinics on a safe basis, but with the support of our nurse specialists and other colleagues, we try and work this to make it as easy for patients and staff. A lot of people were redeployed into other areas, and we worked with Empower to manage and assess patients at home, providing them with pulse oximeters so we could keep an eye on them. The microbiology lab is an area that I'm not particularly familiar with, and it has worked above and beyond in the last 4 to 9 months. They've developed and validated new tests for SARS-CoV-2. They've been testing 24/7 since the 1st of April. They are now currently doing 4 runs of the C gene on a daily basis. The process is extremely complicated, and I'm not even going to try and explain it to you. But Anna has provided with a couple of pictures from the lab and the team that work there on a regular basis, and we're very grateful for them to be able to have done all of that work and provide us with the very quick results that allow us place patients appropriately, put them into the intensive care unit, operate on them where they are COVID not detected, and the lab has allowed the hospital to run on a regular basis. These are the tests. This is the testing that they've done over the last 9 months. Initially, we were providing the testing for the community, and then that moved up to central. Our peak was obviously back in March, and a more recent peak at the beginning of November. These are the positive tests that we've had, and we run at about a 3% positive test rate, which compares reasonably well nationally. Anthony Bresnan already showed this slide. It's the COVID-19 notifications across the HSE Northwest, and our hospital admissions track these notifications very accurately. This is a very short graph about our admissions. We've had 4 in ICU in the initial peak and 1 in ICU in a later peak, and the medications that we've used across that period of time. As I said, I'm very proud to have been part of the team that has been part of the COVID response, but I'm exceptionally glad that this view is within my 5K limit. Thank you.
Thank you very much, Catherine. That was really interesting, and what a phenomenal set of pictures that you have taken throughout to record the journey through the COVID pandemic so far. Really interesting to see. And now I think we'll move over to Vota, and following that we'll have the questions. So Jonka, Vota, if you're there, we might, or the other way around, sorry, we might listen to you now.
Thank you very much, Anne. Yes, I've just been listening to all the speakers today, and it's been such a comprehensive overview of what's happened in Sligo. I'm just going to try and focus what we did in the last 9 months in a 10-minute slot on how we prepared ICU for COVID. And I have to say a lot of this is actually a solitary view, my view of what happened. But sometimes when I talk about we, I refer to you, I, her, she, them, they, and how we actually tackled this. So I'm going to just go through these 4. This is not a formal after-action review. This is just how I saw things happened and could recall. First, I'm going to cover what we imagined might happen and how that imagination changed to expectation. So what we expected may happen, and what we say we did and what we actually did in preparing the intensive care for dealing with COVID. I would go as far as to say initially, when this kicked off in January and February across the other side of the world, we imagined maybe in Sligo nothing was going to happen. We didn't really see the SARS pandemic in the early 2000s. Most of us would have gone through the swine flu incidents in 2010, and I myself felt no, it's on the other side of the world. But that slowly started changing as it became more global, as called by the WHO, and further later pandemic. And as we started to see more and more news reports of mass hospitals being built, and it really actually started to hit home when the Lombardy area in Italy was so severely hit. And we saw those very evocative images of army trucks with coffins. And what we imagined changed. And I think we started realizing with the healthcare system in Ireland, it was already creaking at the seams. There was a threat that it would have been overwhelmed. There was a threat that tsunami might hit Ireland, the COVID tsunami might hit Sligo, and that we had to prepare. It became real when the first cases in Ireland was reported, and we started to say, okay, what do we expect might happen? And it is mainly a capacity. Concern was around capacity, ICU, ability to isolate patients. So in February 2020, there was about 250 critical care beds in Ireland staffed and opened. This is less than half the European average on critical care beds. Very soon in March, some funding was allocated to critical care units and additional beds were opened, but only brought that 250 to about 285 beds nationally. In Sligo, we've been struggling to even staff our 5 funded critical care beds, and with that additional funding, it went up to 6 critical care beds. Unfortunately, we were dealing in international demand for critical care staff, and has never really been able to staff it up to 6. And it was purely due to the during the containment phase, when all elective surgery and outpatients were stopped, that we were able to potentially increase our critical care capacity to over 12 patients on level 8. The other areas where we had a problem with capacity is staff. As I mentioned, the redeployment of staff was needed from theatre areas, from outpatients, day services areas, to be drawn into intensive care where they could actually be upskilled or refamiliarized from staff who had previous critical care experience. We expected that we might run out of PPE, we might run low on PPE, we might not have any. We're not going to go too much into that. It was already covered today. And one of the big things and concerns for us as intensivists and anaesthetists was O2 oxygen requirements and equipment. We had to work with our engineers closely to look at the capacity of the hospital to actually deal with high demands on oxygen, and had to do demand testing on the system to see if our oxygen system could actually cope. Fortunately for Sligo, recent investment and upgrading of our systems allowed that to happen. We realized that we wouldn't actually have enough critical care beds, ventilators, infusion pumps, physical equipment to actually deal. And in spite of receiving equipment distributed from national purchases, it wasn't always the right equipment. Due to the capacity problems and the realization that demand was going to be more than supply, we knew and expected that very difficult ethical decisions would be made and may need to be made at some point in time. So what do we say we did? To look at these capacity things, we had to work out search plans. We had to reconfigure certain areas in the hospital. Dr. Finan already spoke about what happened in other areas. In intensive care, we had to look at how we actually go from one negative pressure isolation room to being able to isolate more patients. So structural work had to take place. Access control into the unit and out of the unit had to be controlled so that we could actually maintain negative pressure areas in the intensive care. We had to move our general ICU into the general theatre recovery area, had to actually set it up in there. And for that reason, all elective and emergency surgery had to move down to level 6. As this reconfiguration was taking place in the end of March and April, it was a huge undertaking to actually do this swift shift over from level 8 to level 6 while maintaining emergency and urgent surgery. And we were actually able to do it purely because of staff input coming in on weekends after hours to move and get things ready. We would also say, well, we did a lot of education. The mass of information and news, media, HSE, was WhatsApp groups, journals that were published on Sky News and CNN before they were actually published by the journals was really hard, and we actually had to educate ourselves and learn what is evidence, what is not, what is just going to be changed in a week or two. As clinicians, we had to familiarize ourselves with medication not often used in intensive care, the antimalarials, the immunomodulators, antivirals. We also had to look at previously well-established practices which was being challenged. We had to re-look at the use of non-invasive ventilation, move over to earlier intubation than we would normally do, and then look at other challenges to our base knowledge already. There was a lot of collaboration in the hospital between departments, but also with the hospital, particularly in IT Sligo. There were developments with engineers and departments here to look at developing basic ventilators, CPAP hoods, and so forth, because there was a real shortage of supply, and we were anticipating that would reach capacity. So what we actually did, we did a lot. In one word, I can say we basically coped. We treated, although our numbers in intensive care in Sligo was very low, we were very fortunate in the event that we didn't actually get a huge breach of our ICU capacity, as was experienced at other intensive cares in Ireland. In total, over the time, we had 8 patients admitted to intensive care, 3 of which was invasively ventilated, 3 that was managed on non-invasive ventilation for their stay, and 2 further patients who were admitted to intensive care for a non-related COVID illness, but actually was COVID positive. We also learned that the patients who are admitted for invasive ventilation will spend much longer than general patients in intensive care, and our average length of stay for these patients was 4 to 7 weeks. Those who were non-invasive were obviously in a better point and had shorter length of stays between 3 and 10 days. What else we've done is we've actually looked at how we can develop our unit. The isolation capacity in Sligo has been known to be way below what we should have. So development and design has been done to increase the ICU isolation capacity as a new extension on the intensive care, and that will hopefully start with building works early in the new year. And that will bring our isolation capacity up to 5 intensive care beds. We also hope to then increase our critical care capacity to 10 critical care beds, which would fit in with what was done on assessments in 2014. And as a final point, I think to cope, we had to rely on one another within our department, within our specialties, within our colleagues in other departments. And it was just emphasized today again how dependent we are on one another to actually have been able to get through this up to this point. This is a friend of mine, Owen Keller, is an anaesthetist. He's currently working in the UK, and I think at times as we've been going through, we feel that we're just on this staircase, a never-ending staircase. And I do think, as stated earlier, we're not through this. We're in it for the long run still, but I do think we shouldn't let a crisis go to waste. One thing that I've learned from this is we can't accept substandard in our day-to-day. We have to keep the energy going, and when this is all settled back down, look at what could have been done better, change our infrastructure, change how we operate, and very importantly, how we look after one another so that we actually make a better health system when this is all over. Thank you.
Thank you both for those fascinating talks that took us through the really big changes that have gone in through Sligo University Hospital, and also the emphasis on how the individual teams have all been vital to bringing together the response to COVID. And as Dr. Jonker emphasised at the end, also how important it is for the teams to work together and rely on each other. And as you say, hopefully going forward, that will be something we can develop. We've had some very positive feedback online of people appreciating the talks, so thank you very much. One of the questions that's come in is, which maybe both of you, one of you could answer, and then the other one is, what might you have done differently in retrospect than actually you did this time? So in essence, the same question that you were saying at the end of that talk, Dr. Jonker, what have we learned that we might do differently in response to a future emergency or pandemic?
Well, Anna, I think actually what I've learned is that previously in the HSC, I have found that change is extremely difficult and very slow. And so what I found in the COVID thing is that actually change happened really quickly, and we listened to people, problems were identified pretty quickly, and solutions were implemented around that. It was nearly like we had our own autonomy back again, where we could decide this is a problem, this is the solution that we've identified, let's implement it and go with it, rather than waiting to say, well, what does SAILTA think about that? What does HSC Central think about that? And then for it to have to come back to you. So I don't know that differently I can identify in particular, but I can certainly say it was a different experience.
Yeah. Yeah, I see how you so what you're saying is that the way that we responded was very localized, if you like, rather than going back to the national levels or local levels for small decisions. And perhaps that's something we can take forward potentially in the future.
Yeah, I think so.
Thank you.
Thanks for that question. And yeah, I think one of the things that we've seen in the last couple of months is how the disconnect between clinical and management can actually be removed. And I think that's often they say they don't want to, it's a no, it's a yes, and it seems that the communication and the connection between management and how our hospital is run and how the clinical side is being performed, that is not connected up. And I think if we could get those systems, the meetings and the collaborative meetings where we had all the policy makers and the decision makers all around the same table is very constructive.
Yeah. Yes, they were. I have been at some of those meetings, and it's fascinating, isn't it? You really feel the buy-in when you as a clinician are there meeting with the management and able to communicate quite openly in both directions. I think it's very useful for the decisions we've made. And I think, yes, I agree, it would be great if that kind of communication carried on into the future. Another question's come in. It's around the ethical challenges of COVID, which we read about in the papers. And it's on a day-to-day basis. Did you meet with any ethical challenges in terms of treating patients, and how did you manage them? So I leave that to both of you.
Well, so Anna, I suppose yourself and Dr. Hickey and I think Miriam O'Sullivan very quickly had put a group together, to an ethical group with that came up with a very manageable process for us to assist us in making difficult decisions. Personally, I think that the difficult decisions that we thought were going to be out there in terms of rationing care and having to make decisions about who could or couldn't go to intensive care actually didn't realise, fortunately for us. I think our community colleagues managed the outbreaks in the various nursing homes with the support of palliative care and the community teams exceptionally well. And I think that the decisions that we were able to make, notwithstanding the restrictions about visiting and that, we were able to bring families in to the people that we felt that they really needed to be there for those times. None of the decisions about when people are dying at any time in a hospital are easy decisions, are easy places for either the doctors, the staff, the families or the patients themselves. So I don't know that the decisions throughout this were very different to the decisions that we would have made at any other time.
Yeah, and I would echo Dr. Fine's point there, because we make difficult decisions all the time, and what this pointed out again is the foundation that we go in, the processes that we go through prior to COVID is what the same processes that we went through during COVID. And we have been fortunate that we didn't get a tsunami, that we weren't put to get to that decision. But I think things were put in place that if it got to a point like that, that it wasn't up to one or two individuals to have the decision. That again, this is a group think, it's a group support, and that by standing together, we can make decisions together.
Yes, thanks. That's interesting, and I'm glad that we didn't have to meet those terrible decisions that we were forecast to make. I hasten to add that I was part of a small group in the ethical in the ethical group. I was part of one of many who were involved in that writing up a protocol. With regards, we have one more question here, and I think time-wise it's probably our last question. It harks back to the challenges of working with COVID. We know that both of you were in the higher risk end of managing COVID, in that it's respiratory transmission. ICU involves a lot of procedures that involve the airways, and respiratory by definition is a high risk specialty in this COVID era. How did you manage the pressures and the fears, particularly at the beginning, and what advice would you have to colleagues as we go forward in this era?
Well, I think we soon realized that the burden of this pandemic was going to be on healthcare workers. Then in healthcare workers, there were going to be certain specialties and certain groups that were going to be at a higher risk of it. And we did rely a lot on our critical care societies and Association of Anaesthetists and reliable information that came from them on how to actually protect ourselves. Yes, it has been difficult. It continues to be difficult. It is, and I think what was the biggest challenge in the start was the change of guidelines. Every couple of days there were change of guidelines. There was an expectation of staff, especially to anaesthetists in theatre and ICU, that we'd know what to do, but it wasn't necessarily that we knew. We were also just familiarizing ourselves with guidelines and following infection control policies and guidelines to actually familiarize ourselves. I think the biggest burden I saw, as a clinician, as a doctor, it was easier in the sense that I could go into areas put on the PPE, and I could spend my time with the patient and move away. And I did see it on the critical care staff who were in PPE for hours at end, really affecting them. And I think I have to take my hat off for staff in our unit. We try to limit the amount of clinicians that were looking after the patients in intensive care so that we had more continuity. But it has been difficult, and I think we all learned a lot on how to actually protect ourselves and others.
Yeah, I think I'd echo what Wouter said there. The structures, that the flow within the hospital changed, and I think that the initial decisions around that was to try and protect people as much as possible and keep the red and the green areas as separated from each other as possible. I think the advice coming from both WHO and nationally initially was quite confusing, and it did change on quite a regular basis. It's much easier now. You wear your mask, you wash your hands, and you keep doing your hand hygiene on a regular basis. If you know that you're going into a high risk zone, you wear your PPE. If you have any concerns about going into a zone, you wear your PPE, and you keep washing your hands and wearing your mask.
And I have to say, I don't think we would have been able to work the way we did if we didn't have the rapid testing and laboratory support. Very soon we realized that urgent surgery had to continue. We couldn't wait for COVID results if urgent surgery had to proceed. And we just, once the PPE or the shortage or supply issues were resolved and it was available, it made it much easier because the stuff was there. You could use it. You didn't feel bad for using it for lower indications. And I think the stock was the big thing, to get it in and have it available.
That's really interesting. Thank you both, and thank you all four for the talks that have come from Sligo University Hospital today. We've had positive online comments, people being struck by how cohesive the overall hospital response has been, people really enjoying the talks that have been presented, and so thank you. I also thank you all for your efforts. I think it's been remarkable what has been done in Sligo University Hospital, and I think where you talk of your practical response to the COVID, and don't emphasize fear is remarkable. I think the emphasis on continuing management using our PPE and hand washing and the protective measures is really important. So thank you all for your personal efforts in response and for the talks you've given today. Thank you. Going forward now, we're entering a lunch break. You have 20 minutes out there to go and eat and drink before we restart at 13:40. At 13:40, we have Professor Luke O'Neill, who is going to come and give us an update on the COVID situation at the moment. And I know he's a very dynamic speaker, so I look forward to that. That will be followed by Dr. Francois Romain, who is the clinical development. He's a clinical development of vaccines GSK with a focus on development in developing countries. And again, I think this is really interesting talks, especially as we move forward into a new era of COVID where vaccines may be a possibility. So I look forward to you joining us back at 13:40. And in the meantime, the posters will be rotating on the screen. So if you want to take a look at the posters, you'll be able to link to them on our Research and Education Foundation website in the future. So enjoy your lunch. Thank you and goodbye for now. Just to let you know, we're getting ready to start the second half of the conference. The next speaker due to speak is Professor Luke O'Neill. He's just he's joining us technically, and we're just waiting for him to meet with us. He's scheduled to come on 5 minutes later than we anticipated at 14:45. So, sorry, 13:45. So in another 5 minutes, we expect to have Professor Luke O'Neill with us. Sorry for the delay. Please continue to enjoy the posters until he joins us. Thank you.
Hello, this is François Armand speaking. Can you hear me?
Yes, Francois, I can hear you. Can you hear me?
Just to say that I can hear you, thank you. Sorry, I was on mute. Just to say that I'm connected now.
Great, thank you so much for that. That's really reassuring. Francois, we have a little challenge with our connection with.
Yeah. Seems that, can you hear me now? Sorry, I cannot hear you, Anna.
Sorry, we have a small challenge with our next speaker. He may be running late, so we may ask you to come early to present, but we'll let you know. Is that okay?
That's fine, I'm ready.
Thank you.
Now if you wish.
Your family.
Thank you, everybody, for waiting for us there. We're delighted to welcome you back to the final part of this conference from the Research and Education Forum in Sligo. We would like to thank Francois Romain for coming to present to the conference and for agreeing to speak early due to a glitch in technical connections. So thank you, Francois, for coming and speaking early. Francois Romain is the Senior Director of Clinical Development for Vaccines for the Developing World in GSK, and we're really looking forward to what he has to inform us about vaccine development going forward. The title of his presentation is GSK Vaccine Efforts on COVID-19. Thank you, Francois.
Okay. Can you hear me?
Loud and clear.
Okay, good. Okay, thank you. So, okay, very much, because I could not see anything from the display, microphone and so on. So, okay, good that you can hear me. So, I mean, thank you very much for inviting me to this conference. Indeed, my name is Francois Romain. I've been involved at GSK for several years. I joined GSK in 2007. And I've been working in different programs, including pandemic flu programs, malaria, tuberculosis. I've been more recently involved in the supervision of our COVID-19 vaccine collaborations. Well, you know that the world is really turning hectic with this COVID-19 pandemic, and in particular for the development of vaccines. And there are many manufacturers involved in that. And so the objective of my presentation is not to address this highly competitive landscape. I would like to share with you actually one of the approaches, which is the one of GSK, in which I'm working for, contributing to this COVID-19 vaccine development effort. And I hope that with this presentation, you will understand a little bit more where basically, and including GSK, we are coming from, where we are for the moment, and what are the hopes for the future. So my presentation will be divided into 5 parts. The first one, I will go back to some background on the SARS-CoV-2 virus and how basically it relates to potential insight for vaccine development. Then I will turn into what GSK is doing. It is one approach between many others, but what GSK is doing in terms of COVID-19 vaccine development. And you will see that GSK is actually, giving access to its pandemic adjuvant, so namely ASO3, to be used in the development of the many protein-based vaccine approaches. I will share with you a little bit of, early data that we could collect and that are published now from this collaboration. And I will also speak of what GSK is doing in terms of therapeutic approaches for fighting this COVID-19 pandemic, even though I'm not involved in these efforts. I mean, just to prime you a little bit and just to say that we are not only working on vaccine, but also on treatment. So first, the SARS-CoV-2 vaccine. Unfortunately, I joined this meeting late and apologize for that. I could not do it before. I'm not sure how far you have already discussed and addressed, this this more, say, fundamental question, virological question. But SARS-CoV-2 is essentially an RNA-based enveloped virus. And like many other RNA-based enveloped virus, it displays an important antigenic component, which is called the spike protein. You can see that on the left of the slide. So it is the spike or S antigen. SARS-CoV-2 also contains another important antigenic component, which is the nucleocapsid protein, so the N protein inside of its body, I would say. And so the S protein, the spike protein, is very important. It's composed of two subunits which are engaging, in sequence for virus attachment to the ACE2 receptor, so a well-known receptor in human physiology, and then into, entry of the virus in the cell where it will release its genetic material for further replication. So obviously, the spike protein is an important determinant, and we will see that it will be very, very important for vaccine development. Well, I mean, despite the fact that SARS-CoV-2 is an emergent pathogen in humans, I mean, it shares similarities with other viruses, RNA enveloped viruses like, influenza, like Ebola, HIV, RSV. It cannot be taken for the same, of course, but I mean, it shares similar features, similar characteristics. And so we had some insight at the beginning of vaccine development of where to go. But at the beginning of the pandemic, it wasn't clear, what would be the actual immunity to infection with SARS-CoV-2. And, data have been accumulated, extraordinarily fast over the last months on this. And we now know that actually after SARS-CoV-2 infection, you developed both humoral, so antibody and T-cell responses to the infection. So antibodies against the N protein and the spike protein are detected as soon as after 1 or 2 weeks after the onset of initial symptom of infection. So we know that these antibodies are there, but it wasn't clear, how long they would sustain in time, how much they would associate to potential protection to reinfection. And actually, there have been 2 recent articles published last week or pre-published last week on this, and it seems that antibodies against the spike protein are able to last for more than 6 months in some cases from studies that have been recently published. The memory B cells, so the memory to infection with SARS-CoV-2 is also long lasting, so it lasts for more than 6 months from this recent data. And it was also shown that actually these antibodies were associated to some level of protection against reinfection in healthcare provider after initial infection. So as long as 6 months after initial infection with SARS-CoV-2. This was described in the population of HCPs of more than 12,000 people. So it is quite important data, and obviously enough, it also sort of trace a path or give insight for where to go in terms of vaccine development. We also know that SARS-CoV-2 infection induces T-cell responses. So we see SARS-CoV-2 specific CD8 T cells developing in about 70% of patients. Virtually all patients develop SARS-CoV-2 specific CD4 T cells. And interestingly enough, you may be aware that actually this CD4 T cell immunity seems to be present, even if, in absence of SARS-CoV-2 infection, so before infection. So this may be the reflect of actually cross-reactive immunity against other circulating coronavirus that basically humans know quite well since years or decades. It is, however, unclear what will be the effect of this kind of priming upon, vaccination, and this will probably need to be further evaluated later on. So as I told you, the S protein, so the surface protein, is a very important antigen for vaccine development. We know that it will be an important component, and there are several approaches to develop vaccines based on this antigen. among which protein-based approaches. So you have certainly heard about these new technologies like mRNA technologies or, vector-based technologies. GSK is more looking after, more, say, more known or long-lasted, say, technologies like protein-based technologies, and these antigen components can be used as, antigen-based subunits, so like fragments of the protein that are purified and then, used for vaccination, or under the form of virus-like particles, for instance. But in themselves, I mean, this vaccine component are poorly immunogenic, and this probably due to the fact that SARS-CoV-2 is an emergent pathogen for which the human population does not have a very broad pre-existing immunity like it would be the case for influenza, for instance. So for this emergent pathogen, it is strongly believed that, in addition to these antigenic protein-based components, you need to add what is called an adjuvant to potentiate vaccine-induced immune responses. And so GSK is involved in this vaccine development effort, and also in developing therapeutics. I will speak more of vaccine development as I told you, and is working in partnership with different antigen manufacturers, different companies, which allows GSK to have a relatively broad geographical imprint, since these different partners are located in different places in the world, and we believe that in itself it gives more chance to potentially have a true effect, a true impact in terms of pandemic preparedness. And so under these sort of 4 pillars, we have 2 axes. Again, I'm repeating myself, but on one side, GSK is contributing to the development of COVID-19 vaccine. And on the other side, it is also contributing to the development of treatments, essentially through the development of monoclonal antibodies against SARS-CoV-2. So what is GSK doing actually in terms of COVID-19 vaccine development? So GSK is actually collaborating with other partners, with other manufacturers. GSK is not developing its own vaccine on its own, but it is giving access to other manufacturers to its pandemic adjuvant, which is called ASO3, so that ASO3 can be indeed added to the potentially different protein-based approaches. So it is important. I mean, this collaborative, context is important to have in mind, because basically GSK is not directly, driving the development of this vaccine. It is giving access to its adjuvant, and these are the respective sponsors who will take actually the final responsibility from a regulatory standpoint, for instance, for the development of these vaccines. And GSK has been approached, or has approached many manufacturer candidates, but I would like to put the highlight on these 3 ones here on the slide. You see that it collaborates with Sanofi, another big player in vaccine development. Sanofi is developing S protein-based antigen based on an insect cell technology. Basically, the protein is developed through this insect cell-based system. Sanofi is now in phase 1/2 of its clinical program. Data are about to accrue to be available to potentially enable the next phase of this clinical development. GSK also collaborates with Clover, a Chinese biotech, which is also developing its S-based subunit vaccine using its own trimer technology, which is an internal component to the vaccine to really make sure that basically the vaccine will adopt an adequate 3-dimensional conformation, which is very important for stimulating adequate, strong, and qualitative immune responses. And Clover is in phase 1 for the moment. And finally, Medicago, which is a Canadian biotech, who is developing a plant-based self-assembling virus particle based on S protein assembled in trimers. So it is using a tobacco plant to basically produce these protein-based antigens. Medicago is a little bit ahead since it has started its phase 2/3 efficacy trial a couple of days ago. I mean, I just wanted to highlight this. We, as you know, we are all living totally unprecedented times. And it is also basically the case for vaccine development, where you can see that big competitors like GSK and Sanofi actually collaborate together for the same sake, basically, which is the development of a safe and effective COVID-19 vaccine. So, ASO3, what is it about? What is it about, and why ASO3 for this vaccine? So GSK has accumulated many data on ASO3-based vaccines, and essentially from its pandemic flu vaccine experience over the last years. And from this data, we know that ASO3 has the capacity to enhance the immunogenicity of the native antigen, which in this case will be SARS-CoV-2, which in our past program were, pandemic flu antigen. So we know that it will enhance immunogenicity, which in turn will be a very important asset in terms of, pandemic preparedness, because if you are able to induce stronger immune responses with, lower dose of antigens, you can produce more vaccine and distribute more vaccine. We also know from past data that ASO3 is able to induce response not only against the vaccine strain, which is included in the vaccine, but also against genetically distant strain, which may be an advantage in the context of this SARS-CoV-2 vaccine, which we know is, evolving genetically over time. We have also accumulated, a lot of data on ASO3 adjuvanted pandemic flu and also simply seasonal flu vaccine, and we know that from this data, these ASO3-based vaccines are coming with an acceptable safety profile. And importantly as well, I mean, GSK has the manufacturing capacity to produce the necessary volumes of ASO3, which will be demanded in the context of this pandemic crisis. So this is in summary the assets, why we propose basically our collaborators to use ASO3. We will go into it a little bit more in depth now. Just before that, just to show you what ASO3 is, it is a picture of ASO3, a microscopic picture of ASO3, which is an oil in water emulsion-based adjuvant that contains two important immunostimulants, namely squalene and alpha tocopherol. So you see what it is in real, I would say. So, I mean, how does it work, ASO3, and based on what we have observed so far? So we know that ASO3, when it is co-administered with the antigen, I mean, when it is co-localized at the site of injection, basically this ASO3 will actually help to induce a transient activation of the innate immune system. So it will trigger basically the innate immunity in a transient way, but we know that this initial transient triggering of the innate immunity will be very important for, the later development of strong and qualitative immune responses, so namely antibodies, humoral immunity, and also cell-mediated immunity, CD4 cells in particular, because of the protein-based antigenic nature of the vaccine, we do not expect actually the induction of CD8 T cells, but CD4 T cells, we expect that. And this slide is showing you actually the potentiating effect of ASO3 in terms of immunogenicity. So it represents actually, the immune response, the HI antibody responses in subjects who were administered with an H5N1 pandemic flu vaccine twice at day 0 and day 21. So you see here the HI antibody response after the first dose at day 21 and after the second dose at day 42. The response are expressed in terms of seroconversion rate of these HI antibodies, which is actually a regulatory parameter for basically authorizing the use of this flu vaccine in the population. It is used for registration. And what we can see is that as after the first dose, so the ASO3 adjuvanted formulation in red elicit higher immune responses than the non-adjuvanted formulation, which are depicted here in blue. And so it is not only speaking about the fact that indeed it is potentiating the immune response, but also that even with very low dose of antigen, like here in this case 3.75 micrograms, so the lowest dose, we have very high immune responses. And so in turn, it allows this important antigen sparing benefit that we are expecting from this ASO3-based vaccine. These were for antibody responses. Now, let's have a look on CD4 T cell responses, and we see the same phenomenon here from the same study. We see that with different dose of antigen, when it is used with ASO3 in red, we have higher CD4 T cell responses over time. I mean, it is from before the vaccination until month 6 after the vaccination, and we see higher response, CD4 T cell responses, when you use an ASO3-based vaccine as compared to the non-adjuvanted formulation in blue. I was speaking also of the, the fact that ASO3 is able to induce broad immune responses, and it is exemplified here in this slide. So when you have a look again on the seroconversion rate of HI antibodies against strains that are not included into the vaccine, so namely you see Indonesia, Turkey, or Anhui strains, which are H5N1 pandemic strains, which are different from the Vietnam strain within the vaccine, we elicit immune responses in each case, contrary to what is observed with the vaccine without this ASO3. So again, we believe it is a potentially strong asset in the context of developing a SARS-CoV-2 vaccine, which SARS-CoV-2 is deemed to be, genetically variable over time. Now let's speak a little bit of the quality of the antibody response. Here on this graph, I mean, you should see all these plots. So in red for the ASO3 adjuvanted vaccine and in blue for the non-adjuvanted vaccine. So each time the plot is, I mean, the lower the plot here, the higher the binding affinity to the antigen, of the antibody to the antigen is. So here we can see that indeed after ASO3 adjuvanted vaccination, we obtain better affine antibody binding responses when you use ASO3 as compared to without adjuvant. So strong immunogenicity, potential for antigen sparing, a good quality of the antibodies are certainly, characteristics that we could obtain from our data from our pandemic flu vaccines over the last years. Importantly enough, I mean, ASO3-based flu vaccines, so be them seasonal or pandemic vaccine, also demonstrated acceptable safety profile during clinical development. This is based on data collecting more than 55,000 vaccinated subjects, where we see that overall there were no, problematic safety signals identified, and that the vaccine was generally well tolerated. Of course, the vaccine is the ASO3 adjuvanted vaccine is reactogenic. People who receive this vaccine do experience pain at the injection site and potentially other local or systemic vaccine-related reactions, but which are, say, not unexpected in the context of vaccination. And so overall, the profile was deemed to be good from clinical studies, but also from post-marketing studies, where several studies were conducted, in particular in the context of, the H1N1 ASO3 vaccine. There were several studies looking at, different safety outcomes, or evaluating the benefit-risk profile in different populations, like, for instance, pregnant women or immunodeficient people. For all this population, the vaccine was continuing to have and to be considered having an acceptable benefit-risk profile. So many studies were conducted after, indeed, during pandemic H1N1 days, and including also studies concerning new emerging risks, safety risk, and you may have heard of this narcolepsy risk that was actually identified with one of the H1N1 ASO3 vaccine, the Pandemrix vaccine. It was actually some cases of narcolepsy were reported after injection of this H1N1 Pandemrix vaccine, so that the EMA decided to open or to launch actually a procedure to further evaluate the benefit-risk profile of Pandemrix. Epidemiological studies indeed identified this increased risk of narcolepsy after Pandemrix vaccination, particularly so in younger population. And so in accordance, in agreement with the EMA, GSK has proceeded to multiple evaluation, including mechanistic evaluation that suggested actually more a role from the H1N1 antigen from the Pandemrix vaccine, involved in a relatively complex multifactorial mechanism involving potentially a phenomenon of molecular mimicry between the H1N1 antigen and hypocretin, which is actually a protein, a self-protein involved in the physiopathology of narcolepsy. But so essentially, this was considered to be driven by the antigen. Actually, the most plausible hypothesis, as in agreement with the EMA, was that actually it was driven more driven by the antigen rather than by ASO3 in itself. And based on all these evaluations, the EMA gave a positive opinion on the benefit-risk profile of Pandemrix and decided to close basically the investigation in 2016. I mean, it is important to emphasize the fact that, all this post-marketing data after registration of this, H1N1 ASO3 vaccine were based on about 90 million doses that were administered worldwide, and that really supported solidly the benefit-risk profile of this ASO3 H1N1 vaccines. So, I mean, this was for the safety profile of ASO3-based vaccine. Of course, I mean, the work needs to be done with upcoming SARS-CoV-2 vaccine. This is, I was referring to the experience that was accumulated with pandemic vaccine. Now we have to do the same work with all this, new SARS-CoV-2 protein-based approach. And in that context, I mean, GSK endeavored to manufacture up to 1 billion adjuvant doses in 2021 to potentially cover the pandemic needs. And so this was for basically the rationale of using ASO3. Now let's have a look on early preclinical and clinical data from vaccine collaboration. And here I'm showing you data from NHP experiments that were conducted with the Clover's vaccine candidate, so the trimer-tag-based vaccine candidate, where rhesus macaques were injected with either an ASO3-based vaccine and also another adjuvanted vaccine. So with it is actually the CpG 1018 from Dynavax. So you can see on the left side of this slide antibody responses in terms of pseudovirus neutralizing antibody titers, which gives a sort of proxy of the true neutralizing antibody response. The monkeys were administered twice with the vaccine at a 21 days interval, and you can see on the graph the kinetics of the neutralizing antibody response, both for the ASO3-based vaccine and for the Dynavax-based vaccine, so ASO3 being in red. And you can sort of directly compare that to neutralizing antibodies that were evaluated in from people who actually developed the disease and who were convalescent from the disease. So clearly, the levels of antibodies were reaching or were sort of similar to these neutralizing antibodies observed in this convalescent sera. So on the left you have pseudo-neutralizing antibodies, on the right you have true neutralizing antibodies, and you see the same kind of kinetics. These are, and so, I mean, the objective, of course, of this NHP experiment was also to evaluate the protection of these vaccines against a challenge with the SARS-CoV-2 virus in these monkeys. So you see that you see actually the same line, the red color coding, I would say. So for ASO3, you should look at the red line, and you see that in terms of body weight, there was actually, you know, a better profile for the adjuvant, for both adjuvanted vaccine as compared to the control, which is illustrated in gray on this on panel A. On panel B, you can see that the body temperature tend to be actually higher in the controls compared to the adjuvanted vaccinees group. In the bottom of this slide, you see actually viral replication in these animals who were sacrificed after challenge with the virus. Unfortunately, you know, it is a little bit small to see, but what we could see is that generally viral replication seems to be, you know, less or lower in the respective swabs that were collected either in the throat or from anal swabs, or from, you know, the trachea, or from the nose of these animals. And on the right, you see actually viral replication in the lung tissues, while in those who did not receive the vaccine, there were continued viral replication. In those who received the vaccine, there was no viral replication anymore, which was, you know, reassuring information on the protective potential of this vaccine. So again, it is relatively a crowded slide. I apologize for that, but these are very recent data. These data are not preclinical data anymore. These are, you know, data coming from phase 1, from a phase 1 that was conducted by Medicago. So, you know, this company was developed a protein-based, viral-like particle-based antigen from a plant technology, so the tobacco plant technology. And you should look at the red dots for the ASO3-based vaccine on the upper panel. So on the left, the panel A, you see ELISA IgG antibodies after vaccination. So the same schedule is respected. So it is, I mean, the vaccine was given at day 0 and at day 21. And what we can see is that for whatever the dose of antigen that is used, so either 3.75, 7.5 or 15 microgram, you see that there is induction of ELISA antibodies as after the first dose, so 21 days after the first dose, and it is further boosted after the second dose of vaccination when we look at the data, when we look at the point at day 42. So as after the first dose, we observe a relatively ample antibody response. So on panel B, you see the same trend in terms of pseudovirus neutralizing antibody titers, and it is equally seen in terms of quote-unquote true, you know, virus neutralizing antibody titers. So clearly, the formulation was demonstrated to be well immunogenic in terms of antibodies. And now in terms of T cell responses, or rather cellular response, we have here ELISpot data that actually show, you know, cellular response as a whole, I would say. And so it will basically count, you know, after stimulation with the SARS-CoV-2 antigen, basically the number of cells, you know, expressing interferon gamma, so a Th1 cytokine. And we see that after the first dose, we observe a good interferon gamma response, whatever the dose used in this experiment. On the bottom panel, we also see that a level of response for a Th2 response, so IL4, as after the first dose. So we have a balanced Th1, Th2 response as expected for this kind of adjuvant, so namely ASO3. We have also observed that in the past in pandemic flu programs. Okay, so now treatment approaches. So GSK is collaborating with VIR. VIR is a biotech who is actually, developing new antiviral antibody, approaches. And so GSK is using the VIR's monoclonal antibody platform to basically develop, in collaboration with VIR, monoclonal antibody strategy. The phase 3 of this evaluation is ongoing for the moment. The study is called Comet Eyes, and the results for these studies are expected during the first quarter of 2021. And if we have positive data, there will be, of course, regulatory discussion to make this medicine available to patients as quickly as possible. We are really speaking here of treatment. And then GSK is also developing another antibody-based approach, so namely otilimab. Otilimab is actually tested in other, disease indications, like the treatment of rheumatoid arthritis. But since it works by blocking the effect of GM-CSF, so it is a sort of cytokine, which is found in high levels in patients with COVID-19. GSK is also developing this antibody for helping these people to, resolve their symptoms better or faster. And so the study is actually ongoing with, again, primary endpoint results that should be expected during the next half of 2021. And again, if it is positive, GSK will work with regulators to make the medicine available to patients as quickly as possible. So some take-home messages. Well, I mean, and I will potentially focus again on vaccine development and on what GSK is doing. ASO3 is a proven technology. We have a lot of data from our flu programs, including pandemic and seasonal programs. The aim is really to give access to ASO3 to collaborators. So we are working in collaboration with these partners to develop this vaccine. Clearly, the first data are encouraging. We are, of course, waiting for, the efficacy readout from all this collaboration that will come in the coming months. And indeed, potentially, after, some of the readouts that were already obtained with other, manufacturers who could already show after interim analysis that, their vaccines were highly efficacious. So the field is extremely dynamic. We are living in a very competitive environment, that is for sure. But we believe that there is room for many vaccines. Actually, many vaccines should be used and should be actually distributed worldwide, and coming with potentially different platform technologies with different profile and potentially different, specified indication for different population. So GSK has the endeavor to produce 1 billion of adjuvant dose in 2021, and importantly, the profit of these programs is actually planned to be reinvested in future pandemic preparedness efforts. So it is important that basically we are not stopping our efforts there, but being prepared for any further emergent threat that may arise worldwide in the future. So I will just end up here by saying that I presented you one of the approach for developing a vaccine. This is the one that GSK has taken. There are many actors involved in the field. I think that indeed GSK is between other approaches. At the end of the day, what is really important is that we can provide to the population a safe and effective vaccines, and this need to be put in place as soon as possible using adequate ways of developing it. So thank you. This is where I would like to stop the presentation, and I'm happy to take any question you may have.
Thank you very much. We're just going to mute the mic in this room. I apologise for the echo. We would just have to work through it for a moment. We have several questions, and unfortunately we only have about 4 minutes for questions, but I'll quickly ask you a couple of them. One is quite a simple question, which will be, I'm sure, a one-word answer. Is this a 2-dose or 1-dose vaccine that you're talking about?
Yeah, I mean, generally it is a 2-dose. I mean, these are 2-dose vaccines. I mean, for the collaboration in which we are involved, these are 2-dose vaccines. Even though single dose have been evaluated in some instances, the aim is to go for a 2-dose vaccine. Yeah.
Thank you. Thank you very much for that. Another question has come in over the airwaves. Since SARS-CoV-19 has shown variation, can a number of COVID-19 antigens be incorporated into one vaccine, or is it better to have just one antigen per vaccine?
Well, I mean, I think that there are different approaches to tackle that. I mean, obviously enough, one potentially radical option is indeed to put as many valencies, as many different strains in the same vaccine, and to have a multivalent vaccine to address this potential problem. But you know, given the situation and given the very specific accelerated program in which we are, I mean, we may not have actually, you know, the room for doing that. And this is why maybe, and this needs to be evaluated further. I mean, we cannot say it for the moment, but this is why, you know, using an adjuvant may potentially, you know, address this question, because like we see in pandemic flu vaccine, ASO3 adjuvanted vaccine, these vaccines are able to generate a response, immune response, not only against the vaccine strain, but also against other vaccine strains, not including to the vaccine.
Thank you. And one question, if you could answer it briefly, because we are short of time, but your title is Development for the Developing World also. How are these vaccines to be distributed among populations where obviously there are quite...
That's a very important question. Obviously enough, there have been a lot of discussion and debate, and I'm probably not the best one to answer what will be done or what needs to be done. I'm a clinical researcher, you know, trying to push the development of this vaccine and making them safe and effective. But we are, you know, working with collaborators which are actually funded by organisms like CEPI, for instance, which is coming clearly with a global mission. And GSK is actually totally in line, accompanying this global mission. So it is through this kind of mechanisms that we believe this vaccine can be distributed largely worldwide and not only in several countries.
Thank you so much for that talk. It was really informative. I think you made what's an incredibly complex subject very understandable to us who are not living in that sort of level of biochemistry and immunology. And so I really appreciate the talk you've given. I think it's fascinating the way that you have combined with other companies to come forward with this sort of technology and innovation. I think that can only do us good in the future. And I was fascinated also by your treatment arm that I have to say I was ignorant of. So thank you so much for that informative talk. It's been great.
Okay, thank you. Thank you for inviting, and have a good rest of the meeting then.
Thank you. I think you'll all agree that was absolutely fascinating, and hopefully Professor Luke O'Neill will have had a chance to listen into some of that and can follow on from that really interesting talk. Our next presenter is Prof. Luke O'Neill, who probably needs no introduction to most of you who are based in Ireland anyway. He's a doctor who is well known in the country for his media discussions around COVID. He is a professor of biochemistry at Trinity College Dublin, and he is known for has produced a book which I believe will be on the big book list for Christmas presents for adults and children alike with regard to science this Christmas. He has also won numerous awards and done much research into biochemistry and medicine. And if I go to his CV, I could sit here for half an hour and read out both his publications and awards, which would do us no good whatsoever because we want to hear the man himself. I will say the best award, the two most notable that I came across was an award from the European Federation of Immunology Societies medal back in 2014. And the one that I personally liked was in 2009, he won the Immunology Guru National Institute of Health Award, which I thought sounded quite spectacular. But I will stop now because I know that we would be delighted to hear from Luke O'Neill and hear what he has added to this COVID conference. Thank you so much, Professor Luke O'Neill.
Thanks very much, Anna. I'll just share my screen, I think, now, do I? So bring up the slides, hope you can see them. Great, okay. Thanks very much, Anna. Can you hear me all right?
I can hear you all right, and your slides are up.
Brilliant. Me and poor old Brendan. I want to thank Brendan because we struggled for a good 25 minutes to connect, so I'm very happy. It seemed like Trinity had its own Teams thing and I had to change the Sligo, but we did it. So thanks, Anna. That was good hearing Francois, and I've got a big connection to GSK as well. I'm on their advisory board for the GM-CSF drug, actually, so I know all about that aspect of what GSK have been doing. And of course, I had an important sabbatical in GSK back in 2016. And they have funded stuff in my lab, so I know a lot about what GSK are doing. Great to see them with their fantastic adjuvant. I'm going to give you kind of an overview of my sort of view on COVID in terms of therapeutics mainly. I'll also talk about our vaccines as well. And so my own work, we're working on COVID-19 in my lab. We're mainly in the therapeutic anti-inflammatory end of the business, I guess. Now, as you don't need to introduce it, I suppose, there's the virus. It's worth remembering this is the most startling thing in 100 years, no matter what anybody says. A third of the world's population into quarantine, 1.2 billion children out of school, trillions and trillions wiped off the world economy. So we have to crack it, basically, and science, as we all know, is the way to beat this virus. And since the get-go, I've been confident that we will beat it. I work with guys who work on SARS before, for example. I've got a big interest in the whole vaccine area with adjuvants over the years. So my lab was easy to sort of convert into a COVID lab to some extent. We've got 4 projects running, as I'll explain to you. You probably have done this in the meeting already, Anis. I don't want to go on about it, but this slide makes an important point. It was in Science magazine about a month ago. The big question that we don't know is, will infection protect against reinfection? And that's still an unknown. More than likely, there'll be a range, of course, as with every biological trait. Some will be protected, some won't. Most are in the middle, which means they can get reinfected, but with a milder disease, which is not too bad. I mean, if that happens, the fatality rate is decreased because of that. These are the viruses in the coronavirus family. You get about 2 years protection, possibly with SARS, nearly 3 with MERS. That's based on measuring T cells and antibodies. But the common cold, remember, is only 6 months at most, and that's been proven recently to be the case. So maybe this will be a 6-month protection virus. We don't know. It's still an unknown. Obviously, other viruses, you get lifelong with measles. You get about 6 months with flu. So it varies from virus to virus. And this is a new virus, we still don't fully know. The other big question then that's in the media a lot is it just like the flu? This is a much more dangerous disease than flu. We have to counter that. This is a really good study. O'Driscoll and colleagues, just an Irish person actually, was in UCC. She now leads a group in Cambridge. They've got a very good Nature paper on the infection fatality rate for COVID-19 compared to flu, and you can see it. Look, so if you look at this very simply, much higher, the red, higher, especially past the age of 50. 13, 14-fold higher infection fatality rate compared to seasonal influenza. So therefore, we've got to take it very seriously and not just consider this to be another type of flu. But they're 2 very important points, because if you have reinfection, even if it's mild, you cannot achieve herd immunity naturally, and that suggestion was unacceptable to immunologists. Secondly, it is a serious disease, much worse than flu based on this data. And all these studies combined tell us it's much more severe than seasonal flu. Therefore, we have to come up with ways to combat it. Now, the other malicious part of this virus, the single most pernicious aspect actually, is asymptomatic spread. Whereas with SARS and MERS, it was a deep lung infection that was symptomatic spread. The common cold is up here in the upper airways. That's asymptomatic. This can be either, and that's why it keeps spreading. It may be as high as 50% spread is through people with no symptoms. That means you can't contain it like SARS and MERS. You can contain those because people with symptoms could be isolated in quarantine and stop it spreading. But this one, half the people spreading it have no symptoms. So again, that's a very important point to keep reminding people that it's very hard to contain through selected, lockdown or quarantine rather, based on symptomology. And then, of course, the other very serious part is what we call long COVID. Obviously, this happens with this disease. Other diseases, other infectious diseases are similar. We still don't know enough about this one. Again, an unknown is how common this is. Some studies are showing 1 in 10. Some are showing 1 in 3. It'll be age dependent. It seems over 50 again, you're at but much higher risk of having a longer symptomology, and this can really debilitate people for months on end. So again, it emphasizes how we have to take this as a very serious virus indeed. Now, some of the therapeutic parts, you all know this already, I guess. ACE2 is the receptor. Into the cytosol, RNA is released, RNA virus. You get direct translation. You get assembly of the new viral particle. This presents a number of targets, of course, to go after, including ACE2, where lots of work is going on there. We know you get a strong immune response, of course. You get a good IgG response, IgM. The big question is, will this persist? And this gets back to the reinfection idea. Can you get memory B cells, memory T cells? And again, this will be mixed. Some will have a memory response and will see protection, but others won't, or at least not a strong enough response. So again, an unknown there. The big worry would be this ADE, antibody-dependent enhancement, and that can happen with some infections. That would threaten a vaccine if you got that. That doesn't seem to be the case, thankfully. But again, it's something that we don't know and that we're keeping a very close eye on. Again, T cells come out in their droves, CD4, CD8 response. The virus, though, is very good at knocking off the T cells. And lymphopenia is a key feature with viral load. T cells go down as viral load goes up, and that's a challenge because that means you're now immunodeficient effectively with this virus. Now, remember, vaccines are not the live virus. They won't do this. So when we see sort of worrying things like lymphopenia or not so much a strong memory response, that doesn't concern us when it comes to a vaccine, because they won't have those features, because it's a subunit, it's the RNA, it's not the live virus. Now, here are the options then. We have vaccines, antibody therapies, antiviral drugs, and anti-inflammatories, and that's what I work on, this side of the equation. I've always worked on inflammation for many years now. There are the 4 approaches that are now being taken. In terms of vaccines, we've heard from Francois already, I suspect, several types, whole inactivated, subunit, RNA or DNA, and recombinant vectors, and we all know examples of these. This was a very useful thing that was done about 4 months ago now, I think. It was Barclays Investment Bank who asked the question, what's the story with vaccines? And they were projecting approval of 3 before Christmas and 5 after, and a 6th one way out in 2021. Now, we know Moderna and Pfizer are seeking approval at the moment. We're waiting for the regulatory bodies to adjudicate that. AstraZeneca, again, they've submitted their data. We'll see what happens there. We saw yesterday a slight wrinkle in the AstraZeneca trial when they revealed a mistake, which is a concern, but still that vaccine works as well as our view. And we're bound to get at least 3 approved in the coming weeks, if not before Christmas. And then J&J maybe before Christmas as well, actually. So we're going to see at least 8 vaccines is our projection, approved by Q2 next year. Time will tell if that's true. It depends on the regulatory bodies and various other things, of course it does. But still, there's grounds for the usual cautious optimism in the vaccine timeline. And then the Pfizer-BioNTech vaccine, we know this, I made this for a slide I gave last week. You know, this is showing allegedly 90% efficacy, which is really good. And then the Moderna one is similar, 94.5%. But again, these are press releases. We'd like to see the data. They have submitted their papers, I've heard now, to journals. So we should see the real data pretty soon. One last thing to mention before I do therapeutics. My lab does work on BCG for years. And there's a chance of BCG giving protection. It's called innate immune memory or trained immunity. And one idea is that it causes some kind of epigenetic change in monocytes. Cytokines are made, and then we get a priming. And any viral infection might then, we might see protection. RSV is a famous one. Influenza, will SARS-CoV-2 be the same? There's trials running with BCG to see if you can get this kind of non-specific innate immune barrier to SARS-CoV-2. And again, there's optimism because of the other trials that have been done with RSV and influenza, for example. Now, getting back onto my own work, that's a whistle-stop tour for you there through some of the big issues that we're facing. It's an inflammatory disease, effectively. And we know macrophages and lymphocytes and cytokines are part of this. It isn't that much different to ARDS that you'd be familiar with, or LPS, gram-negative induced sepsis. You see similar features with COVID-19. And in fact, there was a JCI paper comparing cytokine profiles, and they're almost identical with standard ARDS. So there's overlap here from what we know before from respiratory distress during infections. And then because of all that, then we can now speculate on possible approaches. And of course, the anti-cytokine approaches, we've heard about GM-CSF already from Francois. very interesting target. Anti-IL-6 is another one, and there's pluses and minuses in the trial so far. These never worked in sepsis, really. So we need a bit of luck here, and it might be about timing. It may be that this virus will be amenable to sort of anti-inflammatory therapies. We don't know, but still, it's something to watch, and many trials are running. Antivirals, remdesivir is the famous one. Works a little bit, not a great drug. It has a bit like Tamiflu. You know, there are some signals there, but it won't be the answer. Other antivirals are in development, as we know. This was a slide I made a few months ago. Chloroquine's now gone. That didn't work in the trials. And then the antibody-based approaches. There's loads of antibodies in trials, monoclonals, single domain antibodies, convalescent plasma. Again, that's uncertain from recent data. But certainly two have been approved. The Regeneron and Lilly cocktails that are against the spike protein, they're now approved for use in hospitals early in disease. And of course, Trump himself got and it makes sense. They'd mop up the spike protein. They're relatively straightforward to make. They're going to be safe, you know. So again, we wonder, would antibodies be part of the therapeutic approach? And remember, it's becoming less of a serious disease because the death rate's going down. Here's survival rates in May versus June, and at every age there's more survival happening. You know, the fatality rate's gone down, so that's really good. And there's all kinds of reasons for this. It's to do with things like proning, something simple. It's to do with the age profile. It's probably the lower dose of virus going into people because of the masking and the various procedures the things we're doing. You know, that means if you do get infected, the dose of virus is lower, and that means less problems. And that's a part of this decrease in fatality that's happening. So again, this is a trend that's growing, and maybe by the time we get to March, April, May, the fatality rate will go right down, survival again much higher, and that's interesting. What do we do about the vaccination rollout then? You know, and these are discussions that are running at the moment. Dexamethasone, a well-worn anti-inflammatory. I worked on this in my PhD. That showed efficacy in some of the trials, and here we see. Get rid of that's my next meeting coming up there. Get rid of that. Here we see Dex. That was from the New England Journal paper, and you can see here decrease in mortality. And that would be probably because you're protecting against injury from ventilators, for instance, partly is one thing we think. Secondly, an anti-inflammatory effect as well, and it can be useful. So I reckon it's about 20% benefit at the current data, about 20% effect here, which is still something. 1 in 5 people are surviving that wouldn't have, is the idea there. And then lastly, my own stuff, we're working on this molecule, itaconate. Now, this is something that we came across about 3 years ago now. It's an endogenous anti-inflammatory metabolite made by macrophages as an off switch for inflammation. And we got some very nice data. We had a big paper on this in 2018. It came from my work in GSK, to be honest. That's where I first came across it. And of course, because it's so anti-inflammatory, we wondered, would it have use in COVID? And there's the structure of the molecule. And here was some of our early data. This is 2018, our paper came out. This is the model of LPS-induced septic shock. Again, that will create ARDS in mice. And the mice, it's a lethality model. We gave them itaconate, we protected them. So we can protect mice from LPS lethality. And then about maybe 6 months later, after the paper came out, a group in Canada contacted me working on Zika virus. And they said, we'd like to try itaconate in Zika's lethality. And look at this, here's Zika virus in a model causing lethality. They gave them itaconate and the mice were protected. So there was evidence here of protecting against Zika-induced lethality. And that paper had a nice slide in it. Here was the itaconate, look at that on the spray can, being sprayed over Zika. That could be SARS-CoV-2. So we wondered, would itaconate work against SARS-CoV-2? And indeed, we're getting some very interesting data. And here's an example of some of the data we've got. This is an ex vivo model using human airway epithelial cells. You infect them with SARS-CoV-2, and this virus will kill those cells. You get a cytopathic effect, so 20% survive in that model. Give them itaconate and they survive. Look, we're protecting the cells here from cell death in a SARS-CoV-2 human epithelial cell model. And that's a very interesting prospect, actually, because here we have a possible therapeutic. Now, I know it's early and there's many anti-inflammatory approaches being taken, but we think this molecule has legs, basically, because it's got antiviral effects and also anti-inflammatory effects. And that's one piece of data to show you what's going on. We've just recently got in vivo evidence, actually, in hamsters, and it's protecting the lungs in a SARS-CoV-2 hamster model because of its anti-inflammatory effects. It works, we think, by modifying a range of proteins in macrophages, on cysteine, covalent modification, and turning off these inflammatory proteins. NRF2 is one that gets boosted, for example. NLRP3, the inflammasome, that's inhibited. So again, we think this could translate into a therapeutic effect in COVID-19. Now, I'd also say this, that remember, if we crack COVID-19 and hopefully the vaccine will have a huge effect, of course, that's our first hope, because vaccines will be the way to get out of this. Some of the fear begins to go away, of course. Other inflammatory agents are being tested as well. These approaches will be useful in other diseases. That's the beauty of it in a way. We'll go beyond COVID into ARDS, into sepsis, into all kinds of things, or anti-inflammatories more generally. So none of this work is going to be wasted in terms of, you know, final use in different indications, we feel. So that keeps us going as well, because the speed at which data is being generated and the excitement around, you know, all these different approaches is remarkable. So what COVID has done in many ways is it's galvanized the world of immunology and virology and all these areas. It's galvanizing the vaccine people. Now, the effect of those RNA vaccines will be more broad. It will get drug companies more interested in RNA vaccines for all kinds of diseases, no doubt. And then on my side of it, we're getting more insights into pathologies that are linked to inflammation. And these could be infectious-based or indeed other pathologies, who knows? So again, we're learning an awful lot more about the immune system and inflammation through working on COVID-19. And the other analogy, I used to work on HIV back when I first became an immunologist back in the 80s. We did work on HIV. Again, I mean, we never got a vaccine for HIV, but we did learn about T cells. Much of our knowledge about T cell biology, a lot of that came from HIV research, because HIV infects T cells, as you all know. So again, we're getting lots of sort of ultimate spin-outs from all this, as well as the immediate goal, which is to tackle this virus. And I might finish with a couple of general points for you. Where are we going to go next? Well, even though I said there was limited evidence for protection, there is some immunity will build up in the population, and there is evidence for that. Reinfection seems rare, and let's hope that's the case. And so therefore we will begin to see some natural infection building up. That won't be sufficient to create immunity in the population. Remember, no infectious disease created herd immunity, really, let's face it. The only one we eliminated was smallpox, and that was with the vaccine. Polio was close to it. But this will be useful. There will be some immunity. Now, a vaccine, tremendous, will help with this. Even if it's partially effective, it'll still make a big contribution to allowing immunity to build up. And of course, the main reason is it's not the live virus, and it's much more potent. And the RNA, by the way, in the Moderna and Pfizer-BioNTech vaccines, that's a great adjuvant. It's a self-adjuvanting vaccine, because TLR3 and TLR7, which I work on Milo, they're sensing that RNA. So you're going to get two for the price of one. So we're going to see more and more evidence of efficacy, I believe, with the vaccine trials. Therapies are improving. Great hope is there for that. Antibody-based therapies, maybe. They're going to be expensive. But remember, the death rate is going down, and that's a wonderful thing, and that'll help with our discussions and what we do next. And then another point is the antibody therapies will be used for those who can't be vaccinated. Some people can't take vaccines for various reasons. They could be immunodeficient. They could be allergic in various ways. So antibodies give another option for those people. And then the prophylactic bit, the Lilly trial actually running at the moment is in care homes. And they're giving all the people the antibody and then measuring protection against infection. So it can be used as a prophylactic as well. Most importantly, all of this combined means the fear begins to dissipate. Governments can now begin to take risks on things, and we can begin to restore society to the way it was with all of these combined, you see. Without doubt, the vaccine is the main way through this, I think, as we all would agree. But still, all these different things give us great hope that the fear begins to dissipate. And remember, though, we must keep doing the same things that we've been doing. We can't imagine that this progress gets us off the hook. It's vaccines, therapies plus is the great phrase, because it'll take months to roll out the vaccines. We won't be able to get a widespread vaccination program into Ireland. You know, we're talking Q2 next year, if we're lucky in a way. You know, March, April, May maybe is a possibility. So we got to keep doing what we're doing, keep doing what we have to do, keep working together, and we will finally beat COVID-19. Thankfully, it'll be a thing of the past, or at least it'll go endemic and be much less fearful as a disease. So I'll finish there, and thank you very much.
Thank you very much for that interesting and rapid run through of the background to the COVID virus, the various vaccine options and treatments, and your own work. Fascinating and
had to go fast. Had to go. Sorry, I went so fast, but I hope.
No, fast is good. It's good. We appreciate it. More time for questions. We've some questions coming through on the on the web, so I will ask you them. The first question was about interleukin-1. Is there any role for interleukin-1 blockade and sort of?
Absolutely, and we're all over that, of course, like literally like a rash. That's my main focus is IL-1 for years, and NLRP3, the inflammasome. So there was a trial with canakinumab, which is an antibody to IL-1 beta. Novartis ran and it failed, so that was bad, right? Now again, those anti-inflammatory trials are very difficult. They've always failed in sepsis anyway, in ARDS. So I think it was timing. It was given very late, and that's very difficult to achieve a therapeutic effect. But still, it failed, and that's a disappointment. There are 2 big trials running with NLRP3 inhibitors at the moment. Novartis have one, and a company called Olitech, and they're running. I mean, we'll see. NLRP3 will drive IL-1, and there's good evidence for NLRP3. Well, I mean, there's some evidence, I suppose you'd say, for NLRP3 in COVID, because it is a very potent inflammatory pathway. There's evidence that it's in respiratory tissues driving IL-1, IL-18. So I think NLRP3 could be an interesting prospect, actually, and we'll see what those trials tell us.
It sounds like there's potentially good news there, and it's interesting that you have to put it earlier in than we'd anticipated. Yeah. The next question online that we have is to do with, you mentioned that mask wearing meant that people were getting, if they were exposed to COVID via an ineffective mask, it was going to be a lower dose than anticipated, and therefore they possibly were getting less serious COVID infections. So there's 2 questions really about that. Is there any way to actually use PPE in a way of developing immune response? And the other question posed related to, you said this less serious form of the vaccine was bringing into question the whole vaccine program. But if we stop the ideal, I guess, is that we stop wearing masks. Presumably, the minute we stop wearing masks, the risk of a higher viral load once again becomes a problem.
Exactly. Yeah. Well, that was a theory that was published in the New England Journal actually about 3 months ago. That masks were kind of variolating people in a way. You know, and the term variolation, as you may know, Anna, was from smallpox, where they were using like a low dose of smallpox to protect against infection, you know. And then these masks are never perfect, remember. Maybe 10% comes out, say. That may not be a bad thing. That may give rise to this almost like a vaccine in a strange way, you know. Now, that was a hypothesis. We don't know if it's true, but I think it's a reasonable one. It's intriguing, isn't it? That masks might actually have an added benefit, not just to do with stopping spread with high dose, but and low dose spread could be a good thing in a way, you know. I think I can't see us stopping wearing them for the next 6-9 months, really, because again, they are a useful weapon, as we know. The evidence is compelling. There was a dodgy Danish study this week, which was discredited, by the way, as flawed. In fact, the lead author on that paper said, "I think we should still wear masks. Don't read our paper too closely," you know. So I think masks are going to be part of our future for definite. The vaccine issue, yeah, was that the AstraZeneca vaccine? Were you wondering about that? And I don't know, that was the one I mentioned briefly. Yeah, remember they made a mistake in that trial, which they've come clean about, and the regulator didn't really worry about that mistake. So I have to see what happens there. I think the AstraZeneca vaccine will work. It may not be at 90%, though, but we'll see.
That's interesting. Thank you for that. Yeah, I think it's unfortunate we will have to keep wearing masks, but I agree. Yeah. It's going to go forward. I was interested to hear your comment on the BCG and the protective effect of the BCG. How does that work in reality? Obviously, many of us have had the BCG vaccine, but are still at risk of getting COVID. So, what can you expand a little bit upon that?
I can. It's more young people. So, but some countries still use BCG a lot, right? And you get protection with BCG, supposedly, to some extent from TB, of course. And then the idea there would be those young people are now protected and aren't spreading it to older people. So the decreased incidence in the BCG community isn't so much that your BCG 30 years ago is protecting you. It's not so much that. It's more the repeat BCG use lowering incidence in the population. You know what I mean? Now, what that would mean, though, is that you can now use BCG in any of us to re-trigger that. There's no the BCG the effect there won't last more than 15, 20 years, really, you know. So at best, what the idea, if those trials now are giving BCG to older people and seeing if they're protected, you know, and let's just see what happens to see if this kind of innate barrier goes up. So that's the idea there.
That clarifies that, and also puts me in an older group, which is a rare thing, and I appreciate it.
Yeah.
We have another question that's come in here. It says, do you think there's going to be a polypharmacy approach to COVID and treatment?
That's a good question. I haven't thought of that actually. Yeah, to be honest, it could be. Yeah, I mean, I think the big question is going to be what would standard of care be? So when someone is hospitalized, that's the group we're talking about, of course. What will happen? If there was a good antiviral and it was very potent, you might give that first in that situation. We haven't got that yet. Remdesivir doesn't really do that. It's okay, but it's we need to do better. You may give a high dose antibody like old Trump got. Trump is the polypharmacy, isn't he? Because he was given every drug. I think they could fire at him, and they even gave him dexamethasone. That meant he must have been pretty seriously affected because they gave him dex early on, But I think you might get the antibody approach. Whether you would give 2 or 3 immunomodulators, you always risk dampening the immune system too strongly then, So I suspect there won't be a polypharmacy initially, unless it's very serious, like in the Trump situation, then you might throw several things at them. But I suspect there'll be, I suspect antibodies will be useful. They're expensive is the problem, but they're very specific and they work. Those trials are quite impressive. So I suspect antibody use will probably be the standard of care.
Thank you. It's really fascinating. There's a question here with regards to the flu vaccine, and would the immune response to the flu vaccine have any impact on the COVID, subsequent COVID infection?
That's been proposed in the past with it's like BCG in a way, because you're getting like what's called heterologous protection is what the immunologists call that. So in other words, a general immune activation with any vaccine may bring out monocytes and dendritic cells and innate cells, and they're now primed. And then when you have a challenge with another infection, they're primed and they fight the infection. It's called innate immune memory, or training is the name for this. I've done a bit of work on this guy called Mihan Ataya is the real pioneer there. He's in Nijmegen. So yeah, maybe you never know. There could be cross protection. That's an interesting one. Yeah, that's a possibility.
This is a question that wasn't actually addressed in your talk, but has come in. A lot of people have been questioning the long-term effects of the vaccine. And I think as doctors and healthcare workers, it's one of the main reasons that people talk to us and suggest that they won't be willing to take the vaccine. They say it's been tested for the short-term effects, but what about years down the line? Would you have any sort of thoughts or medical knowledge there?
A very important point in our minds all the time, Anna, to be honest, because especially with a new vaccine, I mean, these technologies have not been approved for human use. There is lots of data on RNA vaccines now going back 5 or 6 years. That's very useful to look at anyway, but nothing's been approved. So and they're new, and this is a new virus. So all those worries would be in all our minds, of course. And all we can say at the moment is with previous vaccines, 1 or 2 month safety data does predict long-term safety. In other words, if you're going to see a long-term effect, you're going to see it within a month or two, basically, and that's good. And we've got that's all we have to go on though. So what happens now is the so-called phase 4 is the next thing, of course, and that's when you monitor, 6, 9, 12 months out, and that will be very closely watched just to see if there's any long-term effects. But the EMA and the FDA, I mean, they won't approve these vaccines unless they're confident on that question, obviously, and they'll be looking really closely at the 2-month safety data just to make sure there's nothing there. I would worry, or not worry is too strong a word. I would suggest that if they do see even a tiny safety in 2 months, they won't approve the vaccine for fear of a long-term effect, So they'll be very zealous on that question.
Sorry, we have another question. My apologies. Thank you for that answer. We have another question that's come in again relating back to the BCG discussion. With regards to BCG being an option that's being contemplated here, there's a question asking why the BCG was never approved in the US and Canada, and will that be significant?
Well, it was used, and I'm not sure. I don't know enough about the history of different countries of BCG, but it was used widely, remember, all over the world, and they may have stopped using it. I mean, some countries stopped using BCG because TB went away from those countries, remember, and there was no need to use it. And Ireland is in that category actually. And TB is a disease of poverty. So as soon as countries become slightly affluent, TB begins to go away anyway, and then that decreased the justification for having widespread BCG use, you see. So several countries did stop using it. And now we do see it, and at the moment it's used in India, for instance. They all get the BCG vaccine. Certain African countries, they still get it, and they're the ones that are the lower incidence. That's what gave initially this idea, this correlation thing. There probably isn't much in that, having said that there's other reasons maybe where they're protected, but that gave a hint of something going on, But I think those countries just stopped using BCG because they became affluent, I think, is the main reason. You've gone quiet, Anna. I can't hear you.
I'm off mute. Can you hear me?
I can hear you now. Yeah, go on.
Okay. There's the data, you mentioned the data from India and Africa. Is that data reliable given the lower amount of testing per population and the rural nature of the population? Is it actual that they're having less disease, or is that, do you think, a sort of a phenomenon of the circumstances of their countries?
We don't know. It's a good question. We don't know. But I from my sources tell me that some countries are really good at that. In other words, I think Tanzania is a good example. So we can trust the numbers in some African countries for definite, I would say. Maybe others less. So Yemen isn't reliable, I've heard, for instance. That is, people can correct me on that. But some are more reliable than others, I would say. But it's overall, it's a good question to ask. It does seem to be the case, though, on the ground. If you talk to people, not on the ground. I've got people working in Tanzania, I know. There is a low incidence there of disease, low incidence hospitalization. So something going on. Now, maybe not getting access to the hospital system, I don't know. But I do think overall, those countries are doing better. One big reason is very simple, though, Anna. It's the age profile. We know this is a disease of older age. The average age in those countries is a lot lower. And that's a simple reason why there's less incidence, maybe,
Yes, it's very interesting. It's interesting how it affects different countries in many different ways. And obviously you've got the HIV incidence as well, which also has a challenge.
The other idea, Anna, is the parasitic infections protect, maybe, a bit like the heterologous idea there. And some people are speculating on low-grade parasitemia in these countries are actually giving a protector in some way. That's another factor to consider.
Really interesting. Coming back to Ireland, there's a question about the number of the number of people that would need to be vaccinated. So this tails into two questions. One, what percentage of the population do you think will need to be vaccinated to allow us to reduce PPE sort of use and our current separation? And the other question is, will it be mandatory, do you think, for health workers?
Well, if you read this Sunday's Independent, I've written a whole piece on this. So these are really important questions. And I'm now on the government's vaccine advisory group, actually. So I'm in the middle of, we're having all these discussions. Many countries are having this discussion, of course, and how do you roll it out, how do you convince people, how do you reassure people, all those things, mandatory is bad. We don't want that because that takes away people's civil liberties, and that and it puts people off vaccination. They hide away, and it's very hard to implement. That's the first thing. It can't be mandatory. Is one view. Now again, this is being debated, and there's many ideas and opinions around this. But overall, mandatory is not ill-advised. What you do instead is you say to someone, look, if you want to go to Australia, you need to get a vaccine. And it's your choice. You can choose not to go if you wish. Ticketmaster are saying they won't issue tickets for events unless you can prove you've been vaccinated, so things like that. Because it's not your civil liberty right to go to Australia, is it? That's so those kinds of things may be introduced. We're hoping, Anna, we can get widespread buy-in, really, through consensus. Now, GPs are going to be very important. They'll be the front line on this one because people trust their GPs usually, and if the GP says take the vaccine, that would increase use, So those kinds of things are in our minds. The number is 70%, by the way. That's a pretty good guess, actually. Immunologists are good at this because they can do an overall, it's a bit statistical. If you get 70% coverage, that's enough to get the R naught right down. It's all about getting the R naught down, you see. So if that goes down to 0.1, you're doing great, because that means it takes 100 people to infect one, So you're going to ramp it right down. We think 70% might be the goal that we would aim for.
And just checking the time here, so we've probably got time for one, possibly two more questions. The question that's come in is, could itaconate be useful in other inflammatory processes such as bowel disease or cancer treatment?
Absolutely. We've been working on itaconate for the past 3 years, you see, before COVID, with that in mind. I mean, very much so. We think this could be a global anti-inflammatory process. It's natural. The body makes it, you see. It's made, actually, interestingly, during the resolution phase of inflammation. So we think it could be pro-resolving. And that could have use in IBD, for example, or any inflammatory situation. That's very much on our horizons here, really.
Thank you. I think time-wise, we may have come to the end of our possibilities for questions. So may I thank you for agreeing to come and talk to us, and also for your very interesting talk and responses to our questions.
No problem. Thanks very much. Thanks for all the questions as well, everybody.
Thank you.
The very best.
Thank you.
Cheerio.
We're just moving on to our next speaker, who is Una Parsons, and we're just teeing her up in the other room, so there may be a second or two delay. Una Parsons is head of the School of Engineering and Design in IT, and she's going to talk about the Sligo IT and Sligo University Hospital collaborative response to COVID-19. I know some really interesting work went on. I don't know what aspect Una is going to talk about, but at the outset of the crisis, we were challenged for ventilating machines. We were challenged for reagent to use in our vaccines. And it was through collaboration with the IT that we managed to have access to reagent, but also developed some ventilating apparatus that was useful in increasing our capacity for patients who might present to us with COVID and require urgent ventilation. So it was a really interesting time for speedy, and I think this is what we've heard about in the conference, speedy, innovative action between the IT and the hospital. And I think it's these collaborations that we really want to foster going forward and develop in order to make sure that our research that we're doing in the hospital is linked to the IT and is linked to industry, so that actually what we're doing on the ground can be really focused and really useful for health development in the future. And that's why conferences like this are really vital, so that we can keep developing these responses and just improve our healthcare going forward. And we'll go live to the talk now. Thank you so much. This is Una Parsons and the IT and Sligo University Hospital collaboration.
Good afternoon, ladies and gentlemen. Can you hear me?
I certainly can, Una. Good to hear you.
Great, wonderful. Well, my name is Una Parsons, Head of Faculty of Engineering and Design at IT Sligo. I'm so delighted to be speaking to you at this research conference on COVID-19, challenges, experiences and learning. And I'm going to share with you the journey, the collaborative journey IT Sligo went on with Sligo University Hospital in responding to the COVID-19 crisis. So how did we get started? Back in January, the first cases were in China. In February, the first cases in Ireland. Then in March, the World Health Organization declares a pandemic. And then the whole country went into lockdown. And here in IT Sligo, we closed our doors. On the 16th of March, we only had a couple of hours to get organised and move everybody, staff and students out. 2 days later, Sligo University Hospital made a request. And I remember distinctly getting a phone call from our HR manager, Rod Toner. He had been contacted by Dr. Omar Tujar, consultant anaesthetist and intensivist in the hospital, reaching out to us, could we help and reverse engineer ventilators? And that's how the journey started. The following day, one of my electrical lecturers, Pori Corneen, contacted me, and he'd also been talking to somebody in the hospital, Dr. Anne Dolan, an anesthesiologist. And both of them made similar requests, and that's how our journey started. So I'm going to give you an overview of the variety of things IT Sligo got involved in with the hospital, from reagents to face shields to ventilators and so on. So let me get started. The first big request came for personal protective equipment, and this came via Sligo Chamber of Commerce from Marion Prendergast, Head of Finance in the hospital, asking us, could we supply anything at all that would help them out? They were in a great need. So we put together from our labs, from our workshops, from our offices, masks, forensic overalls, gloves, lab glasses, goggles, and so on and so forth, and delivered them to the hospital. At the same time, we got a request from the General Manager, Grania McCann, to our President, could we help out and make partitions and poster boards? And two of our carpentry and joinery technicians, Peter Gillespie and Colin Hart, were only too delighted to help out. And you see in the photo there, some of the partitions going up in the hospital. The next big ask was, could we help with reagent production? And this came about by a chance encounter by our science technician, John Kavanagh, who happened to be in the farmer's market in our car park here, and bumped into Anne O'Toole, the micro laboratory chief. And he just made inquiries, how are things going, and found out that she was having issues trying to get ingredients to make these reagents, and asked us, could we help? Indeed, we could. We reached out to all our suppliers, and were able to get the ingredients together, and then Anne asked us would we help put together the ingredients, provided us with a recipe, and then our lab technicians got to work. They'd never done anything like this before, and under the guidance of Anne, to ensure we were following all the protocols and quality assurance protocols, they produced the testing materials, and IT Sligo was able to facilitate in our science lab that you see in the photo here, over 1,000 tests for Sligo University Hospital and Letterkenny University Hospital. We were delighted then a couple of days later when Eileen Magner had us broadcast on RT News and present all the great work we were doing to the nation. It was great kudos for us here in the college and our linkage with the hospital. The next big story I wanted to talk to you about was the ventilators. And we all know how important it was to have ventilators. We all became aware of the worldwide shortage. And Sligo University Hospital want to explore with us, just in case the need arose, could we have ventilators ready if they didn't have sufficient further patients? And this is before the peak arose in their hospital. So we looked around and decided what we would do is put together universally available materials. We felt it was very important that whatever we designed and came up with could be made anywhere in the world, including developing countries. So it had to be materials that were easy accessible. So here you see we put Bosch wiper motors. On many cars you can get these, an ampu bag, simple power supplies that are in every PC, very simple wiring, and put them together. And in this next slide, you see the first prototype. And as we were going on this journey, we learned so much, how important the tidal volume was, breaths per minute, inhale, exhale ratios, pressure control, and so on. A huge learning curve for us. And we ended up making these pre-production models, 10 ventilators, and the detail that went in to ensuring that we got the correct controls. You can see all the angles that had to be set to make it easy for somebody, a technician in the hospital, to manage, and so on and so forth. So great team effort. A big shout out to all my colleagues who were involved, in particular design lecturer Dave Roberts up in the top right hand corner. I'd like to thank Dr. Omer, who many times visited David in his shed at the back of his house where he initially put this together, and then linking in with some of our technical and lecturing staff in the college. You see Ross McMurray there in the top left hand corner, a mechatronics technician, and in the bottom left are electrical workshops where an awful lot of our lecturing and technical staff helped out. We were also helped with a group of retired scientists and engineers in Clare who gave us great advice on the control mechanisms that were really important to get right in the ventilator. Publishing a paper on this, and we put in place a website, SOS Ventilator, because we want to open source all the materials and findings that we've learned along the way. So that's all in hand. We were also asked to, if we could design a COVID treatment helmet. And this helmet is used to deliver pressurized air or oxygen to the patient. Again, there was a problem with supply of these worldwide. And so again, we put a team in place to look at how we go about designing these, and use the same reverse engineering mechanism using simple available materials that we got from local suppliers. And you can see silicone seals, neoprene rubber that we had to source. We had to figure out how to heat weld those clips. And in our tool room, our staff CNC produced machines, those in and out ports. We were delighted then, the feedback we got, both Sligo University Hospital and Limerick University tested the helmets and gave us feedback that the pressure was held really better than some of the models they were using. We were ready to produce over 100 units a week. But luckily, their supplies came in and we didn't have to resort to this, but it was a great experience to have to put that in place. The next big project was our face shields. Again, a big issue with sourcing PPE and particularly face shields all around the country and on the front line. So our staff and students got involved. I did an email to all staff saying who wanted to help to get involved in this project. A great number of people volunteered. The initial prototypes and trials were done in people's homes. On the left-hand side there, you can see the living room of one of our postgrad students, Conal Donal. He's got 4 3D printers set up, producing materials. On the right-hand side, Ross, our technician, did some galvanized bands for the design. And on the bottom right-hand side, Paul McNamara from our contract research unit was busy looking at open source materials that we could use for the designs. Our first delivery went to Bailey's Nursing Home in early April. And here we see, I can remember that well, I drove down towards Tubbercurry, stopped in a Connery and was met by our technology gateway manager, Finola Howe, for the pickup. And when she got we delivered over about 200, and when she got them home, she realised that they weren't as clean as we had wanted them to be. So herself and her husband that evening, here you can see them in their kitchen, cleaning them to ensure that the following day, that when they went to the nursing home, that they were to the highest spec we could make them. On the 30th of March, the HSE put a call out that they needed 10,000 of these visors a day. So we decided that we would set up production line in our fab lab. And here you see my colleagues from the PEM Gateway. That's Mark on the left. In the middle, Paul, and on the right, Mel from the Contract Research Unit, setting up and putting all the equipment in place, moving all the computer projects out of the way to set up the Fab Lab. We got great response from contributors. Both Sligo Library and Ballinode College provided us with 3D printers as well as our own 3D printers. We put a call out for materials, for acetates, plastics, anything we could get our hands on to help us make these visors, and we got a fantastic response. We came up with 3 designs to make of the visors: the flat model, the 3D printed model, and the laser cut model. And you can see mapped out here the timeline of the various stages we had to go through to get it approved by the HSE to ensure it was that they were satisfied with them. And over the period of those 7 weeks, we produced 12,000 face shields, which was just fantastic. We had to ensure we had the correct documentation in place, work instructions for the staff and students working in the production lab. We had to agree a disclaimer with the hospital for the materials we were supplying, and we had to ensure we had safety procedures because we were setting up the lab in this facility. So here's a picture of some of our volunteers, and we had a great bunch of people that came in every day to help out. Great atmosphere, feeling that we were doing something incredibly good to help the frontline workers. So we set up in pods, ensure we had social distancing, and ensure we had sanitizers and wearing face masks as we produced the face visors. We ended up putting together production rotas. We got so busy doing it. We had a morning and afternoon shift, and we had staff right across the institute from every different function involved. And one of the highlights of the day was we're delighted O'Hare's, who are here on campus with their cafe, providing us with the sandwiches and buns to keep everyone going, and between shifts that we could enjoy them. Here you see our daily productivity, and over those 7 weeks, we ended up getting up to making 800 a day, which is just just brilliant. We never thought we'd be producing these face shields for so long. We can all recall Aer Lingus with their airplane flying over to China to bring back all the PPE. So we thought fairly soon after that the PPE would reach the Northwest. But the need was still there, so we kept supplying and producing as the need was needed in the Northwest. We had various distribution channels, initially with the HSE and Sligo University Hospital, over 2,000 delivered. We also provided to the ambulance services, Sligo County Council, and a multitude of secondary channels you can see there, from medical centres, GP practices, Autism Ireland, the Guards and Civil Defence. Here you see your own Colin McNabb, who was from the HSE Northwest Logistics team. He came every couple of days. We had set up a reception area for a sort of a distribution pickup area, and took the face shields when they were ready to be picked up. We also got a great response from the Gardaí. Initially, we were delivering to the secondary channels, but when they realised what we were doing, they came on board and delivered to all the various locations all over the region. I'd just like to point out on that photo on the right, Ruth Moran. She was one of our volunteers from the research office, and we couldn't have done it without her. Her enthusiasm and passion to coordinate on the ground with the production lab brought it all together just fantastically. And just to tell a little story, one day she was delivering to the vets in Boyle. She got pulled over by the guards, wanting to know what she was doing. She thought she was being stopped for speeding, but they were just fascinated with the work that was going on. And this is before they came on board to help us out. Stopped her for 20 minutes, just looking at all the work, asked could they have some face shields for themselves, and then started to describe an issue that they were having themselves. Because they have to wear their own Gardaí caps when they were on traffic duty, face shields wouldn't work for them. So they had an issue with, if people coughing or sneezing or very close to them. So this is where this next design came on board. Mark Rooney, one of our lecturers in design, when we learned about the problem, designed these 3D printed clips, and just simply with a acetate visor sheet could be put together and put on the Gardaí cap or put on any baseball cap and used by people who weren't on the front line. Luckily, we didn't have to put them into production, but it was just a great experience just going through that design process with the guards who trialled it for us. We delivered all over, to nursing homes, to carers, to Meals on Wheels, and we were delighted when they sent back these photographs just to show them in operation and see the smiles on their face with having these face shields. We got really nice thank you cards and letters from the guards, from hospitals, from the HSE. And I'd just like to read one of them out to you from John Hayes, from the crisis management team in the HSE to our president, Brendan McCormack. And he said, I wish to formally acknowledge the contribution of your staff, students and executive in assisting our efforts to address the unprecedented challenges of the outbreak. The spirit of collegiality shown by all in IT Sligo in the production of protective equipment and reagents, the work on the ventilator project, the donation of PPE, offers of facilities and the willingness of volunteers to step forward is much appreciated and reflects the strong links between the HSE and IT Sligo. So we were just really delighted to get that feedback. The HSE also visited our production lab on campus. They came in to have a look at our where we made the reagent in the science labs, where we were making the face shields in the fab lab, and also how we were doing the ventilators. We were joined by Marion Prendergast, Head of Finance, and Jonathan Morrissey, Procurement, and also Eamon Valley, Head of National Procurement, dialed in. And they gave us great guidance and feedback, and we really appreciated that. I'd also like to say a big thank you to some other key HSE contacts in the logistics team, led by Sean O'Donnell. It was Amanda Doyle, Barry O'Hagan and Colin McNabb. We couldn't have done it without them, every couple of days linking in with us and giving us advice and showing us where the greatest need was for us to up our production to respond. An important thing for an institute like ours is academic publications. And we were delighted when our postgrads and a number of our academics and staff got together to produce 4 publications. 2 of them have been published already and another 2 are under preparation. You see here the 2 in preparation. One is on the control ventilator using locally available resources and materials, and the second is on rapid prototyping and production of face shields for infection control. And the ones we have already produced for the Safety Science Journal. And this publication is on face masks and respirators in the fight against COVID-19, an overview of the standards and testing methods. And the second publication is on face masks and respirators, a review of current materials, advances and future perspectives. So it's great to have these published in, and this one in the Materials Journal. out there for people to see the work that we did, the research we did, because we found it difficult when we were starting out to find materials and knowledge that was up to date. So it's great to have our material currently out there. Another story I'd like to tell you about is the HSE contacted us in regard to sourcing gowns and also masks. And in regard to the gowns, what they were looking for is if we could convert scrubs into gowns. And they asked us, could we reach out to the contacts we'd initiated. And we linked with St. Angela's, and they were very happy to come on board to help do that, the sewing. They had the machines and so on and so forth. But then soon after that, we realized there wasn't sufficient stocks in the HSE for us to do that. So then they asked us, could we make contact and see if we could get any disposable polythene gowns given. They gave us the product specification. Again, we reached out to our contacts, but delighted that through Carol Brennan in Enterprise Ireland here in the Northwest, she gave us a contact with the RD Coach Trim Company, a company that makes car and coach seat covers in County Louth. And so we asked them, could they produce the gowns? They made some samples. They were passed by the HSE. And in the end, they got a €1 million order to make 650,000 disposable gowns. And they're continuing to do that. And I believe they changed the name of the company as well, set up another company called RD Medical Supplies. And that all came from our contact with the HSE. The second story I wanted to tell you was in regard to masks. And again, the HSE was looking for guidance in ordering masks. These are the FFP1, 2 and 3 masks, because there were so many on the market and not to the correct standard. And here we were delighted to link with our science lecturer, Deirdre Barrow, who teaches on our Masters in Medical Technology and Regulatory Affairs here in the college. And she was able to advise which of the masks that were out there had the standard, the CE standards that needed to be used in a medical environment, and the HSE put through orders to that effect. And the last collaboration project I want to talk about is our students this semester who are studying on our health science programs, and we have 3 health science programs there, and they're either on work placement or doing research or student projects from such a variety of areas, and all linked to COVID-19. And I just heard yesterday some of the projects, and just the last 2 on the right-hand side. Dr. Richelle Burns was telling us that they did a national survey of Irish nurses, and the other one that was done with the public on physical and social distancing, that the students in the spring next semester are producing publications on the results of their survey. So that is just excellent. And now just to share the experiences of what our volunteers went through. We brought together staff and postgraduates, and we were all on a shared mission to help frontline staff. And the feedback we got from everyone that was involved in that process, they were just so delighted to come on board to do that. So I just want to give a big thank you to all our volunteers, 120 of you who stepped up and got involved on this journey. And it was over a 6 to 8 month journey. We're still doing things in that regard. Also to thank our contributors from 40 organisations all over our region and all over Ireland, many of them supplying their goods and services for free. Thank you to all of you. And lastly, I just want to finish off to say how proud I am to have been involved in this process. I originally came to Sligo for a period in the late 1970s as an apprentice toolmaker. There's a picture of me there in Strand Hill. And every day I used to cycle to Sligo RTC at the time from Carton Heights along Lash Lane. But one day I had an accident off my bicycle, and I ended up in Sligo Hospital, and I was taken care of so well from the staff there. So I'm just so proud now, 40 years later, to be part of the team that collaborated with the hospital, helping the frontline staff. And what a year to do this. IT Sligo is 50 years old this year. The college, the Sligo University Hospital is 80 years old. So we've been back and forth linking with each other for over 50 years. But what if over the next 50 years, we collaborated further. There's so many more opportunities we can collaborate together on, from student projects, placements, research and inventions, so much more. I'll leave you with that. Thank you so much.
Thank you, Una. That was really fascinating talk, and I think the IT and Sligo University and yourself can all be proud of a phenomenal effort that's actually made a marked difference in the provision of care to Sligo people in the hospital and in the community. And it's really interesting to see the innovation that went on. Really exciting for the future to see what can happen when different communities get together and work together to try and solve problems locally. Fascinating. We've got some questions that have come in here. The first one would be, how has this experience and innovation been integrated into the academic programme?
Well, particularly I mentioned there the students in our health science programme. They are always looking for projects to work on. So they have got involved in reaching out to the hospital, doing a lot of their projects this year with the hospital linked into COVID-19. We also have, on the design process, our lecturers who teach design are bringing back the skills on, how giving the examples of how we reverse engineered the ventilators, how we reverse engineered the helmets and so on and so forth. So it's always great for lecturers to, we call it research-led lecturing, to be able to give examples from their research into the classroom. It brings it to life. So many of our staff who were involved in this did that indeed.
Yeah, I think that's always phenomenal, isn't it? When you can actually show what you're doing has an applicable aspect, it really makes a difference to the teaching and how much it means to the students. Another question, I gather you had, how were these projects funded? I saw that you had some link with HSE procurement, etc. Was it an HSE funded event, or how did, for example, the visors, how was that project funded?
In regards to the visors, we did an appeal on our social media channels looking for materials. So the main material is the plastic acetates. So we ran out of those quickly in our stocks, and we reached out to the Sligo community, and many boxes were delivered to us from many of the factories in Sligo. And also we did buy some, and our president agreed a small budget for us to work on as well if we needed to dip into. So IT Sligo, we do have a materials budget each year for our student projects, and this year maybe we weren't spending as many on some of those. It was great to be able to give it back to this cause.
That's great. Really interesting to see how different funding came together, and also the community was involved in this as well, because I think the community has been valuable in just the many ways we've responded to COVID. Is there any new research that is going to, from what you've done now, is there at the moment, are there any plans for new research in the IT that has come from the developments and unions that you had during this period?
Well, I can't talk about some of them, but I know some of the lecturers, I know some of the lecturers have recently been contacted by more of the doctors in the hospital. I think some of the staff in the hospital learning how well things have gone. So there's some projects underway as we speak. And I know and between the health science department in the college and our computing department and our engineering departments, there's lots of research underway at the moment. Diabetes diagnostics is one of the opportunities that's being looked at, and there's a number of others that they've told me I can't say anything about at the moment. But I think what I'd like to say today is the door is open. We're always looking for projects for our students to work on, and so if anyone wants to reach out to me or my colleagues in the college, if it's not in engineering and design, in science or business, we're always, we have 8,000 students, over 8,000 students, and they're all, many of them are always looking for projects to work on. So we always like to work on real live projects. So be happy to do that.
I think that's one of the learnings from your talk, is really how valuable to both sides such a union can be. And in terms of CRE as well, the publication of papers afterwards is excellent. And also just for that sharing of knowledge, we can obviously not only have your papers shown what you've done and what research you've carried out, but that means someone else looking at similar projects has a foundation provided by the Sligo IT and the union with the Sligo University Hospital to base their research on. So that's excellent. You mentioned that you made, I thought it was really fascinating that you made some of your technology looking at using locally available resources, so that in communities that didn't have access to high-tech materials, your plans could be utilised. Are you aware of, have the plans been utilised anywhere else, or at this point has it not been shared?
No, we're in the process of finalising two of the publications, and one of them is on the Face Advisor publication and the second one is on the ventilator publication. So we're nearly there on those. We have a website, SOS Ventilator, and we're updating it at the moment. It has the initial experience of our journey on there, but we're we're in the process of updating with all the material of what's been pulled together. So it is, it's available to anyone. And for future pandemics, what we've learned through this process will be highly valuable.
Yes, I think that's absolutely true. Thank you so much. I'm afraid we're out of time for any further questions, but thank you so much for your fascinating talk. Really interesting to see what was done. I just think it's phenomenal. So thank you so much. We're now going to, what we're going to do is we're going to give our medals for local research first, and then we're going to actually have a live presentation from Una Parsons. So I guess that's a win-win. It's good to hear the voice of the person live. So we're going next to John Williams. John Williams has been in the Research and Education Foundation for a long time and has been here since the inception of the conferences, which have been going for 21 years. He's been central to the success and the drive towards the conference, and has been, along with Anita Patel, has been really the driving force behind this COVID conference. So a lot of thanks to him for his input over the years to the Research and Education Foundation and to this for this particular conference this year. John is going to present a medal for the non-consultant doctor research and also for the allied health professional best research piece, and he's going to do this now. So I'll hand over to John Williams and let him take it from here.
As the sun set, 8,000 people lay dead. The year was 1863, the place Gettysburg, Pennsylvania. 2.5 months later, Abraham Lincoln was asked to give a talk, and it has undoubtedly become probably the most famous piece of rhetoric or speech that has ever been given in the history of America, anyway, if not the whole planet. His talk was 272 words long, and it lasted for less than 3 minutes. He was precise, to the point, and meaningful. Now, if you think about it, the chap who spoke before him spoke for 2 hours, and nobody can remember what his name was or what he really spoke about. His name was Everest, just for the record. And this is the challenge that people who have when they're trying to write posters. They're trying to be concise, which takes an awful lot more cerebral effort to write a 272-word speech than it does a 2,000-word speech. Mark Twain once said that I hadn't time to write you a short letter, so I wrote you a long letter. That's the first challenge that people who are trying to write posters, to be able to condense their thoughts. The second one is, and I've come across it all my careers, why should you bother being involved in research? Well, research, in my view, not only adds to the expansion of our medical scientific knowledge, but also encompasses the acquisition of additional skills such as comprehension, observational skills, and communication skills, both written and verbal, which is useful in anybody's future career. And I suppose another problem is people say, well, why would you bother in Sligo? Well, innovation is not nailed down in one place. It doesn't exist in a vacuum. Innovation comes from thousands of small projects run around the world. And that's what we're at here today. So I wish to congratulate all of the people who were involved in the putting up posters. We had about 50 posters this year, which is fairly standard for our conference. It's unfortunate that we can't pass them in the corridor like we used to in other years. However, there is a link in the Research and Education website to these posters, and I suggest you go along there to have a look at the posters. One of the things that people who present posters get from it is they get their peers, their colleagues to make comment, and maybe they think of a different way of approaching it, or a different answer, or an issue that they haven't seen before. Also, not having an actual conference, they don't have the interaction with their peers. So it would be very nice if you have comment to leave it on the posters. We have 2 prizes this year. The first one is for non-consultant medical doctors, and we have a nice medal here, which I will be presenting. At some stage, we obviously can't have the people here today. The first prize in the medical section goes to Maeve Leonard, Safety and Sustainability, a win-win for neuraxial anesthesia. And I'd like to congratulate Maeve Leonard and her team in that poster. The first prize for the other allied health professionals goes to Cathy McGreal, the effectiveness of dialectical behavioural therapy in patients diagnosed with borderline personality disorder in a community mental health service. A bit of a mouthful. But congratulations, Catherine, and your team as well. And as I said, I would suggest that people look up the posters. An awful lot of work goes into these posters, and they're well worth seeing. And I wish to thank Pat Timpson for allowing me to present these medals, because it would be usually the chair of the foundation that presents these medals. And I wish to thank everybody, especially the REF team, and my own research advisory committee. I've been chair of the first research advisory committee for 21 years now. And I'd like to thank the team for all their work over the years, and also to thank Anita for her super work in organising this conference. Thank you very much.
Now we're going to move over to Pat Timpson. Pat Timpson is the chair of the Research and Education Foundation, and he's going to say a few words before the presentation by Una Parsons. Pat, I hand over to you.
Thank you, Anna. I just want to use this opportunity to publicly recognise the major contribution that Dr. John Williams has made to the Research and Education Foundation. John was a founding member in 1991. Yeah, I know he's probably wearing his short trousers at that stage. But as a member of the foundation board, he played a major role in establishing an ethics committee in the hospital. And with respect to resource development, he had a critical role in developing the Library Information Centre and the education facility at level 6. John was also involved in developing the training programme, and particularly core curriculum programme, which I believe led really to the establishment of the annual Research Day, which is very close to John's heart. And the success of the Research Day is thanks largely also to his research committee and the hard work and commitment of that group. John has said he's retiring from the foundation early next year, and on behalf of the board and on my own behalf, because John and I go back a long way, some of it is very hazy, but we go back a long way, and I wish to thank him for his commitment, for your energy, John, and your contagious enthusiasm, which have made a major contribution to the operation and indeed to survival of the foundation. So I promise you that will mark your retirement in a more traditional way when this madness passes. Thanks, John.
Thank you very much, Pat, for that for those few words. We're coming to the end of our conference. We have one more short speaker who will close the conference for us. But just prior to closing the conference, I'd like to say a couple of thanks again. May I once again thank our sponsors who made it possible for this conference to go ahead. I'd like to thank people on the ground who've really put in lots of effort leading up to the conference and actually during the conference. John Williams, who you saw earlier, Pat Timpson, who's been highly involved in all of the preparation. There's been Brian, who's sitting beside me and been filtering some questions towards me and monitoring the chat box, which has been really useful. We have Emma, whose surname I don't know, down the corridor, who's been very helpful to as well. And Brian Hurley, who's been managing the IT and talked through different people when there was IT problems. He's been really essential to us and we thank him for his help. It's also been Chris O'Malley in the background from Sligo IT. And as I talk about people from Sligo IT, I'd like to thank Sligo IT for hosting this conference, which has enabled us to put this conference out on this level, and their IT and expertise has really been essential to us. So thank you for Sligo IT and their coming together with our research foundation to produce this conference. And I think going forward, hopefully the connection between Sligo IT, the hospital and the research foundation can be increased and grown to allow us to do more exciting things together. And perhaps if we bring in some of the industries, that would be another branch that would really add to what's going on in this area. So with no further ado, I think we'll go towards the close of the conference, which I have to say has been phenomenal, thanks to all the speakers and the fascinating information that we've learned. The closing remarks are going to be made by Dr. Brendan McCormack, who is appropriately the president of Sligo IT. So I hand over to Brendan McCormack. Thank you very much.
Thanks, Anna. Just checking that you can hear me. All right, Anna?
We can hear you clearly.
Great. Thank you. Colleagues, distinguished guests, it's been a privilege for us to host the 21st International Multidisciplinary Research Conference here at the Institute of Technology, Sligo. At the conference, we welcomed many hundreds of online attendees keen to learn more about COVID and how to fight it. And most of today's attendees are engaged some way in healthcare at community research educational level, and those also from the healthcare industry and business. So very welcome that multidisciplinary team of audience who wanted to find out what's going on. We've seen an unprecedented level of single-minded approach from all of the players towards the common goal of managing and eliminating COVID-19 in our communities. And I've no doubt but that the research and knowledge shared here today will have far-reaching and effective impact on that goal. Today, we've been honoured to host some of the most influential people in 2020. Dr. Mike Ryan, a native of Sligo and a person who's shown immense leadership throughout this pandemic through his role at the World Health Organization. And his warning interests me at the end of the chat about the danger of amnesia after the pandemic has passed, of forgetting about the impact of the pandemic, is very well made. I think, he's pointing out that we'll get through this, but keep watch. Professor O'Neill of TCD shared his knowledge of immunology, his passion for science, and his incredible ability to communicate and engage audiences, which have been a real lift for this country to help us get through the pandemic. The fact that we have somebody so knowledgeable and able to explain to us what's going on, particularly the layperson, has been a great help. He is a most worthy recipient of the Science Communicator of the Year Award this year, so well acknowledged for him, or deserved. I'd also like to thank Francis Roman from the clinical development team of GSK Vaccines for the insights from the industry side. And finally, by no means least, I want to thank the contributors of the many local researchers who presented here today, and well done to the medal winners. I'd like to just say a few comments from the local perspective. For 50 years, we've been close neighbours with our colleagues in Sligo University Hospital. The very first formal MOU that the Institute signed with an external agency was with the hospital, around the same time that this international conference first started. In fact, our colleagues John Bartlett and Pat Timpson, who's the chair of the Research and Education Foundation, drafted the original agreement. We've always enjoyed extremely good relationships and have shared and worked collaboratively on many research projects Examples of our research includes measuring cutting sharpness of blades, monitoring bowel sounds, modelling of acoustic diagnostic arrays, stroke rehabilitation, Alzheimer's respite, exercise for diabetes and dementia, among others. And individual staff have supported various other projects in both directions on a day-to-day actionable basis, including lending equipment, research analysis, hosting staff and students for periods of time. We also work with the hospital personnel to provide regular exercise and monitoring of previous patients of the hospital who need to keep up their exercise regime. I can assure you today, this relationship between IT Sligo and Sligo University Hospital and our colleagues in NUIG will strengthen all the more once we become a TU, Technological University, next year. As a TU, we'll increase our capacity to attract more funding for research, which in turn will lead to more multidisciplinary clinical-based research and an opportunity for the TU and NUIG, the hospital, to work together, including making joint awards, joint supervision of researchers, and so on. So the TU will greatly widen the pool of academics and the expertise of academics available for this collaboration. And with the enhanced mission of the TU focused on research, innovation, engagement, we should bring many more opportunities for collaboration. And I think it's important to kind of look forward to that opportunity. This year, when the virus reached Europe, horrifying news filtered from northern Italy as we braced ourselves for an event none of us had witnessed before. And as we planned to close our campus last March, we looked up to our frontline neighbours at Sligo University Hospital, and with some feeling of inadequacy and much admiration for their work, we asked if we could help in any way. And you've heard about this work just recently, a moment ago from Una. Just to add to what we got from this as an institute, we learned so much about how to manage volunteers, people from different backgrounds, to source materials and to manufacture scientific and engineering products to a high standard suitable for clinical use. And we'll be using this learning again in other areas. So I think back to Mike Ryan's approach, there is a future here. There's learnings from all this experience that can be applied in other arenas. I think we've all learned this year that medical and scientific advancement can be achieved at breakneck speed if we work collaboratively and share knowledge openly. So our institute is ready to collaborate and assist Sligo University Hospital in any way it can on any such endeavours over the coming years, just to again make that point. Finally, I'd like to thank the organising committee for hosting the 21st annual Multidisciplinary Research Conference at IT Sligo. A particular thanks to Anna Clemenson for her superb chairing of the conference. Anna, you did so well today to keep us engaged. A long day, all the switching over between talks, you kept us going, and you asked very interesting and inquiring and engaging questions of the various speakers and drew them out. So well done on that, Anna. Thanks also to Brendan Hurley and the team behind the scenes for managing the online presentations and recording. And thank you all. I hope you got a lot out of today, and next year I hope we can all meet in person. All the best. Have a great evening.